3.5 विजय लक्ष्मी मैम की 350 इंटरनेट। भेजा हुआ वो ऑर्बिटिंग मैम को भेजा हुआ। प्रिंट मैं नहीं मतलब मैं नहीं निकालता हूँ तो।
नहीं मैं बोल रहा हूँ प्रिंट निकाल दे मैडम।
अब कहाँ से निकालेंगे?
बाहर वो जो बैठे हुए
चंगू मुंगू
जंग जो ये निकाल रहे प्रिंट
पूछ लेते। ये मैंने आपको वो भी एक बार कौशिकी ये भी पढ़ लो, मैंने आपको भेजा है, जस्ट एक बार पढ़ लो उसके बाद में। नहीं वो नहीं एक और भेजा।
Good morning, everyone. A very warm welcome to all the respected doctors, faculty members, delegates, and guests sitting right here in the room with us. I am Kaushiki Sharma, your host for the day. It gives us immense pleasure to welcome you all to ECHO Jabalpur 2026, an initiative of Golden Heart Hospital conducted under the banner of the Heart Research Association Society. Today's conference has been designed to combine strong fundamentals, real life cases discussion, and hands on learning sessions. As we start with our day, setting the tone of the day, with our first session of the day, starting with fundamentals of echocardiography, who will be led by Dr. I.B. Vijay Lakshmi ma'am, who is the first Indian woman cardiologist, who herself doesn't need any introduction. I request Dr. Kaveri ma'am as a moderator to introduce her.
Good morning, one and all, and I welcome all the delegates from different places and from Jabalpur over here, and I welcome Dr. I.B. Vijayalakshmi Madam to be here. We are today really witnessing the role model for the cardiologist today, and this is our really a wonderful day because we are sitting with two amenities of this field to whom we read, whose books we read, whom we follow, whose papers we follow. And today she is with us and ready to give us their golden words. So I request who all are here, please have your plates and get seated so that we can witness the program. First, I would like to ask Dr. Pushpraj Patel, who is having this thought that we should do something in echocardiography, which is the basic need of any physician to serve their patients. So I request Dr. Pushpraj Patel to welcome Dr. I.B. Vijayalakshmi Madam and Dr. Prabhavati Bhatt Madam. Both are from Jayadeva Institute, and Madam Vijayalakshmi is ex-Professor Emeritus, and Dr. Padmavati Madam presently the HOD and Professor of Jayadeva Institute, Bangalore. And I would like to tell you that both have taken really big pain to come over to Jabalpur because there is no direct flights for Jabalpur from Bangalore. So I welcome both of you. And a very short introduction, though it is not, I feel we are doing justice, but I would like to introduce our course director of the day. Dr. I.B. Vishalakshmi Madam. She is a renowned echocardiography expert and academician of this country. She is a former professor and head of department of Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bengaluru, and is a leading name in the field of pediatric cardiology and echocardiography in India. She is the course director of today's event. Madam has been working in the field of echocardiography more than 40 years, and she has many papers, many courses under her guidance. She has worked I'm little sorry, just my yes, ma'am. Yeah. She is the first lady cardiologist and first one to start the pediatric cardiology department in Karnataka as a professor and HOD of pediatric cardiology. Because see, pediatric cardiology is one of the toughest branch. We work on normal people, and this is the branch where we are working on the small kids. So we are just working from the baby who are coming with us with some heart disease, and it is really one of the toughest thing because the anatomy and physiology is entirely different from a normal adult person's. So this is one of the basic thing from where you are actually giving life to a person. She has worked in Jayadeva Institute of Cardiovascular Sciences and Research, Bengaluru, and has been gold medalist in her MD career, brilliant academician, and non-academic career also. She has bagged around 40 gold medals and 3 silver medals. That's the proof that 3 silvers were also supposed to be the gold one. She has done her pioneering work mostly in acute rheumatic fever and given Vijaya's eco criteria pioneer in the amplitizer device closure. She has delivered 32 prestigious orations. She has been authored step by step to echo in congenital heart diseases, for which it was written by Dr. Naveen C. Nanda and edited 3 textbooks. Acute rheumatic fever and rheumatic heart disease, a comprehensive approach of congenital heart disease, for which her books has been reviewed and written by Dr. Crystal R. Butchinson of Mayo Clinic. And this is one of the prestigious thing because we follow Mayo Clinic, and Mayo Clinic is taking reference for our India. It has been published in European Heart Journal. Dr. Mullins has written forward to cardiac catheterization imaging from pediatric to geriatrics, which was edited by her. So you can see that whatever work we follow, mostly we follow US, UK, and some of kind of Indians. But you can see the West is following us because we have this much gold medalist lady with us who is giving birth to the different kind of echocardiology which we need to learn today. There are a lot of experiments, lot of work, lot of research is going on in echocardiography. We should not think that it is very simple. It is one of the tests which we can do perfectly to help our patients. So welcome Dr. I.B. Vijayalakshmi Madam.
Thank you. Thank you so
Big
much.
round of applause, please.
Thank you. Thank you. Keep it. Yeah, thank you so much. Suprabhat and Shubhoday to everyone. It's a pleasure to be here. Madam, we didn't take trouble to come here. With pleasure, we have come here. So it has been wonderful to be here in Jabalpur. Though it's the first time, the aerial view itself was so beautiful that I loved Jabalpur, and thank you very much for inviting us. So today I'm going to talk about the fundamentals of echocardiography, the basics. This, whenever the base, that is the foundation is strong, your pillars and all your whatever intervention you do will be better. So the technology of cardiac imaging has grown by leaps and bounds and has become an essential part of diagnosis of any heart disease. Anything, right from congenital to the geriatrics, the heart functioning, everything can be detected by echo. So much so that it has almost threatened the supremacy of the clinicians. There was a time when our professors used to make the diagnosis and say, "This is my diagnosis," and they used to shout at the top of the voice. Now nobody says that with confidence because the next echocardiography will prove them wrong. And that's the reason people, they are replacing, but they are not replaceable. Clinical examination on top of that echocardiography, it is like icing the cake. So basic clinical examination is still important. And though we used to say catheterization is the gold standard, today echo has almost replaced this. So one of the most wondrous features of innate nature is surely the most perfect harmony existing between the structure and the function. That's what John Hunter said. The heart is the perfect example of harmony. Whatever the structure is there and the function, they go hand in hand. And only when there is any defect, then there will be problem. So this is the inverted image that we pediatric cardiologists use because it is exactly like how the surgeon sees in the operation table. But since most of you are adult, I'll keep everything in the regular echo features. So these are the basic standard views. That is, this is the epigastric view. We start every examination with the epigastric view, and then we go to the apical view, and then we go to the parasternal long axis view, and then parasternal short axis view. Then just above that we go to the ductal view and then go to the suprasternal view. This is how systematically you start with the epigastric or the subcostal region and then go to the notch so that nothing is missed in the diagnosis. But in dextrocardia, whenever we are doubting mesocardia or dextrocardia, we come to the right side, exactly opposite of what we have, the apical, and instead of parasternal long axis, we have the right parasternal. And sometimes the right parasternal view is also used to made out the aneurysm of the ascending aorta and other things. So it is not only dextrocardia, in the aortic lesions also can be made out. So this is how, we look into the thing. So these are the probes where you keep to see the dextrocardia. And the segmental approach is very, very, very important because unless you go step by step, you'll be missing lots of connections. And that's how, the segmental approach is very important for your diagnosis to be robust. Otherwise, the whole thing will collapse. And hence, I will show you how you have to go systematically. So venosegmental segment, that is includes both the systemic veins and the pulmonary veins and the coronary sinus. So all together it's a segment. So in that segment we look at the SVC, IVC and also the pulmonary veins and also whether the coronary sinus is draining well or not. And when we come to the great veins, the superior vena cava, left persistent LSVC, that also should be looked for because sometimes that can drain into LA causing the cyanosis. Then coronary sinus, then we have 5 major pulmonary veins. Everybody thinks 4, but it is 5 because we have 5 lobes in the lung, so we have 5 pulmonary veins. But then when we do the echo, we see the 4 ones. So the veno arterial connection are also to be seen, and arterial segment, whether it includes the RA, LA, and also whether there is an intraatrial septum, appendages, all have to be examined. And we have to distinguish morphologically which one is the right atrium, which one is the left atrium. And unless we do that, we miss. So when we start with the subcostal view, the first thing that you look for is the aorta and the inferior vena cava. You can see here that the red color one is the aorta and the blue one is the IVC. Now, how do you confirm them? Put the Doppler and then see there is a triphasic flow in the IVC, there is a monophasic in the aorta. The peak pressure you can make out. And sometimes what happens is when there is a situs inversus, aorta comes to the right and the IVC goes to the left. So that gives an idea that there is a situs inversus. Sometimes there is a situs ambiguous. You are not able to make out. And then when you are not able to make out, you have to go for the CT or the cardiac MRI to make out whether the situs solitus is there or not. Now when we come to the venous connections to the right atrium, it is very important that the IVC has to be visualized in the subcostal and where it is draining. In the total anomalous systemic venous connection, the IVC will be draining into the LA. So we have to see that. And SVC in the transthoracic study, it is very important to visualize in the bicaval view. In the bicaval view, you can see that there is the IVC and the SVC both come in the same, and that is called as the bicaval view, and that is the 90 degrees. So in the subcostal abdominal view, the images are very important. Here you can see the hepatic veins and also the IVC and the part of the right atrium. And what you see is if you just tilt the probe, Prabha will show you as we are doing the cases, the whole intraatrial septum is beautifully seen. And this is very important. The whole length of intraatrial septum measurement is very important, especially when we are putting a large device and the size of the device has to fit there. And this is the place where you get the whole length of the intraatrial septum, and that is very important. And what is more important is if you find the spontaneous sec, that is the spontaneous echo contrast, that means there is a stasis in the IVC flow, and here you can see that hepatic veins are so much dilated. So dilated inferior vena cava, it can happen when the pericardial effusion is there or tamponade is there. We are going to discuss that part later on, and how the IVC is dilated. When there is a constrictive pericarditis, restrictive cardiomyopathy, right-sided heart, that is RV dysfunction is there, or pulmonary hypertension, or there is a tumor obstructing the IVC flow, all these conditions, there will be dilatation of the inferior vena cava. And if you find sec in the IVC, it indicates that there is an impaired flow or the stasis, and or there is a membrane in there. So here you can see that there is a tumor, and this is the pericardial effusion. So the tumors in the pericardium are extremely rare, and they are very aggressive and fatal, and this is one of that is the endothelioma. So this is how you can diagnose the malignancies also, and you can see that this is how the tumor is seen, that is the pericardial effusion and the non-compaction, and you can also find out whether there is a pleural effusion. You can see that this is the pleural effusion and this is the IVC, and that is the eustachian valve and then draining into that. So the IVC is not collapsible, it is dilated, indicating that there is something wrong there. And here again you can see that this is the IVC, the hepatic portion, there is turbulence inside. If there is a turbulence, either there is a membrane or it is an infradiaphragmatic total anomalous pulmonary venous connection, what we call as a TAPVC. When there is obstruction and then it is entering into the hepatic portion of the IVC. So that's how, when we put the Doppler, you can see that the continuous wave Doppler is seen and indicating that it is an obstructed infradiaphragmatic TAPVC. So remember, in subcostal view, first you see the IVC, SVC, and then you see the other portion and IVC. And here you can see that when you tilt a bit, this is how you get all the 4 chambers, the LV, LA, RA, and the RV. And the whole septum you see, both interventricular septum and the interatrial septum. So that is the cut section, and this is how echo. It is exactly mirror image, and it is how you see all the structures in the subcostal. Why the subcostal is important is when they are obese, you can go for the subcostal, especially in small children when they are sick and all the leads are put and the chest is not free. In the subcostal view itself, we can see everything and make the diagnosis. And that's how the subcostal view is very important. Then we go to the parasternal long axis view. In the parasternal long axis view, what you have to see is you see the LA like this, and the left ventricle, interventricular septum, and you can see that the RVOT is here and the aorta. And this is the view where you are going to see the long axis of the aorta, aortic valve, left atrium, and the LVOT. Suppose there is any obstruction in the left ventricular outflow tract, this is the best view to find out. And that's how we know parasternal long axis is very important. In the parasternal long axis view, you can literally see whether there is aneurysm or dilatation or annular dilatation. The cusp, the annulus of the aorta, all can be measured there. And apart from that, if there is a LA dilatation, normally aorta and LA are of the equal size. When the LA is bigger than the aorta, that means there is an obstruction to the mitral valve, and that's how, or there is a regurgitation, that's how the left atrium is dilated. And if there is hypertrophy, that also can be measured. And if you put a cursor and take the M mode, you can measure the RV, interventricular septum, and also the left ventricle. And here you can see that. Can anyone tell what you notice here? Anybody? Anybody can try. What has happened to the aorta? There is something ballooning. This is the, like how we have the mitral myxomatous valve, this is the myxomatic aortic valve with the prolapse. And whenever this prolapse is occurring, you can see the aortic regurgitation because the non-comption. And in this parasternal long axis, I told you, you can see the dilatation of the aorta, you can measure the annulus, and also if there is a supra-aortic narrowing, what you call is as a supra-aortic stenosis, the Williams syndrome also can be made out. So, aorta, LA, LV, RV, septum, everything can be seen in this view, and then you can make the diagnosis. And this view is also important. Here you can see that this is the histopathology. From the right ventricle, aorta is arising. From the left ventricle, pulmonary arteries are arising. Always arching vessel is the aorta, branching vessel is the pulmonary artery. And here you can see that aorta is coming from the RV, pulmonary artery coming from this. This is the transposition of the great arteries. So this transposition can be made out even in the fetal echocardiography. Then somebody said that they are doing the fetal echo, and this is very important because once the duct starts closing, the patient deteriorates. And if you do not make the diagnosis in time, you lose the patient, and that's how it is very important to see the parasternal long axis. So here you can see that in the parasternal long axis, the interventricular septum is so thick, and then this is the posterior wall. So when the interventricular septum is 1.5 times more than the posterior wall, this is the hypertrophic cardiomyopathy. Then we have to look for whether there is a gradient. And apart from that, what you have to do is take an M mode. And here in the M mode, you can see that there is a SAM. So you can see that the SAM is occurring, the whole anterior mitral leaflet is touching the septum. and the SAM occurring indicate that the LVOT obstruction is there. And then in the aorta, when you cut the cursor, you can see that there is a premature closure of the aortic valve. Normally you have a rectangular box, and here you can see that the leaflet is fluttering and there is a premature closure. So that is a classical sign of the obstructive, hypertrophic obstructive cardiomyopathy. And apart from that, the hepatic veins are directly draining. If they are directly draining, that indicates that the inferior vena cava is obstructed. So whenever the inferior vena cava is obstructed, that time we can see the hepatic veins directly draining into the RA. And apart from that, sometimes we have the azygous, I'll leave that. And then in the subcostal view, the interatrial septum can be seen. And here what you notice is like a flap, two flaps are seen. And that happens when there is a foramen oval is dilated. So when the right atrium is dilated, the septum is moved, and that's how the flap opens, and that is the patent foramen oval. So this is how we can see. And in the inverted image, we can see the levocardia and the dextrocardia and the mesocardia. These are important for the pediatric group. And this is the apical four-chamber view, and exactly how the cut section is showing. You can see that that is the left ventricle, right atrium, left atrium. That gets the pulmonary veins, and the RA gets the IVC and the superior vena cava. And this is a apical five-chamber view. You just tilt it, you get the five-chamber. Apart from the LV, RV, LA, RA, you get the aorta, and that is the apical five-chamber. Apical five-chamber is extremely important in the congenital heart disease, and especially if there is a subaortic membrane or the VST, all that can be made out in the apical. And also you can see if there is a supra-aortic stenosis. And this, it appears like a two-chamber view, but actually it is the apical four-chamber itself. And why it is looking like two-chamber is RA, RV are dilated, and this is the giant right atrium. The giant right atrium occurs when there is a severe tricuspid regurgitation, and that time you can have the PFO also. You can see that there is a torrential tricuspid regurgitation, and this is the triology of Fallot. There is a pulmonary stenosis and there is a TR, and that is the triology of Fallot, not the tetralogy. And then this is the inverted image. We look, and in this, you can see that there is a large atrial septal defect. To confirm, you have to put the color Doppler to see that there is a atrial septal defect. And here you can see that always the tricuspid leaflet is attached more apically compared to the mitral. And here you can see that carefully. This is the tricuspid leaflet much below the mitral valve. So what has happened is morphological LV has come here and RV has gone there. This is the transposition, that is the corrected transposition of the great vessels. That means only the ventricles are inverted. Earlier I showed you the great arteries are inverted. Here the ventricles are inverted. This happens in the corrected transposition of great arteries. And here always you must do the echo with the ECG gating, because they can have the bradycardia or tachycardia in this CTGV, as they have the accessory AV node, and hence always ECG should be connected. And in this you can see that there is a huge right atrium with the tricuspid regurgitation, and the septal leaflet is attached or the tether to the interventricular septum, and this is the Epstein's anomaly. And the RV, morphological RV or the functioning RV is very small, and this is the atrialized RV, and this is the atria. This is the whole atrialized RA is so big, and this is the Epstein's anomaly. And in fact, the Epstein's anomaly, you can detect it even in the fetal echocardiography. And here, something is wrong. What is wrong? Can anyone tell? This is the apical four-chamber view, and there is something abnormal seen in the left atrium and the right atrium. Can anyone tell? Anyone? Anyone? Louder? Huh? No, I can't hear. Somebody give the mic to them and. Okay. See, I was also surprised whether the pulmonary veins or what are they draining. And then you can see that, in fact, this is the aortoventricular tunnel. From the aorta, the tunnel is coming and then draining into the RV. So, what do you see in this? This is again apical 4-chamber view. There is a VST. What do you see here? The tricuspid valve is atretic. It's a thick one. And what you see here? This is the Chiari network and that is the atrial septal defect. So, this is the tricuspid atresia with the VST and with the Chiari network and the septal aneurysm. Now, what do you see here? This is the apical 5-chamber view. What do you notice here? This is what I showed you. This is the tunnel coming from the aorta. See, you can have the double aortic arch, you can have the truncus arteriosus, you can have the tunnel coming from that. All that can be made out in this view. And here you can see that this is the tetralogy of Fallot, that is a the overriding of the aorta is seen with the large restrictive VST in the apical 5-chamber view. In the same apical 5-chamber view, you are seeing the supra-aortic stenosis. So, apical 5-chamber view, these are the conditions where you can detect all that. So, this aortic tunnel which was going across and draining into the RV. So, that's how you can see. Now, coming to the apical 2-chamber view, here this we are focusing on the left ventricle, left atrium and also the mitral valve, and this is how you can see the chordae tendineae and the any mitral valve prolapse or any mitral regurgitation, all that can be studied. Anything to do with the mitral apparatus can be studied very well in the apical 2-chamber view. Now we move on to the parasternal short axis view. This is at the base. I showed you parasternal short axis view, and that time what happens is the aorta short axis is seen. You can see 3 cusps separately. This is the RVOT, that is the pulmonary valve, then the main pulmonary artery and the left atrium. And if you tilt it, you can also see in this short axis, you can see the aorta and its leaflets, whether the bicuspid or unicuspid it can be made out, left atrium, IAS and RVOT, pulmonary valves can be seen, and also the main pulmonary artery and its branches and the coronary artery. This is very important because if there is any coronary anomaly, you can make out. You see carefully here, what you see the thin line here, the 2 parallel lines is the right coronary artery and that is the left coronary artery. See, this is the left coronary artery, right coronary artery, that is the pulmonary valve, and this is the main pulmonary artery, RPA and the left pulmonary artery. All these things can be made out in the short axis. It is like a cup and saucer. Aorta looks like a cup and the pulmonary artery looks like a saucer. And then here you can see that there is something turbulence in the pulmonary artery. It is coming from the aorta. And this is the AP window which I have closed with the device, and once the device is put and the color is put, this color turbulence is gone. So, this is the AP window also can be made out, and the PDA also the best seen here. And I told you whether it is a bicuspid, unicuspid, tricuspid, all can be made out, and here you can see that this is the bicuspid aortic valve. The most common congenital anomaly that you see in adult is the bicuspid valve, and that can get calcified, it can become stenotic, and later on the patient may require the transcatheter valve replacement, and that's how you should be able to see the bicuspid aortic valve. And then in the short axis, when there is a transposition, in the long axis I showed you when the transposition of great arteries occurs. In the short axis, you see them side by side. So, instead of aorta here, it has gone there, pulmonary arteries come here. So you see like a two circles, and that is called as the owl's eye. Like how owl has got two circular eyes, in the same way you see the two circles, and that is the transposed great arteries. So when they are malposed, what happens is aorta comes proximal and the pulmonary artery goes posteriorly. So these are the malposed. So either it can be transposed or malposed, or this is the normal. This is the cup and the saucer. Aorta is there, pulmonary artery, cup and the saucer is the normal, side by side is the transposed, anteroposterior is the malposed. So this is how you can see the great arteries also. And sometimes when you carefully look for, when somebody has come with the atypical chest pain, you can see a flap in the, thin flap is seen here, and that flap, indicate that there is a aortic dissection. So aortic dissection and rupture of sinus of Valsalva or aneurysm of the sinus of Valsalva can be made out in the short axis. You can see that all this is what mushrooming is seen is the aneurysm, and when it ruptures, you can see that where it has ruptured also can be made out in the short axis. So this is how we see. And apart from that, those who are doing the echo in the pediatric, this is the most important one. This is called as the ductal view. It is in the first intercostal space above the parasternal short axis and below the subcostal view. And here you can see that this is how the PDA is seen, and in the ductal view itself we decide what size of the device has to be put in this patient, and then depending on the length and the size we decide. So here you can see that this is the PDA, this is the LPA, and that is the device. Once the device is put properly, there is no turbulence and the PDA is totally closed. So this is how we know we can do even in the newborn babies, premature babies, that can be done because of that. Then we move on to the parasternal short axis view at the mitral level. Why this is important is, in a rheumatic valvular disease, you can see the beaded appearance. Can you see that? They are all looking like the beaded appearance, and that is the classical feature of rheumatic carditis, and the mitral valve commissures can be made out. Whether the patient is fit for the mitral valvotomy or not can be made out. And what is important is, if you go down, you can see at the papillary muscle, always there are two papillary muscles in the short axis, and the intraatrial septum acts as a part of the LV. But when there is a suprasystemic PA pressure, then the RV is dilated and this intraventricular septum is pushed, and instead of circular it becomes D-shaped. This becomes straight and then it becomes like a D. That indirectly tells that it is a severe pulmonary hypertension and the RV is dilated. So this is how you can make out. And apart from that, instead of two papillary muscles, if you see only one, then we think of the parachute mitral or the congenital mitral stenosis. So this is how we can see. Then we move on to the suprasternal view. In the suprasternal view, you see the ascending aorta, arch of the aorta, and then the cephalic veins, the RPA and LA. This is how you can see. If there is a coarctation, we will see at this level there will be turbulence and then the obstruction. So this is how in the suprasternal view you look for the brachiocephalic vessel, descending aorta. Now you can see here clearly that the arch is dilated. Whether it is a hypoplastic arch also can be seen here, and there is an obstruction. And this aorta, and many a times I tell, feel the pulse of the lower limb, you'll never miss the coarctation. Many echocardiographers, they miss the coarctation because the suprasternal view is not seen. And here you can see that almost 98 gradient is there, and that is a severe coarctation of aorta. And apart from that, in the ductal view and the suprasternal view, vertical duct can be made out. This is the vertical duct. The the regular duct is at the descending aorta. This is from the arch it is coming. The third part of the arch it is coming. The vertical duct also can be made out in this view, and this is how it is very important. When we come to the spectral Doppler, Doppler was a person, that's why you have to write with the capital D, not the small d, and Doppler is the name, and that when we are doing the live cases, will show you how continuous murmurs are, the Doppler is seen, how the Doppler study is very important. And here you can see that there is a pulmonary regurgitation as well as the pulmonary stenosis. In some cases of tetralogy of Fallot, absent pulmonary valve can lead to the PSPR. And this is the pulmonary atresia, and that is too much. I will not go into the DORV. And this is the crab view. Crab view is very rarely people do it, and you can see that this looks like a crab. And that is because the pulmonary veins are draining, and this is the common chamber. This happens in the suprasternal TAPVC. That is, no, not suprasternal, supracardiac TAPVC. And what you say, figure of 8 is seen not only in the X-ray, the echo also. This is the vertical vein, horizontal vein, and that is the joining of the junction of the SVC and RA and this. So this is how figure of 8 is seen, and this is the crab view to see whether the pulmonary veins are draining properly or not, and this is important in the congenital heart disease. So the Doppler effect you all know, and the color Doppler is extremely important to see the multiple VSTs, the mid-muscular VSTs, the non-compaction, and all these things can be made out with the Doppler. And the pulse wave Doppler, as we are doing the cases, will show you how it is important. The color Doppler, spectral Doppler, and how severity, all that, then Nyquist limit, everything will show live when we are doing the live cases to you. And this is the 2 jets of MR are there, and that's how multiple VSTs also can, I'm going retrospectively, sorry. And this is a single ventricle. I have seen 45 years old man with a single ventricle. So adult people should know whether the interventricular septum is there or not. In this case, there is no interventricular septum. There is a rudimentary septum, and that is the mitral valve. So the single ventricle also can be made out. And this is the infradiaphragmatic with the continuous wave Doppler. And ultimately, the take-home message is a complete study must be done after the clinical examination. I told you the base foundation is the clinical examination. Once you have a good clinical examination, you know what you are looking at, and then you can get all these things. The segmental approach is very essential because there is a complex problems in a given case. Multiple problems will be there. And all views and measurements must be done in complete study. And additional views are done like the crab view or the ductal view when we are suspecting the congenital heart disease. So ultimately, these basic views are extremely important, and you know what to look for, when to look for, how to look for, then you can make a perfect diagnosis. So when I went to the Vatican City, I was thrilled to see this man, and he is the man of the wisdom with the pot of wisdom, and that is Socrates. So always we heard about Socrates. I had not seen the statue of Socrates. So I was so thrilled. I ran and stood there in front of Socrates, and I asked them to take my photograph. And I never realized, only when photograph came, I saw my empty head was there over the knowledge of pot there. And that's how we know it is better to have empty head so that you can fill in good things in your head. And thank you very much for your kind and the patient hearing. And I hope whatever I have spoken has made sense. Thank you very much. Any questions I can ask, or we can, when we are showing the live cases also, we can go ahead. Thank you.
Any questions?
Huh? Okay. Okay, sure.
Ma'am, during dextrocardia patients, there is a common confusion about the probe position. The pointer should be towards left shoulder or towards right shoulder.
पीछे जाइए इधर. Now, in the beginning only, I showed you the. One second. भैया पीछे कैसे जाने का? ऐसे end and go back करना. In dextrocardia also, we keep the probes like this. See, the subcostal view is safe, only the knob is kept on the other side. You see the knob, how it is kept? Yeah. You can see the knob, and that is the probe. And apical 5-chamber view, you go to the left side. Instead of that, you come to the right side, and then the knob is like this. And then for the parasternal short axis, you come instead of to the left, you come to the right side. And then for the parasternal short axis view, you keep the knob pointing towards the neck, that is the suprasternal notch, and this is how you keep higher up in the left, second, and the third intercostal space. So these are the views for the dextrocardia or the dextro position. Okay.
Any questions?
tell the history and I'll tell the findings. I'll examine.
So we are coming to the clinical cases, and here we have a 26-year-old lady who was complaining of breathlessness on exertion for last 5 years. And this started when she got pregnant. She was 7.5 months pregnant when she started feeling some breathlessness on exertion. Before that, she was apparently asymptomatic. For that breathlessness, she consulted some doctor, and then fortunately, she had an uneventful normal vaginal delivery. But then she has been having worsening breathlessness on exertion in YHA class 3 since then, and she's having palpitations on exertion. Although there are no palpitations at rest, but then those palpitations are worsening since then, and now she is pregnant again. So because in India, most of us are like feeling okay and not going to the doctor. Now that she has discovered her pregnancy, she has been referred to a cardiologist again. Now she is in NYHA class 3, 2.5 months pregnancy, dyspnea on exertion for last 5 years, and palpitations on exertion for last 5 years, and no palpitations at rest.
So on examination, her pulse is very fast, 108 or so, irregularly irregular. So what does it tell? She said palpitation and the pulse is irregularly irregular. What does it mean? Atrial fibrillation. And then there is a collapsing pulse. So that indicates that probably she has got the aortic regurgitation. So aortic valve lesion does not cause atrial fibrillation unless there is a mitral valve also is involved. So on auscultation, there is a mid-diastolic murmur, no presystolic accentuation because she is in atrial fibrillation. So M1 is loud, mid-diastolic murmur is there, early diastolic murmur is there. So clinically, we have a rheumatic heart disease with the mitral stenosis with the aortic regurgitation. On top of this clinical examination, Prabha will show you the views and then the diagnosis, how we make it. So the history told that she became worse after pregnancy, that is the hemodynamic changes will be there and the asymptomatic person becomes symptomatic, and on examination we have the rheumatic multivalvular heart disease with the MS, AR and the TR. So we will see what it is there. So clinically almost 85% of the diagnosis is done, and now you see all the views, and after that we will have the final whether the patient is fit for surgery or not, whether she is fit for non-surgical treatment, of course with the severe bounding pulse and then the, I don't know the BP because from OPD she has come straight, we didn't record the BP. With the severe AR, balloon dilatation is out of question. So ultimately what Prabha is going to show, the echo, will tell us how to manage, and this is how we have to go in any given case. Yes. Yeah, there you can see that there is a parasternal long axis view. Show me the pointer. And you can see that, the both AML and PML are thickened. Okay, thank you. You can see that that is the anterior mitral leaflet, and this is the posterior mitral leaflet, and these are the chordae tendineae, and here that this chordae is torn, and because of that torn it is running there, and probably when there is a torn chordae there could be MR. You can see that the LA is so big. So it is almost 3 times the size of the aorta. So that means the mitral valvular disease is there. And yeah. And what is important is there is a non-compaction of the left ventricle. And now Prabha will put the color, Doppler, and show you that is the aorta. And this is the aortic regurgitation, torrential. And how we diagnose whether it is severe, the LVOT and we measure the jet and the LVOT. And if it is more than 50%, that is a severe AR. So visually we can see that this is a severe aortic regurgitation. There is a mild mitral regurgitation. Now it is severe. You can see that it is an eccentric one. Whenever there is an eccentric mitral regurgitation, we are underestimating. And that's how we know we go for the vena contracta to find out whether it is a severe MR or not. So whether there is associated mitral stenosis, when she goes to the apical four-chamber view, she will put the Doppler, and that time we can make out whether there is also mitral stenosis, because there is an MDM there. So this is the short axis she is showing. Okay, then you see that that is the RVOT, that is the pulmonary valve, and this is the huge left atrium, and that is the appendage, left atrial appendage. This is very important to see whether there are any clots in the left atrial appendage. So this is how very beautifully she is showing the appendage and the giant left atrium, and there is a tricuspid, that the three cusps are there. Okay. Okay. Huh? Yeah, dilated pulmonary artery. You can see that this is the aorta, then that the pulmonary artery is dilated. And you can see that the beaded appearance of the aortic valve also is there. And we'll go for the short axis of the mitral valve also. And you can see that there is a prolapse of the mitral valve, and this is the beaded appearance. Prabha, can you freeze it? See there? Like beaded irregular thickening is there. And this irregular thickening is a classical of rheumatic fever. So our suspicion of rheumatic fever is proved here, and there is a mitral valve prolapse, mitral regurgitation, and then she will, yeah, now you can see that that is the short axis, that is the left ventricle, and that is the mitral valve, and that prolapsing tip is there. Sometimes in congenital, if there is a cleft mitral, that also can be made out in this view. Okay. The commissures are open, so it is not a severe mitral stenosis. Even if it is there, it will be mild. Can you put Doppler and tell us the mitral stenosis, Prabha? Okay. See, this is the apical four-chamber view. You can see that that is the eccentric mitral regurgitation. Oh, see there. It's a huge. Mitral regurgitation is torrential. I mean, it's very severe. And that's how you can see that the chordae is torn. And you can see there, remove the color, Prabha. Okay. Now you see at the tip, what is fluttering? It is the torn chordae which are rolled up. Now, how do you distinguish the torn chordae from the vegetation? Is the vegetations are on the LA side, whereas the torn chordae are on the LV side, because the chordae are attached. So in the parasternal long axis only we had seen, and this is the torn chordae. Okay. Two jets are there. Yeah, you can see that. Give it to Prabha. Prabha, you have
The ones?
She will measure both.
Madam?
Yeah, she has the mic. Prabha, measure that and tell us how much is the mitral stenosis, and
I don't think there is any mitral stenosis. I
is
think
not there.
yeah, it's widely opening.
Okay.
The gradient, whatever is, maybe because of increased flow itself.
Okay.
Left atrium is
But there is an MDM on
yes,
examination.
flow murmur.
Yeah.
We saw in the short axis also there is no commissural position. It's
Yeah.
mean gradient is around
So
4.
very,
It
very
could be
mild, that is the flow
Flow
mitral
related,
stenosis, where that MDM is like that. So what I thought is the presystolic accentuation is not there because of the atrial fibrillation. It is because it is not a severe mitral stenosis. Okay.
Go to 5 chamber use.
And then you reduce the TGC and show whether there is any calcification. The TGC adjustment, you can see that when you reduce it, if there is a calcification, that will be seen as a dense one. But here it is not. She is a young lady, calcification is not there.
As ma'am pointed out,
Yeah.
History is so important.
Yeah.
Like, meanwhile, she did not have any orthopnea or PND. That also points that she did not
Yeah.
have that significant mitral stenosis, and just that the regurgitation was worsening and the LA size was increasing. Had there been
Now we have to do the ASLO titer also, whether there is a recrudescence of rheumatic activity over the previous one, that also has to be ruled out.
Madam, 5-chamber view. Color.
Yeah. Go ahead.
There is significant aortic regurgitation,
Yeah.
which we already saw in the parasternal long
Yep.
axis. Maybe you can put the Doppler and see whether there is any aortic stenosis.
You can see that that's a atrial fibrillation is very clearly seen. Each beat is varying, beat to beat it is varying. And to get the gradient or measurement, we have to take 5 beats and take the average of that. So atrial fibrillation clinically we had made, and then AR we had made. MS we made it because there was an MDM, but now we know that it is a severe MR. So this is how we know our clinical diagnosis is
RV focus view for tricuspid regurgitation. Right sided chambers are small. There's some mild tricuspid regurgitation.
Anybody wants to ask any questions? Prabha will demonstrate that. Get your mind cleared. No confusion or cobweb in the head. So when you go back, you go with the clear mind so that you will not.
Not aligning
Yeah.
properly. It's
So
very
please.
small tear, difficult to align. How to increase?
Madam, quantification of MR by vena contracta method.
Yeah, Prabha, he's asking for quantification of MR.
I will discuss that during the talk.
Yeah, she's going to talk about it.
Okay. Madam.
She's going to talk about it and then,
Okay. There is no
because she's going to talk about the assessment of the valvular lesions. Or you can just tell the vena contracta here in this case, and then we can be done with. Yeah, you can see that IVC, that is the IVC. Though it is collapsing, you can see the sec. Prabha, keep it. Can you see that that is a spontaneous contrast? And that sec indicates, as I showed you, that it could be the PA pressures are very high, RV dysfunction is there. And see that, so beautifully seen. Can you see that? And this is the right atrium.
the left atrium is
Left,
so huge.
left, and then,
You can see the right atrium squeezed.
yeah,
It's joining the, IVC
That is
joining
the
the
right.
It is squeezed, yes. This is the IAS, what we are seeing,
sec is very beautiful.
yes. The hepatic veins are also dilated.
So she requires 2 valve replacement, aortic as well as the mitral valve replacement, double valve replacement. Yeah. Yep.
You
Use the
said
mic.
torn chordae. Usually they are seen in more in like CAD ischemic MRs. Torn chordae.
Huh,
Chordae.
torn
Usually
chordae.
they are more seen in CADs or ischemic MRs. Like
No,
more
the torn chordae can occur both in rheumatic as well as ischemic heart disease. In ischemic, not the chordae, even the papillary muscle can be torn. Whereas in rheumatic, multiple chordae will be visiting. And she's showing the abdominal aorta for the, huh? Okay, suprasternal. Yeah, give it the mic. Give the mic
Descending
to
thoracic aorta, pulse wave Doppler showing the diastolic flow reversal.
and that indicates that there is a severe,
Severe
AR.
aortic regurgitation. We can also see in the color M mode.
Hold the mic for her.
Yeah, color mode also you can see the hollow diastolic flow reversal.
Yeah, this is the holodiastolic color flow
Yes, the
reversal,
red one.
and that happens in the
Severe aortic regurgitation.
aortic regurgitation.
So final diagnosis is severe MR, severe AR.
So please give a big hand to Dr. Prabha. She demonstrated so well, and then She told that my clinical diagnosis was MS was wrong. Yeah. But MDM is still there. That auscultation, it is there. Yes. So this is how we know the echo turns out to be superior to our clinical findings, but clinical findings are the basics, and that's what it proves. So it helps us to make the decision whether 2 valves or 1 valve to be repaired or replaced. Okay,
If anyone
thank you.
wants to
We go
have
to the next one.
hands-on,
Yeah,
does anyone want to have hands-on, like if anyone want to do?
thank you, Prabha. ಚೆನ್ನಾಗಿ ಬಂತು notice. ಹೌದೌದು. And clinically, apex was almost down and out, and then only I realized that it is a severe AR and MR. Yeah. Read the clinical findings. Take the clinical findings. No, you ask the history, no? The same patient? The same patient, क्या कर रहे हैं? Okay.
Yeah, thank you so much, ma'am. Please have a seat.
How will you increase? You are not getting TRZ properly, no? How to increase it? Anybody? Take deep inspiration or passive leg raising. Passive leg raising will increase the TR. Tell her not to hold the abdomen, otherwise it will not serve the purpose. Yes, passive leg raisings. Put the color, see whether any. He left it. This is not extra. What are you trying to see? TR. It's very. Yeah, you got it. What do you want? What? Okay. Maybe remove it. IVC is dilated. Maybe she is treated. What is the size? So it's not dilated? Cutoff is 21, but in Indians they take 17 also. But definitely there is sec, as madam told. You can see. What is it called? Dense sec in the IVC, what is it called? Traffic jam sign. Classically seen in constrictive pericarditis, but it's a sign of high RA pressure. I think you don't see traffic jam here.
We are fortunate today that we are witnessing you and without expecting any results. Otherwise, these questions are those by which we get to you, like fail or pass will be decided.
And the other sign, you show the IVC with hepatic veins, dilated IVC with hepatic veins. It's called, anybody? Playboy bunny sign. It's a rabbit with 2 ears. Rabbit is the IVC and the 2 heads are the hepatic veins dilated. So that's a sign of high RA pressure, right heart failure.
You want to
Playboy bunny sign. Sometimes it is multiple veins you can see. That's also called antler sign, deer antler sign. What we see in pulmonary venous congestion, X-ray finding. Here also these veins can be. Yes.
Ma'am, Dr. Vijay from Singrauli wants to see, learn how to see ascending aorta from supraesternal notch.
Suppression.
Yeah, diastolic flow reversal.
What is his name? What is his name? The one put it.
Yeah, you transducer in the suprasternal view.
Yeah.
And the pointer towards the left 3 o'clock, left sternal border.
Dr. Manish was very happy doing the case because the pictures came out very well.
So
Which is the best part of the
you
machine?
can put the,
Can anyone tell? Which is the best part of the echo machine? The man or the woman behind the machine?
you put color there.
If
put
you
color.
can evaluate.
2-year piece, that is the most important thing.
You can see the blue flow which is away from the transducer is the forward flow. The red flow is the reversal. Now you put the pulse wave. Pulse wave. Here. See, you freeze it. Freeze. Yeah. This is the forward flow. This is the forward flow and this is the reversal. You can get better one. Yeah. Yeah, put it, pulse wave Doppler. Can you see there?
Holodiastolic flow reversal.
Yeah. Hey. Something is happening. Yeah, I wanted to freeze. Yeah. This is the holodiastolic flow reversal. You can measure the velocity of the end diastole. It should be more than 20 centimeters. You can measure it at the end diastole. This should be more than 20 centimeters. At the end diastole. Area. Height, something like, it's like a dimension. You can take it as, or velocity. In our machines, if you just keep it, will come. Wait a minute.
Dimension.
They should not use actually, supposed to damage the transducer. I don't think you are looking at velocity. Yeah. And other thing is, you can see color in it. The color amount. You see that? It's as well as the reversal. If the reversal VTA is more than the forward, that is also suggestive of severe aortic regurgitation. And this flow reversal you can see in the abdominal aorta also, and that is more specific of severe aortic regurgitation. Let me try whether there is aortic. You want to try?
Just show the prop position.
Yeah.
Supraesternal. Dr. Prahlad Patel, the most.
See that? This is the pointer. Pointer, you face towards the 3 o'clock. 3 o'clock.
So Dr. Prahlad wants to know the probe positions. Madam is explaining.
Yeah, you can see the arch vessels also there. Yeah. This is helpful in coarctation of aorta, flow reversals in AR and aortic dissections also, this way will be helpful. You want to try? Towards the left, 3 o'clock position. 2 or 3. Yeah, little. Yes.
Anurag?
Yeah, you're getting it. Yeah, probe. Yeah, probe position towards the.
This point and this.
Yes. Yes, yes. This is the point. This is the point. Keep it towards like this and deeply into that. See that? Angulation is like that and down angulation. Transverse point is towards the 2 o'clock position. 3 also sometimes you get, but here it is 2. And if deep angulation is towards, yeah, downwards. Downward angulation, yes. Yeah, you can try. Ah, you got it. Yeah, that's the way. Ah, okay. Because I am moving the mic. Yeah, that is the descending aorta. You put the pulse Doppler, and color M mode. Yeah, that is the pulse wave. Why is it varying? Why is it varying? Because of atrial fibrillation, yes.
Delay is much enlarged.
Delay also because of severe mitral regurgitation, yes. You see 2 huge jets.
You can see the academic enthusiasm. Dr. Manish Mishra is present, CMHO at Narsinghpur, and still he took so much pain and came to attend the conferences to still learn and improve his skills and knowledge. So we all appreciate, sir. Thank you. He's in Apollo Hospital.
So basics from holding the probes, the position of probe, and how to focus. I think these are few basic things which gives the better results. I request all that whoever wants to learn few basic tips, please whenever we call upon here, you can come over here. We are thankful to our patients who are helping us to learn. And this is a time that if a disease, eco-assessment. After 10 minutes, we will start. So just a short break. Please have your tea and join here.
Dr. B.M. Sharnagat sir is
I think
also with
better to
us. He
use,
is currently IMA state president, and he came all the way from Balaghat to attend our conference. Thank you, sir. Thank you.
You're still doing it?
Welcome back. I request everyone to take a seat as we start with our next session. Our last session was wonderful indeed. Now we move on to our next session, valvular heart disease, which will be led by Dr. Prabhavati ma'am. Dr. Prabhavati ma'am is a senior professor of cardiology and a course co-director with decades of excellence in clinical cardiology and echocardiography along with medical education. I request Dr. Kaveri as a...
So I expect that everybody is now again ready and motivated with our first lecture and hands-on. So please be seated. Dr. Prabhavati Bhatt madam, she is highly distinguished senior cardiologist and currently she is the HOD in Jayadeva Institute, Bangalore. Madam doesn't want that I should speak much. So I will not take much of time. She is one important thing that 100 of students are every year, 100 of cardiologists are coming ahead every year. So we are very fortunate that madam is over here and she has more of work in pediatric cardiology. I request madam.
Thank you.
I will take my all this vomiting in later in the main part. Madam is not allowing me to introduce her properly.
Thank you very much. I am very happy to be here among all of you. At the outset, I would like to thank Dr. Pushparaj and the organizers for giving this opportunity and also Madam Vijayalakshmi for inviting me. Because of her, I am here. Yes. Shall we start? People are still having coffee? Yeah. So, echo in valor heart disease, which is very close to my heart. Every day we see at least 12 cases of valor heart disease echo. So echo helps in assessment of the valve anatomy, what is the etiology and mechanism of valve heart disease, what is the severity and coexisting other valvular lesions and also its effect on the other chambers, ventricular functions, pulmonary artery pressure, and in aortic valve disease you have to see the aortic root dimensions also. We'll start with mitral stenosis. I may take 40-50 minutes whenever you want, you can stop me. Dr. Pushparaj or anybody? Yeah. You all know mitral valve is the most complex valve in the body. Affection of any part of this, annulus, leaflets, chordae, papillary muscles, and subjacent myocardium or left atrial wall also can cause either MR or mitral stenosis. What is the most common cause of mitral stenosis? And how often it is rheumatic? Anybody? 98 to 99% it is rheumatic. Rare causes which we see, madam showed congenital, degenerative, and sometimes we see for some cases of post-MV repair. Recently I saw a patient with SLE having mitral stenosis which improved with the treatment. And mechanism, it could be commissural fusion. There are two commissures which can get fused, or it can be purely cuspal, thickened fibrotic cusp with calcification, or just a caudal subvalvar, and very often they will have combined of these. So balloon valvotomy helps when there is commissural fusion only. So that is the importance of looking for that. So M-mode and 2D helps us to look for all these features, and Doppler we can assess the turbulence and increase gradient. So very important to see the M-mode. You all may be thinking M-mode is obsolete. No, it is still helpful. See, in the normal mitral valve, you have this is the anterior leaflet, this is the posterior leaflet. Posterior leaflet goes in the opposite direction. When there is mitral stenosis, you can see the mitral valve movement is reduced, EF slope is reduced, and the most important is the posterior leaflet goes along with the anterior leaflet. That's called paradoxic movement of the posterior leaflets. When in doubt, especially in isolated aortic valve disease, you want to see whether the mitral valve is involved with the rheumatic process, you can look at this. Either the PML will be flat or it will be paradoxic. So that is the usefulness of M-mode. This is the classical MS you might have seen. This is the hockey stick appearance, very pliable leaflet, very encouraging for balloon mitral valvotomy. And you can see the color turbulence. And here you see, this is a severe submitral disease. You can see the thick and fused chordae, very short chordae, and you will not get optimal result with balloon valvotomy in such patients. And you see the jet here, it spreads like a sun ray when there is severe submitral disease. Otherwise, it will have a candle flame appearance. The most important view is the short axis view, where you will see the commissures. You can see leaflet calcification, and the medial commissure is densely calcified, whereas the lateral commissure is not fused. This patient is unlikely to benefit from balloon valvotomy. On the other hand, here you see the leaflets are very pliable, both commissures are fused, there is no calcification. This is an ideal case for balloon valvotomy. And this is a 4-chamber view showing the classical candle flame appearance of the turbulent flow across the mitral valve. So assessment of severity depends on the orifice area. This is the most accurate non-invasive assessment to assess the severity, and it has a best correlation with the explanted valves. It is highly feasible, possible to do in majority, 95%, only in 5% because of the calcification and distortion, you may not be able to assess. So how to measure? Parasternal short axis, you take the smallest orifice to be identified by scanning from apex, because the valve here is funnel shaped, and use optimal gain settings and image magnification using the zoom. So you see gain high, orifice area is overestimated. Here low gain, it is underestimated. So you have to have optimal gain. And so you have to see the maximum opening in the mid diastole. Trace the contour inside. If the commissure is open, you have to include the commissure also. Better to take average of 3, but in AF you may have to take 5 or 10 beats. So sometimes you may use the color. Yeah, I said it is a funnel shape. You see what is the effect. If you measure at the tip, you will get a smaller orifice. If you get little up, you will get a larger orifice. So you should be exactly at the tip. See this and see this. 3D echo, which we generally do not know on a regular basis. It has a better alignment at the mitral valve tips, more accurate, more reproducible. You can see the morphology and commissural fusion better, and orifice estimation is supposed to be better compared to 2D. The next parameter is transmitral gradient using continuous wave Doppler. This is reliable but not the best marker of severity, because it depends on the flow across the valve, which in turn depends on the heart rate, cardiac output, and associated mitral regurgitation. It's very sensitive to heart rate. The moment heart rate increases by 10 or 20, the gradient goes up. So you should mention the heart rate whenever you record this, and take at least 5 cycles in atrial fibrillation. So gradient, mean gradient more than 10 in a heart rate of 60 to 80 indicates severe mitral stenosis. Another easy parameter is pressure half time. This is the time taken for the jet velocity to reduce by 50%. This is again obtained by tracing the deceleration slope. Same continuous wave Doppler, you trace the deceleration slope of the E wave. Mitral valve area is equal to 220 by pressure half time. It correlates well with the mitral valve orifice by planimetry. This helps, because if the valve orifice is not traceable, then you can use this. Yeah, this is how it is done. And you see the pressure half time is 314, and the machine itself gives the orifice area 0.7. It's widely used and easy to perform. But you cannot do this when there is LV dysfunction, because elevated LVDP, aortic regurgitation, significant mitral regurgitation, and post PTMC immediately within 2 to 3 days. Because of the compliance changes, it is not very useful. Another simple parameter is mitral leaflet separation index. This is measured at the tip of the leaflets in the parasternal long axis and the apical 4-chamber view, and you can take the average of that. If it is more than 1.2 centimeter, not severe MS. If it is less than 0.8, severe MS. You can double it, 0.8 means it is 1.6. Yes. But it is not helpful in calcification. So this is how it is measured in the parasternal long axis view. So echo features of severe MS, less than 1 centimeter square is severe, but recent guidelines say less than 1.5, but we still, most of the cardiologists use 1 because the body surface area of our patients is smaller, and pressure half time more than 220 milliseconds, mean gradient more than 10 at a rate of 60 to 80, and systolic pressure of 50. So you should also look for the other changes caused by the mitral stenosis like dilated LA, which has a correlation with the prediction of survival mortality, and pulmonary hypertension, tricuspid regurgitation, right heart dilatation, RV function, LV function, all these we need to look for. So a word about assessment of the pulmonary hypertension, we just saw there. You take the TR jet velocity and measure the RV systolic pressure, which is a surrogate for PASP as long as there is no pulmonary stenosis. So maximum TR jet you have to take, and it is using modified Bernoulli equation. You can calculate the gradient and add the RA pressure, you get the RV systolic pressure. You should take multiple views to get the complete envelope of the TR jet and take the maximal velocity, like here. And you should not take sometimes you get some kind of hair, you should not take the dense part only, you should take. That's called pseudo hair, you should not take. You take only the beard and not, take only the chin, not the beard. Okay, then RA pressure is assessed looking at the IVC, which all of you know. IVC is measured just proximal to the joining of the hepatic vein, about 0.5 to 3 centimeter proximal to the right atrium. So these are the values. If IVC is normal, collapse is more than 50%, then it is normal RA pressure. If the IVC is dilated more than 21, in Indian you can use 17 because of the small body surface area, and collapse is less than 50%, then the pressure is 15 to 20. If there is sec, it is still higher. So there are various scores for assessing suitability for balloon mitral valvotomy. And another important thing is mitral regurgitation. Presence and severity has to be assessed, and LA clot. So absolute contraindications for balloon valvotomy are bicommissural calcification, more than moderate MR, and a persistent LA body clot. So we have done a study where we have done PTMC in patients with LA appendage clot even protruding to body after anticoagulation for 8 to 12 weeks. So these type of clots are fresh clots, you need to give anticoagulation, and maybe we can try later. But these are mobile clots like these, or septal clots on the septum, or this large clots and ball valve thrombus. Here it becomes a indication for early surgery and not the balloon valvotomy. Sometimes you'll have to do modified views to look for the extent of the clot. Anyway, you have to do T in these patients to know the extent. And this is a dense sec. It's difficult to make out the clot. So all these patients will undergo transesophageal echocardiography. Next is mitral regurgitation. Again, echo helps in assessing the etiology, mechanisms, severity, and most important, feasibility for a repair. So mitral valve is repairable in most of the time, especially if it is degenerative. Here the assessment of severity is complex. You need to look at multiple parameters. Sometimes you may need 3T or 3D. MR can be primary when it involves a mitral valve apparatus. If it is secondary, it is due to LV dilatation or dysfunction seen in ischemic heart disease or dilated cardiomyopathy. Yeah, common causes are rheumatic, mitral valve prolapse, flail leaflets, infective endocarditis, or in old people it can be annular calcification. Are you familiar with this person, Carpentier, who is a surgeon, who has classified MR into 3 types to see whether valve is repairable. So this is motion in relation to motion of the free edge of the leaflets relative to the plane of the annulus. If it is normal mobility, the MR is due to either annular dilatation or leaflet perforation, or as madam told, cleft leaflet seen in endocardial cushion defects. And excess mobility, prolapse or flail. Restricted mobility, classically seen in rheumatic heart disease. We will see some examples of this. See, here valve looks normal. LV function is reduced. So annular dilatation causing mitral regurgitation. This is the secondary mitral regurgitation, and this is type 1. Here what are you seeing? PML is prolapsing. It is above the annular plane, and you can see anterior jet traversing the intraatrial septum. So if the jet is anterior, then it tells you that the posterior leaflet is abnormal. If the jet is going posterolaterally like this, that is AML abnormality. So here we should know what is 3 scallops in the posterior leaflet, P1, P2, P3, A1, A2, A3, starting from lateral annulus to the medial, P1, P2, P3, because posterior leaflet abnormalities or prolapse is more amenable for repair, especially P2 is repairable in 98 to 99% if it is degenerative. So what is mitral valve prolapse versus flail? Anybody? What is flail mitral valve? Prolapse is just leaflet is buckling, but the tip is still facing the LV. When you talk about flail, so this is the prolapse, 2 millimeter above the annular plane, whereas flail, you see here, there is a tone chordae, and the leaflet is moving freely into the LA. The tip is in the LA during systole. So usually occurs due to tone chordae, which madam showed during the demonstration, and also in acute MI it can be because of papillary muscle rupture, and you will see the tone chordae attached to the tip of the leaflets. So that is how you diagnose flail leaflet. Yeah, here is a flail AML, and you can see the chordae, tone chordae moving there, and you can see the jet, posterolateral wall hugging jet. This, anybody? See, the mitral leaflets are thickened, there is hockey stick, and you can see some non-coaptation here, and the MR jet is generally going posterolateral. See here, this is classical rheumatic mitral regurgitation. We talk about prolapse, there actually the excess mobility of the leaflet tip. Sometimes there can be caudal tear causing typical prolapse also, or flail also. So this, anybody can make out anything, any abnormality in the leaflet? This is actually posterolateral MI, patients having infralateral affecting this lateral portion, and you see this PML. PML is not moving, especially during systole. AML is trying best to coapt. This is called actually Siegel's sign, and the PML is not helping because it is tethered by the akinetic segment where the papillary muscle is attached. So that is called tethering, and this is seen in post-MI patients, inferior posterior MI. Even a small area of akinesia can cause severe regurgitation. So assessment of severity depends mostly on the color Doppler, but we need to look at the mitral valve anatomy for coaptation defects. As we saw, flail leaflets usually associated with severe MR. And also look at the LV size, LV function, which is important to assess the chronicity, severity, and the need for surgery. Quantification of MR is depending on the 3 parameters: size of the color jet, vena contracta, and the flow convergence. See, all these regurgitant jets will have 3 components. One is the flow convergence, then the narrowest portion, which is the vena contracta, then the flow, color jet in the left atrium. So generally what we do, look at the color Doppler and assess by the what? Visual estimation, right? Yeah. But it's better to have some measurements. So when you look at the color Doppler, you have to see gain setting should be proper, frame rate should be highest using a narrow sector. I was trying to get a narrow sector there because frame rate increases, you have the better resolution, and at least 2 views you should use. And this is not the amount of blood entering the left atrium, it is the distribution of flow velocity in the left atrium. So this is highly influenced by the instrument settings, preload, afterload, LS size, compliance, and so many things. So it is not that accurate, but still we use it, especially by eyeball estimation. You can measure the jet area. If it is more than 8 to 10 centimeters square, it indicates severe MR, Or you can take the ratio of the jet area, total LA area, more than 50% is severe MR, less than 20% is mild MR. In between that is moderate. Yeah, here you can see it's a small jet. Jet area is hardly 3 centimeters and the ratio 15, 3, it is hardly 20%, suggestive of mild. Here you have a large jet. Jet area is more than 25 and the ratio is more than 50%, suggestive of moderate. This is, severe. This is moderate MR. You can see the jet area as well as the ratio of the LA area. So there are a lot of pitfalls when there is hypertension, when the LV pressure is high, you get overestimation. Acute severe MR, LA pressure is high, so it may be underestimated. Central jets are overestimated because they can entrain more RBCs all around, whereas the eccentric jets, wall-hugging jets are always underestimated because they cannot entrain RBCs on all sides. So there are a lot of caveats. So coming to vena contracta, somebody was asking, this is the narrowest portion of the flow. That is here, this is the flow convergence. This is the narrowest portion, vena contracta. And it approximates the effective regurgitant orifice area, possible to get in majority, 90% of the patients. So image in parational long axis, apical 4-chamber views. You take the narrowest Doppler sector and magnify and zoom. Take average at least 2 to 3 beats and 2 orthogonal planes. So this is how it is done, narrowest portion. And somebody was asking, if it is less than 3 millimeter, it is mild. 7 millimeter or more, it is severe. In between 3 to 7 is moderate. So then you need to use more quantitative methods. All these, you cannot depend on single parameters. You have to have multiple parameters, which we will discuss later. This is helpful when it is circular. Suppose it is smiley face long, so it may not be accurate. Many of jets may not be, organic MRs are usually circular, but functional MRs may not be. So it is strength, that is advantages, it works well in central as well as eccentric jets, simple, quantitative, but it is not useful when there is multiple jet, small values, errors can be more, and intermediate values require confirmation. So I will not go into depth of this proximal isovelocity surface area. The principle is, whenever the blood is approaching a circular orifice, it forms a concentric hemispheric shells of increasing velocity and decreasing surface area. You will have to do some, decrease the Nyquist limit to 30 centimeters. Then you measure this. This is when the color changes from blue to orange or yellow up to the vena contracta. So this is the radius of the PISA. You can use it individually. If it is more than 10 millimeter, it indicates severe MR, or you can use it to assess the quantitative like regurgitant orifice, regurgitant volume, regurgitant fraction, all that can be assessed. We sometimes do in the lab when we teach students. So advantage is it is quantitative, supposed to be most robust parameter, but it's cumbersome, less accurate in eccentric multiple jets, and it may not be always hemispheric. So as I said, this PISA is used to assess the effective regurgitant orifice area, and you can also assess the severity by continuity equation. These are hardly done, but there are some simple parameters you can use. If you can measure the pulmonary venous flow, superior pulmonary venous flow, normally systolic is more than the diastolic. Whereas when there is severe MR, there is a flow reversal. You see systole, there is a flow reversal in the pulmonary veins. And another parameter is you take the pulsar Doppler of the mitral valve inflow. The peak velocity, in the absence of MS of course, if it is more than 1.2 centimeter, it indicates severe MR. If you get a dominant A wave, E is small but A is bigger, that rules out severe MR. This helps sometimes when we are in borderline, moderate MR. Many times you get from surgical colleagues whether this patient needs MER along with CAPG. So we use these parameters. And other thing is you take the VTA of the mitral valve aortic valve ratio. If it is more than 1.4, it strongly suggests severe MR. And if you take the MR jet, if it is dense, signal intensity is gent with a full envelope, that also goes in favor of severe MR. And of course you look at the non-cooptation, flail, all that we said. These are the criteria to have severe mitral regurgitation, and we all already discussed all this. And American Society of Echocardiography says 4 of the 6 criteria should be there to say severe MR or mild MR. So we'll move on to the aortic stenosis. Echo is helpful again to assess the severity, morphology, aortic pathology, other diseases. You all know the aortic valve is having 3 leaflets with the orifice area of 3 to 4 centimeters square, and leaflet separation is 1.5 to about 2.5 centimeters. It could be valvar, subvalvar and supravalvar, which madam already discussed. And most common causes of valvular AS is either calcific aortic stenosis in the elderly, degenerative, or calcification in the older age in bicuspid aortic valve, or younger age without calcification also they can have AS, and rheumatic aortic stenosis still seen in our country. However, bicuspid aortic valve is the most common cause of aortic stenosis and most common cause of congenital heart disease, seen in up to 2%, more common in males. And most of them in the life develop aortic stenosis. 85% will develop aortic stenosis. Remaining 15% will develop aortic regurgitation. They are prone for infected endocarditis. Another important thing is they can have aortopathy, that is dilatation of the ascending aorta with dissection or rupture. Bicuspid aortic valve is classified by Sievers into 3 types: type 0, type 1, type 2. Type 0, there is no raphe. This is a true bicuspid. Type 1 is the most common, where there is one raphe. The raphe is between the right and left, this is the most common, that is seen in 71%. And next common is fusion of the right and non-coronary. They are more prone for aortic stenosis and aortopathy. Rarely we may have 2 raphe. So can you see here, there are 2 leaflets. Here you can see a raphe which is fused right and left, which is the most common. This is the still frame. You should see in the open position, not in the closed position. Closed position, you may mistake it for a trileaflet. Yeah, this is a true bicuspid valve. There is no raphe at all. Okay. So bicuspid aortic valve in the parasternal long axis may have asymmetric closure line. We actually calculate some eccentricity index here. There may be systolic dooming or some leaflet may be prolapsing causing AR. In younger age, when they have AS, there is no calcification, so they are amenable for balloon valvotomy. But in older age, after 40 years, especially calcification will be severe, it may obscure the number of cusps. A word about aortopathy, which is seen in 20 to 84%, either because of the abnormal flow pattern or inherent abnormality in the aortic wall. It is called fate versus flow, flow versus fate. So majority, it will start in the younger age itself, and it is independent of valve function. Even after valve replacement you can have. You need to assess the tubular part of ascending aorta. This is the sinuses most often affected in Marfan's. But in bicuspid aortic valve, it is the tubular part of the ascending aorta is involved. So you need to look at the ascending aorta distal to the ST junction, that is sinotubular junction. So majority will have dilatation there, rarely it can be Marfanoid type. So rheumatic case, like mitral stenosis, there will be commissural fusion and there may be dooming, and you have a triangular circular orifice. There will be calcific nodules on both surfaces, and often they will have regurgitation, always associated with rheumatic mitral valve involvement. You can see here, mitral stenosis is there, thickened leaflets, and aortic valve is calcified. There is some dooming of the posterior, that is the non-coronary cusp. Same. Here you can see the 3 leaflets, tip is affected more. Whereas in calcific aortic stenosis, there is no commissural fusion. So there will be calcific deposition either on the leaflet tip or at the attachment, and it will have a stellate shape. So this is supposed to be the orifice in calcific, triangular shape in rheumatic, and something like a fish mouth in bicuspid aortic valve. So these are the parameters to assess the severity of aortic stenosis. Most important is aortic valve area. We cannot use the planimetry because of a lot of technical issues. We need to use a continuity equation. But most often what we do is we calculate the peak velocity and mean pressure gradient, which is a robust measurement. And another important thing is dimensionless index or the Doppler velocity index. You should also look at the LVH, calcification, which will also help to assess the severity. So these are the features of severe aortic stenosis. You all know 1 centimeter, peak velocity more than 4, mean gradient more than 40, and Doppler velocity index less than 0.25. When you say very severe AS, peak velocity is more than 5 meters and mean gradient 60, by itself it becomes an indication for surgery. So you keep the continuous Doppler in 5-chamber view or apical 5-chamber, suprasternal, right, parasternal, wherever you get the maximum you have to look for, because the jet may be eccentric, you may not be able to align it. So this is severe, very severe. You can see the gradient is more than 72, it's 72. What is Doppler velocity index or a dimension? This is a simple parameter. You take the LVOT VTI by pulse wave Doppler, LVOT VTI by pulse wave Doppler, and VTI of the aortic valve, you take the ratio, right? So here it is 18.8 divided by 121, it's equal to 0.15. Anything less than 0.25 is severe aortic stenosis. Moderate is 0.25 to 0.5, mild AS is more than 0.5. This is actually in relation to the orifice area. Okay, that is why it's called dimensionless index. Continuity equation, we can use, every day we do for all cases, you measure the VTI of LVOT and cross-sectional area of LVOT, which is equal to VTI of aortic valve and the aortic valve area. So we take this, divide it by VTI, you get the aortic valve area. And this is a simple formula. LVOT diameter in centimeters square into DVI into 0.785. This gives you the orifice area. Every day we do this. Okay, you have to look for severity of aortic regurgitation, especially in children planning for a balloon valvotomy in a bicuspid aortic valve. And more important, aortic dimension in bicuspid aortic valve, LV size, thickness, ejection fraction, we assess LV diastolic function, and it can also affect the mitral valve in severe aortic stenosis in late stages. There may be LA dilatation, mitral regurgitation, pulmonary hypertension, and right-sided involvement. Why is it important? There is a staging based on this. Whether LV is damaged, left atrium and mitral valve is damaged, pulmonary vasculature is damaged. So as the staging goes towards the right, then there is increased post-operative mortality. So that is the importance of assessing all these. Aortic regurgitation. Should I go on or stop? Continue, okay. Again, aortic regurgitation could be rheumatic, congenital, bicuspid or quadricuspid, or aortic root abnormalities. There are various causes. Like Carpentier's, here also we have a classification, same thing borrowed from Carpentier, Zogby and El-Khoury has classified into type 1, type 2, type 3. Type 1 is the normal cusp motion with aortic dilatation. Here the AR is because of aortic dilatation or leaflet perforation. And 2, prolapse of the leaflets, which can occur in various diseases, or restricted mobility, classically seen in rheumatic heart disease. Again, to see whether you can do a valve sparing surgery. In these conditions, we can do a valve sparing surgery called Davies, Yacoub. They just replace the ascending aorta and spare the valve. And leaflet perforation they can close with the pericardial patch. Again, assessment depends on the color Doppler and various pulse wave and CW Doppler, which we saw during the discussion. All of you would have seen this AML fluttering. That will not tell you the severity, that will just tell that the AR jet is hitting the AML. And very important point is a premature closure of the mitral valve. You can see it is even before the P wave, it is closing. That indicates a high LV end diastolic pressure, and this can also occur in acute AR or in LV dysfunction. So, one classical question asked in the exam, what is the echo equivalent of Austin Flint murmur? This is the jet hitting on the aortic leaflet, causing a bent knee appearance or a reverse dooming. And it's very important to assess the non-coaptation, LV dilatation, left ventricular hypertrophy. See here, you can see the leaflets are non-coapting because of the ascending aortic dilatation. And madam has already shown this. And here, rheumatic heart disease. You can see the mitral valve is involved, and we just saw a case, aortic valve thickened and there is a prolapse, and severe aortic regurgitation. And this, you can see the vegetation of the aortic leaflets. So bicuspid aortic valve is more prone for infective endocarditis, and they're also prone for perivalvular complications like abscess, pseudoaneurysm, and fistula. So can anybody make out here? Yeah, very classical quadricuspid aortic valve with some moderate aortic regurgitation, which is usually because AR, not the AS. As the number of leaflet increases, AR is more common than the AS. And this is, what are you seeing here? Again, root dilatation. This is typical Marfan's, that is, sinuses are dilated. And this one, can you see here? What is this? Dissection flap. Aortic dissection causing severe aortic regurgitation. This was in the emergency room taken, so there is no ECG or proper. Okay. So how to assess severity of aortic regurgitation? Again, based on the color, madam already showed. You see the jet height divided by the LVOT dimension. 65% is severe aortic regurgitation, and this can be used only in central jets. You cannot use it in eccentric jets. So you can also see the area in the short axis view, jet area and LVOT area. If it is more than 60%, it gives severe aortic regurgitation. This is the one which has aortic LVOT area and the aortic regurgitant jet area. So again, vena contracta also can be used here in zoom mode, narrow sector, minimum depth, to improve the frame rate. So here, if it is 6 millimeter or more, in MR it is 7 millimeter, here it is 6 millimeter or more, indicates severe aortic regurgitation. It correlates well with the severe aortic regurgitation, very important here, vena contracta. Most of the time it is possible if in the central jets. There are other parameters. This is a continuous wave Doppler. If it is dense compared to the forward, it's equal dense or mildly dense, that indicates severe aortic regurgitation. And pressure half time is the pressure taken for the jet velocity to reduce by 50%. Mild AR, it is almost horizontal, flat deceleration slope, whereas severe AR will have a rapid decline. It will have a less pressure half time. So pressure half time less than 200, severe AR, more than 500, mild AR, but it is not possible in LV dysfunction. So you can see here, it is almost flat. So pressure half time is more. Here it is more rapid decline. So pressure half time is less than 200, suggestive of severe aortic regurgitation. This we saw extensively during our case discussion. Suprasternal window. You use pulse wave Doppler or color mode, pan diastolic flow reversal. We have already seen this. You can see so dense it is, flow reversal. And this is the pulse wave Doppler. You can measure the end diastolic velocity, which should be more than 20 centimeter. This is the reversal, and this is the forward flow. You can see the reversal VTA is more than the forward VTA. So suggestive of severe aortic regurgitation. So sometimes you can see flow reversal in the abdominal aorta also. See there? This is the forward flow, this is the reversal. Flow convergence like PISA, what we saw in MR, similarly we can use in aortic regurgitation. Generally we don't use. This is how it measured in the 5-chamber view. And quantitative methods are supposed to be more accurate, but rarely used in clinical practice. So these are all, see, when you assess these regurgitant lesions, you should not depend on one parameter. You should have an integrated approach. Look at the LV. Without dilated LV, you cannot have severe MR or severe AR unless it is acute. So dilated LV is a must for severe aortic regurgitation or severe MR when there is no acute AR or MR. But it should be normal LV function. Large non-coaptation defects, color flow regurgitant more than 65, vena contracta more than 6 millimeter. All these we discussed, 200 milliseconds, and flow reversal. These are quantitative assessments which is done only when there is doubt. So again, ASC, 7 criteria are there for severe and mild. If 4 are there, then you can go straight away, you can say it is severe or mild AR. If it is moderate, then you will have to use quantitative assessment. So these are the 7 criteria: flail valve. Only in central jet you can use the width of the color. Okay. So assessment of LV and LV function is very important because it decides the timing of surgery. Ejection fraction 55% and LV systolic dimension, how much? 50 millimeter or 25 millimeter is the 25 millimeter per meter square is the indication for surgery. And also they predict outcome. Very important thing is to measure the aortic size, both in AS and AR. Annulus decides the size of the valve. Annulus is measured in mid-systole, whereas all the dimensions in the, this is the sinus, the sinotubular junction and the ascending aorta, they all measure in the end diastole because the movement is minimal during end diastole. So this is how it's measured, and these are the measurements of the aorta in sinus, ST junction and the ascending tubular ascending aorta. A few slides on tricuspid regurgitation. Most of them are functional due to pulmonary hypertension secondary to left-sided diseases, and 15% to 30% can be organic due to direct involvement of the tricuspid valve. Again, severities depend on the color, Doppler, visual assessment of color jet area is a quick initial screen, and color Doppler is mostly extrapolated for MR assessment. More than 10 centimeter square, jet area, RA area more than 50%, vena contracta 7 or more or less similar to MR. So this is patient with a severe mitral valve disease, having severe tricuspid regurgitation and some amount of TS also. You can see non-cooptation of the tricuspid leaflets. Here what are you seeing? See, the anterior tricuspid leaflet is flail because of infective endocarditis. You can see a vegetation also causing torrential tricuspid regurgitation. This is how it is, severity is assessed. So these are the criteria for severe. We'll see some more example of severe aortic tricuspid regurgitation, dilated right-sided chambers and the IVC, and the TR, dense TR jet as we saw in mitral regurgitation and AR. And this is an interesting thing. Can you see here? The IVC actually is pulsatile. This is not respiratory variation, it is pulsatile. Then again flow reversal. Somebody was asking. This is the forward flow, and normally systolic forward flow should be more than the diastolic. Here you see from R wave till the T wave is the systole. So there is a systolic flow reversal. This is suggestive of tricuspid, severe tricuspid regurgitation. Same in the color M mode also. Color M mode helps you to assess the severity as well as the timing. You see from here to here is the systole. You have a holosystolic flow reversal of the jet. Again, AAC has given some criteria, 6 criteria to assess the severity. 4 should be there. And they have added 2 more grades. There is a new grading somewhere in some 8 years back it came. They added massive and torrential, especially when the patients are undergoing transcatheter interventions. It came down, but it was still severe. So they added massive and torrential, and it gives an incremental prognostic value also. So mainly we concentrate on the vena contracta. Up to 13 is, 7 to 13 is severe, but 14 to 20 is massive. 21 and above is torrential. So these patients, when we treated, it came down, but we still call it as severe. So they added these 2, and also it has a profound effect on the prognosis. You can see here the leaflets are wide apart, and this is a torrential TR with a vena contracta of 5 centimeters, 50 millimeters. So this you cannot compare with the severe TR of 7 to 13 millimeter. And it's very important to measure the annulus of the tricuspid valve, because this is an independent predictor of future TR. When patients are undergoing mitral valve replacement, we need to do something to the tricuspid valve if the annulus is dilated, because in future they may develop severe tricuspid regurgitation. So if the annulus is more than 40 millimeter or 21 millimeter per meter square, then they need to repair these valves. 2 slides on tricuspid stenosis. Most often it is rheumatic, and assessment is more or less similar to the mitral stenosis. Mean gradient more than 5 is suggestive of severe tricuspid stenosis. You'll see the thickened, distorted, calcified leaflets. Valve area assessment is not easy here. Pressure half time you can use, more than 190 millisecond is suggestive of severe TS. And the gradient is affected by heart rate, forward flow and respiratory cycle. This is an example of a TS. You can see the dooming, and you can see a small orifice with a turbulent flow across the tricuspid valve with a mean gradient of 8 millimeter mercury. And this, why we should know this? If you're doing a balloon valvotomy for a mitral stenosis, this also has to be addressed. And if you're doing surgical valvotomy, it needs surgical valvotomy during mitral valve surgery. So to summarize, most important is clinical assessment. As madam told initially, we have to assess how severe is the lesion clinically. Then you have to go for echo. Echo is a complementary. So they are diagnostic in most of the cases, but no single parameter is completely accurate. You have to integrate multiple parameters. Well, anatomy, chamber size, Doppler measurements, all should be used to accurate assessment. Thank you.
Thank you, ma'am. Ma'am, yesterday we were talking about that valvular heart diseases. It take around 2 years of residency, super specialty residency, to complete valvular heart diseases. Thank you for covering a brief of it in an hour. Now
1
we
hour
will.
I have taken. Sorry for that.
Yeah, ma'am, and echocardiography, we goes on learning for throughout our life, because previously what criterias were there, now they changed, now they evolved. Now everything is like evolving with, in view of AI also it is changing. Now we will go on for our live case demonstration. Only 5 volunteers are invited per case. Can you come over here? Yes, sir. Sir.
Ma'am, I am Dr. Srivastava. Some clarification requires. How?
Yes.
How often you get across the thrombus in left atria in case of mitral valve disease? Number 2, if it is a massive ball wall thrombus, how can we differentiate between a atrial myxoma and this ball wall thrombus?
So LA clot is seen in up to 40% of patients with mitral stenosis. Usually occurs in patients with atrial fibrillation, but in 5% of patients it can occur in sinus rhythm also. And LA myxoma on the left side is attached to the intraatrial septum. And in mitral stenosis, you'll see the stenosis. And the clot is freely mobile, or it may be attached to somewhere else. It is not attached to the intraatrial septum. Whenever there is mitral stenosis and there is a mass inside, the first diagnosis is clot only, sir.
Sometimes the clot is occupying the whole of the
Yes.
left atrium,
Yes.
and similarly the atrial myxoma is occupying the whole of the left atrium.
But it is always attached to the intraatrial septum. Only when it is attached to intraatrial septum, you can call it as myxoma. But MS will not be there.
MS not there. But that huge left atrial myxoma or a huge ball wall thrombus, can it produce a clinical signs of mitral stenosis?
LA myxoma can obstruct the mitral valve and can cause mimic mitral stenosis. This is one of the cause for MDM. It can hit that valve and cause MR also. That's called, both MS and MR can occur clinically.
I'll show you those cases, sir.
Okay,
In fact,
okay.
the structure is different.
Structure.
The thrombus,
Yes.
the partially organized, partially is still liquid, they can make out, and it will be mobile. Whereas in myxoma, there is a speckled appearance. Sometimes there can be hemolysis, sometimes calcification. That speckled appearance is very important. The structure will be different.
Unless it is attached to IAS, you cannot call it
Yeah.
as myxoma.
Okay. Can TEE is helpful in such cases?
No, sir, it is the same. T doesn't improve, but T improves with the left atrial appendage. Our assessment is much better with the T. Whereas the LA and RA thrombus, you know, the body thrombus, it is the same, almost same.
Thank you.
Thank you.
Thank you.
Thank you.
Any other questions? Ma'am,
Please present the case and then we'll start.
So this 33-year-old female, she's having history of progressing breathlessness since last 1 year, and now she's having breathlessness on lying down also. Along with that, she's having palpitation also on and off, and presently she is on medical therapy, and with the current treatment, her symptoms are better now. So we'll proceed with the clinical findings.
Please tell the clinical findings also.
No, I'm not talking.
Her pulse rate is 100 per minute with beat to beat irregularity. Then on clinical examination, the apex is displaced at 6th intercostal space at the anterior line. There is apex is palpable.
No,
heaving.
no, clinical findings on auscultation.
Yeah, on auscultation there is long mid-diastolic murmur at apex, and
In the tricuspid area.
yeah, at tricuspid area there is pansystolic murmur is also present. So we'll proceed with the echo findings.
What about the second sound?
Second sound is loud with loud P2, ma'am.
P2 is loud. Is it split or not split or what is it?
It splits, ma'am.
Okay. So what is your clinical diagnosis, sir?
Ma'am, I already know the like.
No, you tell the
So
clinical
there is a
diagnosis.
rheumatic heart disease with severe mitral stenosis, with pulmonary hypertension, tricuspid regurgitation with pulmonary hypertension, severe pulmonary hypertension, ma'am,
Okay.
with atrial fibrillation.
No, that's a echo diagnosis or clinical diagnosis?
Clinical, ma'am, clinical.
Okay. So let us see on echo what extra findings we get.
Steth is there?
We are seeing your beautiful sari, not the patient.
Ma'am,
Okay.
we were just
Now, yeah.
adjusting the place. 1 minute just.
Before doing any echo, clinical examination is a must for every patient because that guides you to what to look. Otherwise, eyes will not see what your mind doesn't know. So it is visualization, assessment is much better when you clinically assess. Yeah. Now, Dr. Prabhavati is showing the parasternal long axis view, and you can see that the LA is bigger than the aorta. So there is some mitral valvular disease. So you have to decide. Now, RV is dilated, probably either hypertension, pulmonary hypertension, secondary to that. And then you can see that the septal movement is something very funny. What is it?
Paradoxical septal.
Yeah, paradoxical septal movement is there. And look at the mitral valve. There is a doming and PML is restricted movement and it is thickened. Submitral structures are also thickened. Some amount of calcification is there. No pericardial effusion.
Madam, you can see the dense sec in the left atrium.
Yes.
And you can see it flowing into the LV during diastole. See that?
See there. Can you see the sec? That is the spontaneous contrast. You can see that. It is whirling. That means
Swirling in
there
the
is a
LV.
severe stenosis.
And you can see it going through the mitral valve. See that?
Yes. You can see that.
Hey, they're not showing.
And now, no, she's showing the probe, how she's keeping in the parasternal
Parasternal long axis view.
long
towards-
axis view.
Pointing towards the right shoulder.
So the knob is pointing to the shoulder.
Right shoulder, yes. Yeah, you can put the color and look for the turbulence
Yeah.
of the aortic valve.
There is a aortic regurgitation. So apart from the severe mitral stenosis, there is a aortic regurgitation. This is important because if you want to do the balloon dilatation, contraindication is severe AR. If it is a mild AR, we can still do the balloon dilatation.
But moderate AR you can still do because aortic valve.
Now we will measure the vena contracta and assess the AR also.
You can see the vena contracta there. Zoom it. Magnify. Yeah.
Sometimes mild MR, after doing the balloon dilatation, it disappears. And that is because of the non-coaptation and the stenosis. But AR will not make a change. So here it is
It looks mild to moderate.
3,
Yeah, 3.
3 millimeter. So it is between mild to moderate.
3
Yeah.
and less is mild. 3
Yeah.
to 6 is moderate, yes.
Probably it's
But-
not a contraindication.
Definitely not. But the valve per se is not looking that great.
There you can see now, vena contracta is quite narrow there.
And the
See
jet,
that is the
yeah,
portion.
jet at
Yeah,
the
there.
origin
Yeah,
is narrow.
Yeah.
Because it's a central jet, it is
Yeah.
overestimated.
Yeah, see there, that's it. So it is a mild AR. So don't go by the jet.
Yeah. So now shall we move on to the other things, madam? Is there any clot? What is that? Some artifact is coming there. Okay. So AML is dooming here. Some amount of pliability is there, but severe submitral, can you see there? So it is shortened chordae, thickened chordae, and fused.
Sometimes shortened chordae and the thickened submitral structures, you'll have to dilate it before you do the balloon dilatation. Otherwise, you may tear them and cause the severe MR.
We have
Very
done-
rarely, very rarely
No, we
you
have
to
done in
dilate.
some cases when there was entry was difficult. With a peripheral balloon, we dilated the submitral and then valve was dilated. Okay. Anything else, madam, in this view? We'll
Yeah,
go to
that's
the other
fine.
view.
I think orifice you show us and calcification and the commissures and the echo score.
Yeah. You can ask her to turn that side.
So we are making
Thoda
her to
phirna,
turn
yeah.
on left
Turn
side.
that to the left side, left
Just
lateral.
some more gel you can put.
See, when you turn to the left lateral, mitral valve can be better assessed. Even for auscultation as well as this. So she's showing the
Basal-
appendage, LA
Basal
appendage.
short
Yeah,
axis, yes.
yeah, that's the LA appendage.
There appears
So
to be
before doing the balloon dilatation, it is very important to rule out. Somebody asked about the TE. The TE is important, especially older patients, where the left atrial thrombus is better seen in the TE than the transthoracic.
You can see the
And-
dilated pulmonary artery here, suggestive of pulmonary hypertension.
And we have seen in our own hospital, our cath lab technician, he developed thromboembolism, and that's how, ruling out
It
the
looks
left
like,
atrial
but,
thrombus is very
we'll have to rule
important
out by TE.
before doing the balloon dilatation.
Yeah, maybe there is some clot. Yeah. No,
Short axis mitral valve. Is there a thrombus in the appendage?
TT is only 50% sensitive in picking up the clots.
Yes, yes.
You'll need transesophageal.
So in this case, we have to do the transesophageal to rule out the thrombus.
Go to the short
yeah,
axis.
yeah. Now this is the short axis she's showing. You can see that the classical beaded appearance is there. That string of beads, and it is irregularly thickened. And you can see that those are the beaded appearance. It's a rheumatic.
It's calcified, and you can see the
Yeah,
commissures fused.
the
Both
commissures,
commissures appear
yeah,
fused.
yeah.
And also fibrosed. Some calcific nodules are there on the
Yeah.
leaflet tips.
They're all healed nodules.
Yeah, it's a thick, at the tip it is quite thick and fibrotic. Yes. Okay. Can you put color there? Sometimes you see the flow through the commissure. You see the
You
flow
keep
through
the color compare and then measure the
You
orifice.
see the medial commissure, there is flow through the medial commissure. It is partially open. It's not completely closed, I think. Is he undergone PTMC or something? No. It's not partially fused. Okay. Go to the apex.
What's the orifice and the gradient?
The orifice you have to measure.
Orifice and the gradient.
You want to measure?
Yeah.
Orifice? Can somebody
Freeze it. Yammu.
These patients, it may be a little difficult because
Two papillary muscles. That's at the papillary level. So. Yeah.
partly
Previous one.
yeah, it came in between.
Yeah.
Yes. See, the medial commissure looks partially open.
Yeah,
partially
you can see
fused.
the calcification,
Yeah.
but not at the commissures. The commissures are free, so
It's
it
not
is still
proper.
suitable for the balloon dilatation.
Okay. Shall we go to fourth chamber?
Yeah, gradient.
I'm trying to use the same.
Anyway, between 25 to 30.
Just
it will be,
demonstrate
so
how
it
to
will-
measure the mitral wall area, ma'am, also in the short axis view.
I should go to the tip and. You see, if you go further down, you'll get the submitral structures. And see, now you see the commissures, yes. Yeah, you come from the apex.
Yeah, that's fine.
then-
Now you can
yeah,
measure.
Yes. Now you can see that. It's, in some frames, it is picking up the body.
Okay.
Yeah, it should be, yeah. Mid-diastole. Yeah, you can have the visibility.
Here it looks like the double orifice, but actually it's not double
Yeah, you can
orifice
trace it.
because of the calcium. It is looking like
You
that.
can trace it. Yeah, you can zoom it. Error will be less whenever you zoom it. It will not come when you put that. Ah, okay. Yeah. Yes, now you can see the medial commissure. Lateral is more fibrosed.
Yeah.
Medial is partially.
Actually, commissure is
go-
already split, you know, both. They're not
it's-
very.
It's not. No. No, here only this. You have to come this side. Yeah,
It's okay. It's approximately.
yeah, you come down. That is all outside the valve. This is the commissure. This is-
And
no,
here,
no,
you
no,
know,
no, come
that
here, here.
spike like calcium, you must be
You can see
prepared.
the light
The
when
balloon
you-
may rupture. You may not
Yeah,
know.
come down now. Yeah.
Because the calcification can rupture
No,
the
that is
balloon.
not valve. This is
So that's
that
why
is
there should
outside.
not be any air in the balloon.
Niche, Anna, yeah. Yes, niche. Yeah, correct. Yeah. Yeah,
So 0.5?
0.5. Yeah, this-
0.5. So it is
you
very,
can see
very
the
severe.
light. That is not the part of the valve.
Show the gradient,
See there?
apical fourth chamber and gradient.
Yeah, madness. See there?
And here,
You put the color, then you will know
Yeah.
whether there is a flow across that.
yeah, that's it.
Yeah. Yes. Anyway, it looks severe. Here there is no doubt about the severity. Yeah. See, sometimes you get severe orifice area less than 1, but the gradient will be less. What will you do? What are the situations when you get low gradients? There is some entity called low flow, low gradient MS also, like AS. When there is severe pulmonary hypertension or severe TR, forward flow is reduced, relay pressure is reduced. So then the gradient is less. And also when there is LV dysfunction, because the EDP is raised, your gradient will be less. The gradient depends on the flow across the mitral valve and the heart rate. So if the slow heart rate, 50 heart rate, you may not get high gradient. So then we exercise, the gradient goes up.
Always keep the ECG connected. Here we are not, but it's a must.
Yeah, now you can see the increase the
There is a atrial
scale, I
fibrillation.
think.
You can see that each one is different. It's a atrial fibrillation.
Yeah. So in atrial fibrillation, you will have to take at least 5.
5
On
average.
average. See here how much variation is occurring. VTA.
And since that atrial fibrillation, all the more you must suspect the
Okay.
LA appendage thrombus. And we had a doubt in the transthoracic, so before doing balloon, that is important.
9. You take another one, it will be. See here the mean gradient will be less because it's slow. Yeah, no, other one.
Next one.
Take the other beat, okay. No, I don't. These are average looking. You
Yes,
take
yes. Freeze and
first
now
or
you
second
take.
you can take, first and second.
You take 1, 2, 3 and we'll take the average.
Here it will be more mean gradient. You can see it more flat. Yeah, see how much it is.
It is 26. Okay, peak is 26. Here it will be around 30. No, I suspected between 25 to 30 and that is it.
Yeah.
Okay.
It's mean gradient more than 10
Okay.
in a heart rate of 60 to 80 is severe mitral stenosis. Is it giving?
Okay. So this is 31.
Yeah. Mean
So
is
anywhere
15,
between 25 to 30.
15, 20, 24. So somewhere around 20 it is.
Yeah.
Average, yes.
So the lesson learnt here is,
We'll see
one,
whether
there is a
mitral
haziness in the left atrial appendage. We have to do TE. There is atrial fibrillation. Always
color.
suspect
See the
thrombus.
sec, so
Otherwise,
much
your
dense
balloon dilatation will be successful and the patient will have the cerebrovascular accident and the people will blame you for it. So you must explain, put anticoagulation first, see that everything is cleared and then do the balloon dilatation. Next, because there is a calcification, you have to suspect that you may, a balloon may rupture, so you have to take care. And the third one is, you see the submitral structure, that is the so narrow and your balloon will be defamed and then don't go and dilate it. So go with the peripheral balloon and split this papillary muscle, make a way and then do the dilatation. So these are the 3 things we have learned from this case.
Yeah, we'll see the
Anything
rise.
else, Prabha?
Yeah, we'll
And this
see the-
AR is not a
Yeah,
contraindication.
you can just take the aortic gradient.
Yeah, please. Please.
Again here the aortic velocity will keep changing because of atrial fibrillation. Yes. Anyway, there is no significant aortic stenosis. Yeah. Now most important, the right side we have to assess. See the TR? First you see whether it is non-coapting leaflets. It's fairly coapting. RA is dilated. These can dilate because of TR.
Yeah, significant TR is there. If it is secondary
You
to
can
the
see the
pulmonary
vena contracta
hypertension,
there.
it will come down after balloon dilatation. If there is an organic TSTR, it may not come down. So the prognosis is poor. So here you can see there is a TS also, TR also is there.
Yeah, take the freeze it and measure. Maybe take the maximum one and exclude the hairs, pseudo hairs.
TS may be about 3 millimeters and the TR is significant.
And again you have to take the maximum, take multiple.
But anyway, we do the TE and take up for the balloon dilatation. We will explain to the relatives that what are the pros and cons and the complication. Always make it a point to talk to the relatives and explain in advance. Otherwise, they will unnecessarily blame you for no fault of yours because the disease consequences, complications are part and parcel of the disease.
Okay, one more thing here, you have to see IVC to assess the RA pressure. Put some, all our rabbit, that is funny bunny sign. What is that?
What bunny sign she was telling, no? You can see that.
Playboy bunny sign.
Yeah.
Yeah, that is the playboy bunny sign. It's higher. IVC is dilated, and again there is some sec.
And here also you can see the sec,
Yeah.
traffic jam.
Traffic jam is not too much like Bangalore.
No, it came.
Jabalpur, I didn't see morning. I was seeing no traffic only. Okay, so other thing. What is this structure? Just above the mitral valve. Yeah, freeze. What is that? What is this structure?
This one,
Yeah.
coronary sinus.
Yeah. Why is it dilated? Because of
Coronary
high
sinus is dilated.
Because of RA pressure, high RA pressure. And IVC dilates, coronary sinus also can dilate.
And don't mistake that for the primary, ostium primum AST. That is a
So
dilated
whenever
coronary
there is-
sinus.
See, RA can dilate because of AF also. Both
Yeah.
atria can dilate.
Yeah.
And this
And this is the Thebesian valve. That is the Thebesian valve. Like how you have the eustachian valve at the IVC, at the coronary sinus mouth, you have the Thebesian valve.
you see
And
it
there
is coming-
appears to be some membrane in the right atrium. We have to see from the Thebesian valve to the eustachian valve, and that is called as the divided right atrium. They are more prone for the thrombus. Yeah, yeah. Can you see that? That is the membrane. That is the membrane.
And another thing, TR can occur also because of atrial fibrillation. There is something
Yes.
called atrial TR, functional TR, atrial functional TR. So here,
And you see the
yes,
sec is so beautifully
we have seen
seen.
patients with severe, no.
Sec is very
See, in
severe.
rheumatic heart disease, it could be because of the organic involvement or pulmonary hypertension. First is pulmonary hypertension, then organic involvement of the tracheal valve, third is AF. So atrial, MR, even MR it can cause atrial MR, atrial TR, functional.
Ma'am, is there significant TS?
No, no. That is foreshortening of the mitral, submitral structure. So, yeah, because I am foreshortening. You can see the, what you ask, no TS, it's opening nicely, yes. No TS. Okay. Are
So
we
that was a nice demonstration, Prabha.
I want to see.
Big clap for the lovely case discussion.
See, we saw some paradoxical movement of the interventricular septum. If it occurs during diastole, it
Yes.
indicates volume overload of the right ventricle. If it occurs during systole, it indicates pressure overload of the right ventricle. If the pH is severe, if the PA pressure is suprasystemic, then it occurs during systole. If the volume overload of R is there, like severe TR, severe PR, or ASD, then it occurs in diastole. Yeah, yeah. You can see PR, pulmonary regurgitation you can see. Removed, Actually, you saw the dilated pulmonary artery there because of the pulmonary hypertension. When do you say it is dilated, pulmonary artery? No, yeah, one is size of the aorta, it's equal or more than aorta, or 25 centimeter, millimeters, sorry, 25 millimeter. You measure in between the valve and the bifurcation. That is an indirect evidence of pulmonary hypertension. Yeah, you can see there. See the pulmonary artery dilated? Yes, pulmonary artery is dilated. You can put the color and see is there any turbulence across. Very unlikely. We had one patient with rheumatic heart disease with pulmonary stenosis. All the 4 valves are in node. You can go up, sir. You can go up. Yeah, there is no PR, maybe mild PR. There is no turbulence. You can put a Doppler, pulse Doppler or CW, whatever it is. What is the difference between pulse and CW? Yeah. Pulse wave Doppler has only single crystal. So it emits for some time, then receives. So wherever you keep the cursor, that is the sample volume, you pick up the velocity at that particular point. That is called range resolution. Whereas continuous wave Doppler has 2 crystals. One continuously emits, other continuously receives. So it picks up the flow all along its path. So it is not specific place it picks up. So advantage is you can have high velocities also you can measure in continuous wave Doppler. Whereas in pulse wave Doppler, there is something called aliasing. It will come on the opposite direction if it crosses the Nyquist limit of around 1 to 1.5 meters.
So this patient is having significant mitral stenosis, pulmonary hypertension is secondary to left heart obstruction. Patient is in atrial fibrillation. There is dense secondary echo contrast, which is further going to progress in LA clot. Presently, we are not able to demonstrate. In TE, we can better delineate whether LA clot is there or not. So next question comes whether this patient is a better candidate for PTMC or she will be more benefited with mitral replacement, because she is already in atrial fibrillation. So anyhow, she is going to require anticoagulation for long term, and there is dense sac in LA. There may be a like
How old is she?
33 years, ma'am.
33 years. She has delivered how many babies? Has she delivered or not been delivered? See, if she is a childbearing age and she want to have delivery, you can't put the mechanical, you have to go for the biological. So instead of that, balloon dilatation can be done and then bail out, and then after she delivers, then future, depending on the condition, you can do the replacement. So don't think of the surgery right now because she's 33.
You'll have to do a TE and rule out a significant clot. If it is confined only to the appendage, you can give anticoagulation for 8 to 12 weeks, and then maybe you can do a balloon valvotomy. But it is not that favorable morphology because there is severe submitral disease and leaflet calcification is there on that leaflet tips. No, AR is not an issue here. AR is mild to moderate. No, even in
No, we
severe AR,
already
you have done.
discussed. AR is not a contraindication in
all.
this case because hardly 2 millimeter vena contracta. So don't go by the jet away at the narrow point. So that is not. But here the left atrial appendage, submitral fusion, and then the calcification. These are the things we have to explain to the relatives and then do the balloon dilatation. Because 33 years, she may require thing, no? So don't go for anticoagulation now.
Maybe we can postpone MVR for few years. You may not
For
get
by
optimal
another 10
results.
years, yeah.
No, it depends. If there is no clot, we may, actually that medial commissure is partially split. Maybe we can improve that.
You take the mic and ask the question so that all can understand what question you are
Sorry,
asking.
madam.
Yeah.
If she is not willing for another child, for balloon mitral valvulosis.
No,
or we can
even
go for-
then, so see the surgery is more difficult and costlier than this. And for 20 years afterwards, redo surgery is required, then what? So better to postpone the surgery. Always bail out with the intervention is the first option and the surgery is the last option. That should be the dictum.
Thank you very much, madam, for the
Always
clearing.
better to spare the native valve as long as possible because valve replacement is you are changing the native valve disease to the prosthetic valve disease. We have seen patients coming within 1 year, 2 years with massive clot on the valve and succumbing. Yes, not
That's a
venous,
very
clot.
good comment from both.
Because God-given valve, natural valve is much better than the prosthetic. See, they can have a pannus, they can have thrombus, they can have malfunction of the prosthetic valve. It is not spending the money or doing the surgery. See, all of us, our first goal is to give the best to the patient. Not whether it is a surgical or non-surgical. Here, the surgeons and the cardiologist, both of us, we should think what is best for the patient.
This is a very good comment, golden comment for the.
We get patients from Madhya Pradesh. Some of our students send for balloon mitral valvotomy, high-risk patients.
In this patient, ma'am, particularly like this patient is going to require anticoagulation as she is in atrial fibrillation. So still avoiding surgery will be a good option.
No, sir. Sometimes atrial fibrillation may come down once you do the balloon dilatation and LA size comes down. If in future required, they can do the reduction of the LA and also they can do the Mace surgery for the atrial fibrillation. That is in the future. But right now, at the age of 33, childbearing age, better to preserve the native valve. Yeah, Prabha.
Other thing is, after balloon valvotomy, if there is no clot, we can do a cardioversion. We can give cardioversion and bring them to sinus rhythm.
One
We
thing,
routinely do this.
one thing, ma'am, like in with novel oral anticoagulants, they are approved for non-valvular AF, and for valvular AF, warfarin is better. So, can considering the poor compliance and patients they don't follow the PTNR regularly, and the time in therapeutic range is poor. So, can we consider Novax in this subgroup of patient with presence of AF, and we suggest PTMC and followed by Novac, so that the risk of thromboembolism will also be less?
Novax are contraindicated in moderate to severe mitral stenosis. The recent study, Invictus, it showed increased.
After
But if it is
correction.
mild, maybe we can consider.
After like PTMC, if the MS
With the
regresses
VAL,
to
yeah. If
mild,
it
then
is
we can
converted
continue
to
with the
mild,
Novac.
maybe you can use. But in general, MS, we always tend to use vitamin K antagonist. Even if you relieve at the valve level, submitral disease is there. But these Novax are milder anticoagulants, so the risk of thrombosis is more because MS, AF, high risk of thrombus formation.
See, in this patient, there are 3 levels of increased obstruction. Pulmonary artery hypertension may come down, may not come down. Even if it comes down, it may be suboptimal. The valve, because of calcification, even if the commissures are open, the transvalvular gradient will be still persisting. Third, submitral fusion is there, that also will continue. So, though there is suboptimal result we are expecting, but still we'll give first preference to the intervention and the surgery to be kept at the last.
You commented, ma'am, like if we patient goes for MVR, then we are replacing the native wall disease to prosthetic wall disease. So the basis, for that interpretation is because patient requires long-term anticoagulation or like risk of stuck wall. Ma'am has told that if we are sending the patient for MVR, we are just replacing the native wall disease with a prosthetic wall disease. So, like that patient will require lifelong anticoagulation if patient undergoes the mitral replacement with metallic wall. That is the cause, or there is risk of stuck wall persistent.
Yeah, they have a high risk of struck valve. They don't take anticoagulation properly. INR monitoring is not done properly. We see every day one patient coming with valve thrombosis, and it's very difficult.
See, don't overestimate our patients. They don't comply well with the anticoagulation. They may miss and they come with the thrombus, and then it's a life-threatening one, no? And that is the reason, preserve the native valve, no anticoagulation. And as Prabha said, do the conversion of the atrial fibrillation and be happy, at least for few years. And later on we can see. So what we say is, right now, ward off what is the immediate problem, and then later on we can see. Jaan hai to jahan hai.
Thank you.
So there is a case of 51-year female who since 4 years having breathlessness, ghabrahat, chakkar, and recently had an episode of sudden fall at home with presyncopal episode and got admitted. She is a postmenopausal lady, delivered 3 children, and no any abnormality in menstruations. She has been treated for anemia frequently in last 4 years as per her, and been diagnosed as some cardiac issue. Her clinical findings will be detailed by ma'am. She was on lacetlectone, etizola, and Razor-D, Amiton, Ecosprin, and Nebicard. Previously diagnosed as acyanotic CHD, OSASD.
She is obese, so findings are not very classical. Any ECG also looks more or less normal. Axis 90 degrees, otherwise it's normal.
That is what we were talking. When we are doing these echos in our OPD, we are not getting this much clear pictures. Today machine is also supporting.
1 second. Just
Any volunteers can join here. We expect only 5 people only. Make the patient comfortable. We are taking the patient in left lateral. She has mild cough.
Because this is bedside machine. Bedside machine, it is not expected
what is,
to give this much.
madam?
picture.
Are you seeing?
Yeah, Prabha is showing the left lateral position and look at the right ventricle. You just see that right ventricle is so big. Normally you see a very small right ventricle. Here almost equal size as the LV. The RV is big and there is a pericardial effusion. Some amount of pericardial effusion is there. Very mild.
If you see posteriorly, echo free space,
Yeah.
then it is. If you see only anteriorly, it could be due to fat also.
Yeah, it could be fat.
Yeah.
Sometimes
And
the
yeah.
pericardial fat also appears like the pericardial effusion.
Yeah.
So we have to see. But there is some amount there. That space is there.
Echo free space.
Yeah.
But posteriorly we are not seeing, may not be.
Very, very minimal. We'll see afterwards. Yeah, that is the one.
Yeah.
That
we'll
could
see
be
better in the
pericardial
MR
fat
actually.
or a pericardial effusion. Let us see.
She's quite obese, likely to have
Yeah,
some fat.
maybe.
And
Huh?
no, if you see
That's why
posteriorly,
if it is posteriorly here,
echo free space is there.
then
Posteriorly,
pericardial effusion.
Yes.
This is anteriorly.
it's only anterior, it is likely to be
Pericardial
pericardial.
fat.
She's coughing also.
She's
And
obese.
striking feature is RV is dilated, as madam told. So what all comes to your mind when the RV is dilated?
One is the atrial septal defect.
Yeah.
Two, it could be pulmonary hypertension. Three,
Causing-
pulmonary stenosis. What else?
Yeah, tricuspid regurgitation, pulmonary
Yeah.
regurgitation. Yes. So pre-tricuspid shunts like AST. Yeah. Shall I go to other view?
So when you put the M mode, if it is an AST, you get the paradoxical septal movement.
You want
Prabha,
that?
put the M mode and show us the septum.
I'm navigating my.
Yeah. See, can you see that? That is the right atrium, the right ventricle. It's so very severe. So probably there's a pulmonary hypertension, we don't know what it is.
Yeah, it is RV dilatation, but we'll keep it.
Anyway, obvious thing is the RV dilatation
Mitral
and
valve
then
looks
the
normal.
epicardial fat probably.
Color is it?
Huh.
Can you put color? See, we just rule out any left-sided lesions.
Yes, we must.
Yeah, there is no mitral.
There is
aortic
no
abnormality.
AR, there is no MR.
Okay, left side looks largely normal.
See, with the normal left atrium, you can't have the pulmonary hypertension unless they have the pulmonary embolism multiple and then they have developed the pulmonary hypertension.
Okay, I'll go to 4th chamber straight.
You didn't tell us on auscultation what did you get, doctor? You skipped that part. What is your auscultatory finding? No, without auscultation, don't do the echo.
Sorry,
We did the auscultation, but we could not find any significant finding, ma'am.
But P2 is loud.
No, P2 was also not loud. She
Not
is a
that
thick
was the
chest wall and
previous
she's having
Okay,
respiratory
okay, let us
infection.
see, let us see. It's a googly. They have thrown a googly and let us see how echo can help us, you know.
Madam, they already told the diagnosis. You didn't hear, I think.
No, no, I didn't hear. They told the diagnosis, is it?
Yes.
What's the diagnosis?
We'll see whether we can make out. As we said, the first diagnosis of RV dilatation, ASD.
The first is AST, that's what I told. RARV dilated in a
Put
lady
some
like
col-
this,
there
AST
appears
is
to
the
be
first one.
There appears to be some dropout, but I'm not sure.
Where?
Unless you demonstrate color.
No,
flow
no,
across.
colored, I see, across the septum there should be color
Yeah,
flow.
I am not
Without
able
the
to see.
color flow, we cannot.
Yes.
Prabha, you do in the subcostal, maybe you'll get the good septum and then you can.
Madam, you see the patient. I can't get a subcostal.
Now, the obesity, now we have a famous endocrinologist of Jabalpur, please welcome him. And then, you know, obesity has increased by 30%. And we used to be called as the diabetic capital, now obesity capital we are becoming. So, obesity is mother of 6 deadly diseases. Diabetes, high blood pressure, high cholesterol, heart attack, Alzheimer's disease and cancer. All these 6 can occur with the obesity. So, though it is an echo conference, you must see that your patients don't become obese. Eat less, work more. That should be the motto.
Difficult to get a subcostal. Anybody wants to try, can try. You try? Yeah.
Whoever tries, the result will be the same. In obesity, the window will be very bad. So, what is the diagnosis they said? Huh? AST. I'm not convinced.
Atrial septal defect, they said. But we couldn't see any flow across the intratrial septum in 4th chamber view.
Yeah, I'm not convinced about the AST. Do the subcostal and shows the intratrial septum and put the color and show the flow across the AST. Whoever has made the AST diagnosis, come and do the echo and show the
Madam,
AST.
that was in TE, 12 millimeter only.
Okay.
I think it's okay. He's getting, there is some flow. Yeah. Yeah, there appears to be some small.
Yeah, there
good,
it is.
Good, good.
There it is. Yeah, freeze it and measure it. And I think you can do the device closure. There's no problem. Look at the rims and then we can.
They already
In
done
my
TE,
presentation, I'll show you that. Yeah, that's it.
Good.
Measure it.
Good. Hand was paining.
1 centimeter, 10 millimeter. But less than 12 millimeter, we don't close.
Here Yeah, there is some RV dilatation, maybe. Good. Very good. No, I think you take the color only.
Okay, that's all.
Yeah, just 1 centimeter.
Still 10
Okay, good.
millimeters. Still 10 millimeters.
Yes.
So it is unlikely to cause any complications,
And her symptoms are unlikely
So
to be related to
invariably,
this.
AST, they will have the atrial fibrillation, flutter, and then paradoxical embolism. All those are there. Especially obese patient, they have the deep vein thrombosis, and through the AST, it will go to the left side. So because of that, we'll have to close.
I think,
Pardon? Trans?
chance finding, incidental finding. Yes, I think so. Her symptoms are unlikely to be due to ASD.
What are her symptoms? Are they correlating? No.
Some dizziness.
I think her main complaints are because of the obesity. So good diet, good exercise, and daily Surya Namaskar and Ganpati Namaskar, and then you review her afterwards, and we'll think. So next year we'll review her.
You have high hope.
Lung function test. Sir, once you control the obesity, even breathlessness will come down, sir. So without the lifestyle modification, don't go for the functions. First, she's obese. Control the obesity. Everything will be. Sir, but that is not correlating with the AST that we are measuring. Yes, sir. We'll have to rule out. Yes. Yes.
You have to rule out any. You have to see the pulmonary artery pressure also. ASD may not be the cause of all this.
So I said it's a googly case, and it is a googly case. In spite of they telling the diagnosis, we don't accept, because 10 millimeter AST for her age is not the thing.
Cause of a symptom.
Yeah, it's odd.
Even T showed only 12 millimeter.
Correct.
And
What is the size that you got on T?
12 millimeter.
12 millimeter. So that is the borderline. So less than 12 we don't measure, close. More than 12 we close. Only indication for closing will be her future paradoxical embolism.
Ma'am, one thing more, is it a left to right shunt or right to left shunt?
Now that is a left-right
Left
shunt.
to right shunt.
Left to right shunt.
It's clear left to right shunt, yes.
Okay, okay.
Any other patient? That is Dr. Pushparaj, he got a nice subcostal view.
So 5 volunteers, next 5 volunteers can join here. One more last case. A pediatric case is there. Mashu.
Yeah, sure.
Five volunteers can join over here. It's a pediatric case.
Any dustbin is there? Hey.
Ma'am, so next case we have this 13-year-old boy. He's having exertional breathlessness since last 6 months, and there is no other significant symptom. On clinical findings, pulse is 80 per minute regular. Cardiovascular examination findings, the apex is heaving type, it is localized. Then on auscultation, there is long systolic murmur heard over apex, and it is heard all over precordium, and it's radiating up to the carotids. There is the second heart sound, A2 is loud.
No, if it is conducted to carotid, you call it as ejection systolic murmur. If you use the term long systolic, it is for the VST. So there, because you said heaving apical impulse, I take it as a aortic stenosis and not the VST. VST will have hyperdynamic and not the heaving. So this is how I interpret the clinical findings. Because we are old timers, we use the correct terms for the correct diagnosis.
This is ejection systolic murmur. No?
Ejection systolic murmur. And the peaking may be in the second half, indicating severe. And then you have to go and palpate whether there is a fourth heart sound, palpable fourth heart sound. If the palpable fourth heart sound is there above the apical impulse, that means the gradient across the aortic valve is more than 70. So even before doing the echo, we know that this is the severe aortic stenosis. This is how we correlate the clinical findings with the echo. And what is the pulse? You didn't describe the pulse. The pulsus tardus will be there if it is a aortic stenosis. Why this is important is, our echo technician had made the diagnosis of AR. The patient was referred by professor for the aortic replacement, and then the surgeon felt there is something very funny, sent back, so posted for the cath. And then my professor had taught me when I joined DM cardiology. I asked him, sir, thoda, give me tips how to be good cardiologist. Then he said, kuch nahi karna, doctor sahab. Pulse pakad ke rehna, sab aa jayega. Anyone you would have laughed, doing the DM cardiology, he would give some tips. He said, keep the fingers on the pulse. But I was a very obedient student. Any patient, first thing, feel the pulse. And then it so happened, my professor always used to make me, because I was the first lady, I was never given a chance. Aap udhar acha lagte hain, opposite side of the cath lab. He is doing the case and I have to stand opposite. And believe it or not 1, 2, 13 cases of ventricular fibrillation. Even before they used to realize and monitor used to show, the pulse used to go. I said, everyone away and give the DC shock, and saved. And then he realized the pulse is very important. And another time, this patient was put, and I felt the pulse. It was pulsus tardus. I said, ये तो aortic stenosis है, balloon को डालना था. No, this is aortic regurgitation. I said, you take bed, sir. Not even RBCs will be leaking, you just take. Because pulse is pulsus tardus, the slow rising and a plateau. And then it turned out to be aortic stenosis. So don't go by what echo technician gives the odds. Ultimately, you use your clinical acumen. Yeah, please go ahead.
Ma'am, I'll request you please see whether palpable fourth heart sound is there or not. Please see whether palpable fourth heart sound is there or not. I'm not able to find.
Okay. One second. Okay, and above that there is one more impulse, and that is the fourth heart sound. You feel whole palm, you keep it. Apical impulse is below, above Yeah. Now you can see that aorta is dilated. That is the post-stenotic dilatation. And look at the doming of the aortic valve. It's so beautifully she's showing. Now, see there? Can you see that? Freeze it, Prabha, and show that. Okay, can you see that? This is doming. See that? This is the aorta. Yeah, that is the doming. And that indicates that it is a aortic stenosis. And look at that here at the annulus. And above that, Prabha, when she presented, she showed the, see, this is the dilatation. Because the aortic stenotic jet goes and hits and the aorta is dilated.
It is the tubular part of ascending aorta. Sinus
Yes.
is not dilated.
Yes.
So that is why you have to trace the aorta distal to the ST junction.
And you freeze it and show them how to measure the annulus. Annulus must be measured in systole or diastole?
Mid systole is already told, yeah. How will you
Yeah.
know? Systole?
No, I was asking them.
Okay.
Okay.
Yeah. ECG gating is useful, but here.
And he's a young boy. Don't go think of the surgery. First we'll do the balloon dilatation, postpone the surgery. And invariably these small children, they will have the annulus less. And don't think of the aortic valve replacement. Do the balloon dilatation.
It's approximately middle systole.
Press again and then, yeah, now you can measure. Why it's not coming?
Yeah, it's come. No, not
No,
there.
no.
Yeah.
Okay.
Maybe you're overestimating also.
No, you overestimated. It is not 21. It may be 18 or 19. See, you
Where the
measure
leaflet
from
is
there.
attached.
Measure from there.
Yeah, correct, yeah.
And here, till there. Yeah. See, it's
around
17.
17, yeah.
For a small child, you can't get 21. That's
Okay. So,
and then you measure the LVOT and measure this portion. Freeze it. Measure the aorta. Yeah, from there till there.
no, aorta is measured in end diastole.
Yes.
Ideally, you should have the ECG, and R wave corresponds to the end diastole. Yeah, when its valve is closed before it opens, that is end diastole, yes. Just before it opens, yeah. Yeah, okay. So you can, yeah, they say it's leading edge to leading edge.
From here till here.
No.
No, the aorta.
Yeah, this is the sinus, what you are measuring. Sinus of Valsalva, one more.
And measuring the perfect
This is the
annulus is
sinus.
very, very important.
This is the sinus.
Because for balloon dilatation, only 100% of annulus is taken. By chance, you measure 21 and you take 20
Actually,
balloon,
ST junction is effaced.
the patient will collapse on the table
leading edge
because
is
that
anterior to
dilated balloon will block the coronary ostia and there can be asystole and the death. So this is how echo is so important to get the good result and not to have complications. It's very important. And where to measure, how to measure has to be learned
Actually,
perfectly.
junction is effaced. Okay. Actually, normally sinus is bigger, then the junction is narrow, then the ascending aorta comes. Here it is uniformly dilated.
Sometimes after dilatation, this post-stenotic dilatation also will come down. So he's a young boy and the recovery is very good in children.
Actually, they were already balloon dilated.
Remember,
once, right?
this doming is very classical of aortic stenosis.
Once balloon dilatation done, I believe.
Well, that's why it may be for the second time. Show in the short axis whether it is a bicuspid or the
21.
tricuspid.
21 they have done, madam.
Yeah. Okay.
2021 balloon plastic
Okay.
is done.
Let us see how much. You look
Wow.
at that. Can you see that?
So
Only raphe is
beautiful.
there, single raphe is there. It's a unicuspid. See, this is so beautiful. This is a single raphe is there. Very nice. And that is the coronary, right coronary there. And that is the left coronary. See that? So beautifully it is shown.
This looks like
And whoever has done balloon dilatation, don't think that it is under dilated. It is because of the unicuspid, you don't get the good result. If 3 cusps are there and the commissures are split, you get the good result. So this is the problem with the anatomy, not with the operator. बहुत सुंदर आ गया. Very beautiful. See the right coronary, left coronary seen, and see the opening, single cusp, and that is the only one raphe. There is nothing there, no commissures anywhere else. Now gradient, show the gradient, Prabha. Very nice. Unicuspid, I have done hydros fetalis, who was previous case that she had a stillbirth. The second baby, cesarean section done, the baby did not cry. So they put on ventilator and they shifted the patient to me. And then it was a pinpoint aortic stenosis. I did the balloon dilatation with the PTCA 4 millimeter balloon and it opened. Within 24 hours, all the edema fluid went off and the child became so slim and out of the ventilator. And at that time when I presented, Madam Savitri Srivastava and others, they started saying, how could you do it? And Dr. Claire said, I wish I had a daughter like you. Because, you need a courage to do such things, but, you can literally save the child from dying. And that is the beauty of intervention. Prabha, gradient torsi. So she will go into apical 5-chamber view and then measure the gradient. Earlier we used to get the knob, suprasternal, we used to keep the knob and measure the aortic stenosis. Yeah, very nice. Adjust the TGC and get a better pay. Oh yes, that's it. Now you put the color.
Hey, don't move. No, it's okay. I don't want mic. Madam will explain. No, I don't need.
Increase the TGC. We are not seeing the ventricle. Okay, put the probe, the cursor. No, it's not, alignment is not on. How much gradient you had got earlier? So since balloon dilatation is done, we may not have much gradient. And this person, every year, this child, every year they have to do the echo to find out whether there is increase in the gradient. Only when it crosses 60 or 70, then you have to go for the balloon dilatation again. Yeah. The first one was, that's good. Yeah, you can see. Measure that. I think for the unicuspid, whatever balloon dilatation has been done is good enough. and let us see how much the gradient is. And SBA prophylaxis is a must. Yeah, that's enough. You're going beyond. Okay. Overestimating. 82? 82 gradient? Huh? Yeah, now it is better. Yeah, put the cursor. Okay, pull it. Okay. And since it is an eccentric jet, your cursor may not align and you may not get the good. Yeah, take the cursor on that side and. No. How much gradient you have got earlier? 51. So just SB prophylaxis, observe the child. And any dental treatment or anything, you have to be very, very careful. Avoid any infection because bacterial endocarditis, when it is super added, it will cause AR. So along with AS, we'll get the AR. So I think whatever result they have got is good. That is good enough. But that was a very beautiful demonstration of Unicus Spade Prabha. Very nice. And whoever has done the balloon dilatation has done in an excellent way. Who's the doctor? Huh? Dr. Claire? Huh? Uma Maheshwari. Okay. Where is he? Where is he? Huh?
Not came, he will come.
He has not come. Okay. Anyway, congratulate him. That is good. Yeah. The first one. Or second one, rather. The measure it. Okay, that's it.
Yeah, we got it more than 4 meters, suggestive of severe aortic stenosis now. Yeah, he has a long.
Yeah, no, not okay. You are overestimating. Anyway, it's okay. 87?
87 by 54.
Yeah.
You can measure the other one also. It is severe.
It's okay. They are overestimated. It is around 70, 80. Because the fourth sound is palpable, I said it is more than 70 clinically. So it is definitely more than 70. So when we correlate clinical finding of the palpable fourth sound and this, it is above 70. So any time the redo balloon dilatation can be done. So it is not 50 like it was said. It is not 50. The presence of S4 and this gradient indicate that it is a thing. And it should be explained that they are not going to get excellent result. It will be suboptimal result, but LV hypertrophy and the chest pain and the sudden death can be avoided by doing the dilatation.
In this also we have to calculate from that the chin or beard jaisa aapne kaha.
Yeah, same thing. Yeah, this. Yes.
Okay. Yes.
You have to. Here it is not there actually. Here it's the entire thing is CW.
Yes.
Yeah. There is no beard. It is.
Okay.
But sometimes you get some lines, parallel lines. So then you have to take only the dense part, not those lines. They call it the pseudo hair or.
Okay.
Yeah. Here it is not there.
Yes,
it is clear. Okay. There is a nice ejection click. Disappeared. Finished?
Yes.
Okay, bye.
it is. It is a moment of pride and privilege to formally inaugurate ECHO Jabalpur 2026. To begin with, may I request our esteemed dignitaries to kindly come on the dais as we formally commence the proceedings. I further hand over this conference stands as a celebration of learning, collaboration, and clinical excellence in echocardiography, bringing together strong fundamentals, evolving advances, and real-world practice. On behalf of the organizing committee, we are deeply grateful to our distinguished faculty for sharing their expertise and to all our delegates for joining us in this meaningful academic exchange. I further hand over the mic to Dr. Kaveri ma'am and Dr. Archana Thakur ma'am.
Thank you, Kaushiki. So this is, I think, very good and learning morning of this Sunday. We have learned a lot of things today. And I think being gynecs, we both are gynecs and wives of our cardiologist husbands. Myself, Dr. Kaveri Shaw Patel, and my colleague,
Dr. Archana Thakur.
we are better half of our cardiologists who are doing very good in Jabalpur, and they both are doing good because we somewhere feel that we are also learning cardiology from them. So there are, again, the women's are leading the day of today. After seeing this memorable day, I can understand the cardiologist is very easy if you have a very good teacher. So congratulate to Dr. Vijayalakshmi madam and Dr. Prabhavati madam who has come over here and enlightened us with so much thoughtful knowledges in field of echocardiography. I would like to say this is the second annual conference of echocardiography in Jabalpur, which has been headed by Golden Heart Hospital and Heart Research Association Society of Jabalpur. Without wasting much of time, I would like to call our dignitaries for this formal inauguration, and I request them to be seated over here. Our today's teacher, the pioneer, Dr. I.B. Vijayalakshmi madam, kindly join us on the dais. Dr. Vijayalakshmi madam is a distinguished cardiologist and specialist in pediatric cardiology. She has contributed in India's premier heart institute. She has served as the first woman head of the Department of Pediatric Cardiology at Sri Jayadeva Institute of Cardiovascular Sciences and Research Institute, Bangalore, and is now working as Professor Emeritus. Her expertise is particularly in congenital heart defects, which we learned today. Educationally, Madam has received degree of MBBS, MD in General Medicine, DM Cardiology, and won the K.S. Sadaksharappa Gold Medal Award in first position in Bangalore University in MD. She has earned more than 40 gold medals and has been a researcher in hundreds of research papers. Lot of cardiologists are under her taking their degrees. Her specialization is in congenital heart disease. And morning, I just told you that even Mayo Clinic and European societies all are getting references from her papers. Our second teacher of the day is Dr. Prabhavati Madam. Madam has already been seated here. Prabhavati Bhatt Madam. She is also highly distinguished and senior cardiologist of India, working as HOD in Sri Jayadeva Institute of Cardiovascular Science Research Center, Bengaluru, and Dr. Prabhavati has expertise in interventional cardiology, and her major workspace has been in the diagnosis of complex cardiovascular diseases like ventricular fibrillation, aortic valve replacements, arterial hypertension. She also has more than 67 publications on her name, has name in national international books. She has been fellow of Indian Cardiology, College of Cardiology, Indian International Associate Member of American Cardiology, and International Fellow of European Society of Cardiology. Her one of the keen part is she gives free medical services in her village, in her native place, Kota near Mangaluru. And she has been an inspirational scholarly person to all of us. The next person on the dais is Dean of NCB Medical College, Dr. Navneet Saxena sir. Sir, welcome over here.
Good afternoon, sir. Dr. Navneet Saxena sir is a distinguished senior ophthalmologist from Madhya Pradesh, a veteran teacher and a skilled administrator. He is currently working as a professor and dean at Netaji Subhash Chandra Bose Medical College, Jabalpur. His contribution in all these three areas, medical education, clinical service, and institutional leadership, has been extremely significant. Overall, Dr. Navneet Saxena sir is a dedicated physician, inspirational teacher, and visionary administrator, whose contribution is immensely valuable not only for Jabalpur, but also for the medical education and eye care services of the Madhya Pradesh. I welcome you, sir.
The next person on the dais is our CMHO, Dr. Sanjay Mishra sir, who is being teacher for all of us and is having very much good contribution in providing us the permissions and all for this wonderful conference. We are welcoming Dr. Sanjay Mishra sir.
Our next guest is Dr. B.M. Sarnagat sir, and sir is fellow in critical care medicine and American certificate. He got American certificate in echocardiography, and sir is currently elected unanimously as state president of IMA Madhya Pradesh. I welcome you, sir.
We are happy to announce that we have IMA president, past president, Dr. Sangeeta Srivastava madam, who has given her services in the gynecology, but being IMA president, she has Sangeeta Srivastava. Ma'am, she is also gynecologist. So we actually feel saying gynecologist. So she has also organized many conferences at a state level, and we welcome you, ma'am, because one of the most wonderful conference by IMA was in her presidential say.
Our next guest is Dr. Richa Sharma, ma'am. Next guest is Dr. Richa Sharma, ma'am, and she is IMA president. And our Jabalpur IMA is
blessed that madam, being ophthalmologist and holding the position as deputy superintendent in NCB Medical College, is now as a IMA president. I think she is second or third IMA female president, and she has been awarded with a President's Appreciation Award from IMA MP in annual state Conference 2025. Also, she has received award of Shri Shushruta Award and Fellowship in IMA AMS, and working in the MP projects Shakti of Women Ophthalmologic Society, supported by AIOS. That is the great thing, because for women, a woman is again there. So welcome you, ma'am. So I request Dr. Anjane Mishra to welcome Dr. Anjane Mishra, Dr. Anivesh Jain. Kindly welcome our guest, floral welcome of the guest. Dr. Anjane Mishra is the organizing secretary of this today's Eco Conference, and Dr. Anivesh Jain, he is the secretary of Heart Research Association. And the man behind the show, Dr. Pushpraj Patel, I think Madam Richa ma'am told me that you have to introduce him, so I just know he is the man with lot of dreams, with silence, and his silence works. And that is the great thing which we all can see today in this echocardiology workshop is a success in this era, because this is the thing all the physicians wants to do, but because of busy schedule, they couldn't find time to get these small tricks and tips, and we are getting it on this day with two eminent professors. Congratulations, Dr. Pushpraj, for holding this Eco Conference.
Now I invite Dr. Anivesh sir to felicitate Navneet Saxena sir.
Sanjay Mishra sir. As the dais is now full with all dignitaries, I request all the dignitaries to come over here to start the formal lamp lighting. Ma Saraswati, the goddess who is giving all this knowledge today, I think we should worship her. I request everybody to join for lamp lighting.
शंकर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा हस्ते
as this is, I think, first visit of both the teachers. So I am very much thankful on behalf of Golden Heart and Heart Research Institute, Heart Research Association. I request Dr. I.B. Vijayalakshmi Madam to just give few words about today's conference. Okay. So I request Dr. Navneet Saxena sir, Dean Medical College, uh, who is our teacher. And I think today's this workshop really gives us lot of things, lot of knowledge, and that is a dean can address better than all of us. Please.
Good afternoon, everyone. It's really being pleasure being sandwiched between two stalwarts cardiologists of the India. She was telling me. So dignitaries on the dais, Dr. Sanjay, Dr. Richa, Dr. Chandrakar, Sangeeta Madam, and Pushparaj, and all my senior colleagues, and all the delegates. I want to share just one experience of mine. The cordial, as a matter of fact, in all the yes, okay. As the development and the of in all subjects, similarly in cardiology, and gone are those days where we have to rush to the metro for the treatment. I remember when I was a student in 1980. So there was a problem of my some relative, and then we have to go to the Mumbai, and a very famous surgeon, he operated him, right? So now that all those facilities which has been there previously in the metro, now it has come to city like Jabalpur. And thanks to Pushparaj, he is doing wonderful. And thanks to Kaveri, where is Kaveri? And I am proud to be teacher of them, both of them. So that's wonderful job. And now that it is, in fact, the cardiology has become so easy and so, you can say, quick that a person can get relief in a second also. Just do the job and job is done. So I congratulate all this, the Kaveri and Pushparaj for being me here, calling me here. And thank you very much. All the way, success, congratulations, and all the best.
Thank you so much, sir. I request, Dr. Vijayalakshmi Madam to address the audience.
Om Shri Gurubhyo Namaha. You know, it's such a wonderful day in Jabalpur. It's not the number of people, but the number of people who are dedicated, concentrated, and they want to give better quality of treatment to the patients, and they are gathered here. So I would like to congratulate you all through this Golden Heart thing, that you have arranged such a beautiful program. And I also liked because we worshipped Ma Saraswati and lighted the lamp. Just recently we had Vasanta Panchami, which is the Jayanti or birthday of Ma Saraswati. And then we lighted the lamp. Why do we light the lamp when there is so much of light around? Has anyone thought of it? Especially lighting the lamp is important for all, especially for the doctors, because the oil in that, it indicates the ego of the person, ahankar. And the wick indicates the ignorance. So every doctor should see that their ahankar is taken away, the ignorance goes off, and Sudnyan ka deep we have to spread. And that Sudnyan that we are spreading through this workshop on the echocardiography. As sir said, there was a time when clinical examination was ultimate, but now echo has come like, it is like kalasha over the temple. So we are worshipping every patient coming to us is like a god. And that ultimately, to give best, we do that. And for this, I would like to quote that it is said, Ano Bhadraha Kratavo Yantu Vishwataha, which means that let the noble thoughts come from all over in all the directions, and we must implement that. And we don't have to go to Mumbai, we don't have to go to Madras, we have to see that our doctors are doing the best and we give the best to the patients. And that should be the one. And hence, it encourages open mind to learn the right things, and the doctors never cease to learn. We continue to learn. And one thing peculiar about doctors is we never become ex-doctors. We continue to be doctors till the dying day. And that's how we know we are. And among all the professions, the doctor's profession is the noblest profession. Abdul Kalam ji said, teacher's profession is noble. Of course, teachers, they make the personality development and the citizens are better. But unless the health is there, nothing is useful. So ultimately, health is the most important, and hence the doctors should always upgrade their knowledge so that the best can be given. And I would like to congratulate the organizers, and especially myself. You look at the dais, 4 men and 4 women. 50% is given to us, and that is a great thing. I think I have to congratulate the Jabalpur people, you are ahead of even the government. They give only 30%. You have given 50% to us. And the course director and co-director, both women. And that means, So I personally thank you and give a big clap for the organizers. And last but not the least, why should we clap? We have 39 acupressure points. The harder you clap, the 39 organs get more oxygen, pranavayu and poshani. And the energy increases because 60 trillion cells in our body get energized. And when you clap, your face is beaming with smile. There is no negativity, there is no, jealousy. And that is the one, which makes the feel-good hormones release from the brain. Your blood pressure comes down, blood sugar comes down, and then you become very happy, and you are giving encouragement to the organizers. At the same time, you are getting good health without spending money. So let us see how well you clap for the organizers. So now Jabalpur doctors are very healthy, very happy, no jealousy, no ahankar, and no ignorance. And I congratulate each one of you. And I feel God has to give Arogya, Ayushu, Sampattu, Samruddhi, Nemmadi, Yashassu, Tejasu, Varchasu, Ojas, and everything. So the Jabalpur Medical College, as well as the people getting graduated from here, they have made great contributions, sir. I have met them personally. So I congratulate all the Jabalpur people and all the doctors who have come here and not come. And the cases were excellent, and the discussions, were very nice. And I hope whatever you are learning, it will go a long way, and it will be an inspiring day for all of you. Thank you very much. God bless you all. Thank you.
Thank you so much, ma'am. And today we really learned the Deep Prajwalan has of what such a nice meaning as well. And I would like to comment that there is not only from Jabalpur, we have people from Gwalior, Hoshangabad, Narsinghpur, Katni, lot of nearby district also. Almost half of MP representative doctors are over here other than Jabalpur's. Now I request Dr. Prabhavati madam. Madam, few words, because other than teaching, we just want to know your experience coming over Jabalpur, and how you like this conference.
Good afternoon, everybody. I am very happy to be here, and Dr. Pushparaj and his team has done a wonderful work. I am enjoying each moment here, learning, teaching, everything is going on very well, and I think others are also happy. Are you happy? Oh, that's nice. Okay, I congratulate you, thank you, and I'm very, very happy to be here. Thank you very much for the invitation. God bless you all.
Thank you so much, ma'am. Now I request, short and sweet, yeah. Now I request our state president, Dr. DM Sarnagas sir, because he has joined here far away from Jabalpur, and he is attending since morning. How did he find this eco conference?
Good evening to everyone. Respected डायस पे बैठे हुए डीन डॉक्टर सक्सेना और ऐसे वंडरफुल टीचर्स, काश हमारे समय होते तो आज हम कहाँ होते। मैडम विजयलक्ष्मी मैडम, मैडम प्रभावती मैडम, मेरे फ्रेंड डॉक्टर संजय मिश्रा, जबलपुर के स्टेट प्रेसिडेंट डॉक्टर ऋचा शर्मा, मैडम श्रीवास्तव, और जिस प्रोग्राम को ऑर्गेनाइज किया है, जिनके लिए 2 शब्द ये है, डॉक्टर पुष्पराज पटेल। जैसे हार्ट के वाल होते हैं ना, वेरी सॉफ्ट, और किसी को डैमेज नहीं करता है, वैसे वेरी सॉफ्ट पर्सन, उनके लिए 2 वर्ड ये है। पुष्पराज के लिए 2 शब्द कहना चाहूँगा कि वो ऐसी पर्सनालिटी हैं जो बहुत सॉफ्ट हैं, और उनके बारे में कहना चाहूँगा कि इतना सा महको, ये मेरी आरजू नहीं है, तमन्ना है कि मेरे किरदार से खुशबू आए। तो ये वैसे बंदे हैं जिनके किरदार से हमेशा खुशबू आती है। जबलपुर से ऐसी जगह में जहाँ पे नियर बाय जो महाराष्ट्र के नागपुर वगैरह हैं, जिन्होंने बीच में जबलपुर को, रीवा को, सागर को, सबको एक स्नैच कर लिया था, वहाँ पे इन्होंने एक अपना कार्डिक सेटअप में प्रादुर्भाव किया है। मैनी थैंक्स टू डॉक्टर पुष्पराज पटेल। और पुष्पराज पटेल के बारे में एक मैं कहना चाहूँगा कि जब मैंने IIM कॉन बालाघाट में करवाई थी, तो ही इज़ द फर्स्ट पर्सन टू कम देयर एंड ही डिलीवर्ड अ वेरी नाइस टॉक ओवर द सडन कार्डियक डेथ इन कोविड ईरा, जो आजकल हम सुनते आ रहे हैं। उसमें इतनी अच्छी टॉक दी थी कि एवरीबॉडी हैज़ एप्रिशिएटेड, एंड थैंक यू वेरी मच डॉक्टर अजय मिश्रा, कावेरी एंड होल टीम। जो आपने जैसे मोबाइल में सीखो ऐप आता है, आपने सीखो इको ऐप ला लीजिए। मैं आपको बहुत बहुत धन्यवाद। थैंक यू वेरी मच, सो काइंड ऑफ यू।
Thank you, sir. I request CMHO Dr. Sanjay Mishra, sir, to give his word of wisdom.
सम्मानीय मंच, मेरे सभी सीनियर्स, मेरे जूनियर्स, डॉक्टर पुष्पराज के बारे में काफ़ी बात हो रही है। निश्चित रूप से एक टीचर के लिए सबसे बड़े गर्व की बात ये होती है कि जब उसका कोई शिष्य ऐसे मुकाम पर पहुंचता है जहां सभी लोग उसकी तारीफ़ करते हैं, उसके सिर्फ उसकी तारीफ़ नहीं, उसके काम की तारीफ़ करते हैं। मुझे वो समय याद आता है जब PMT की क्लास में पुष्पराज हमारी बैठा करते थे, शांत स्वभाव के, बहुत मुश्किल से ही बात करते थे। अभी भी स्वभाव बहुत बदला नहीं है, क्योंकि इस ऊंचाइयों पर वो पहुंच चुके हैं। एक बहुत अच्छी यहाँ डिस्कशन ऑर्गेनाइज़ की डॉक्टर पुष्पराज ने, पूरी मेहनत के साथ, उनके साथ में डॉक्टर कावेरी। बड़ा अच्छा लगता है देख के कि दोनों मिलकर जब काम करते हैं। और सबसे बड़ी बात यह है कि कावेरी ने मंच को बिल्कुल बैलेंस करके रखा है, एक गायनेकोलॉजिस्ट को भी बैठा के रखा है इसमें इको में तो एक बहुत बड़ी बात है। सबका ध्यान रखना, सबसे अच्छे से पेश आना, और मैं बहुत शुभकामनाएं देता हूं कि आगे भी इस तरह की कॉन्फ्रेंसेज आप करते रहेंगे। यहाँ जितने भी डॉक्टर्स उपस्थित हैं, CMHO में एक सेंटेंस भर बोलना चाहता हूँ जो मैं देख रहा हूँ आजकल, कि जितने लोग भी अपनी क्लिनिक या हॉस्पिटल रन कर रहे हैं, वो अपने हॉस्पिटल और क्लिनिक का ऑफिशियल रजिस्ट्रेशन ज़रूर करा लें। ये बहुत ज़रूरी है, क्योंकि जब भी कुछ मिसहैप होता है तो सिर्फ यही चीज़ हमारे विरोध में चली जाती है कि आपकी क्लिनिक रजिस्टर्ड नहीं है, उसके बाद भी आप मरीजों का इलाज कर रहे हैं। और बड़े दुख की बात ये भी है कि हमारे बहुत सीनियर डॉक्टर्स जो जबलपुर में प्रैक्टिस कर रहे हैं, उनकी क्लिनिक भी रजिस्टर्ड नहीं है। मतलब मोस्ट सीनियर मोस्ट बोलूँ मैं, और हम लोग बार बार उनको ये मैसेज देते हैं, और हम मेरे रहते हुए कम से कम उनके रजिस्ट्रेशन में कोई समस्या नहीं आएगी, ये तो मैं सर वर्ड्स दे सकता हूँ, नहीं भी आ रही है सर। और लेकिन प्लीज़ थोड़ा सा इसका ध्यान रखें, आजकल नियम बहुत सख्त हो गए हैं, पेशेंट बहुत सेंसिटिव हो गए हैं, समझदार हो गए हैं, वो हमारी हर बात को पकड़ते हैं, और वो मैं देख रहा हूँ। क्योंकि एक CMHO की स्थिति वो होती है जैसे एक फुटबॉल टीम में गोलकीपर होता है, सबके खेल को देखता रहता है वो, कि कौन क्या कर रहा है, कौन क्या, क्योंकि हम लोगों के पास इस तरह से सूचनाएं आती हैं। और मेरा सभी को बड़ा हमेशा सहयोग रहेगा, सभी को शुभकामनाएं, और मुझे यहाँ बुलाया पुष्पराज, डॉक्टर कावेरी, बहुत बहुत धन्यवाद आप।
Thank you so much, sir. Now I request our past president, Dr. Sangeeta Srivastava, madam, one of the backbone for our motivation.
Good afternoon, everybody. My special thanks for all the dignitaries for coming such a long way from Bangalore and everywhere, and Pushparaj for inviting such big dignitaries from all over the country for this wonderful workshop on eco. And I'm so happy to see so many people attending and so many registrations done. And Madam has spoken so well. She must be one of the best gynecologists in the city, but she is such a learned person. She spoke everything about, except leaving cardiology. You must be learning cardiology from morning till evening, but she spoke on what is the importance of igniting the lamp and why we should clap. I really did not know that it had so much of significance. And I think I'm the only person in all conferences and everywhere. I clap so hard. I'm so happy that I clap so hard. Today I'm so happy that clapping gives us so much of advantage. It stimulates 39 acupressure points, and we should know every point, significance of everything which we are doing, and Madam has enlightened us so much. And I thank everybody for being here for this wonderful workshop. As a part of Jabalpur IMA and IMA AMS, I once again invite you all, please enjoy the day and try to take as much as knowledge from these dignitaries. Thank you so much.
Now I request our President of Jabalpur IMA, Dr. Richa Sharma Madam, who is witness of today's conference and going to conduct the conference in this February only, Ethicon on 21st and 22nd. I request Madam address the session and also just brief out the Ethicon as well.
सादर प्रणाम। मंच पर उपस्थित आदरणीय डीन सक्सेना सर, डॉक्टर विजयलक्ष्मी मैडम, डॉक्टर प्रभावती मैडम, IMA स्टेट प्रेसिडेंट डॉक्टर शरणागत सर, रीजनल डायरेक्टर हेल्थ डॉक्टर संजय मिश्रा सर, डॉक्टर संगीता श्रीवास्तव मैडम, ऑर्गेनाइजर्स डॉक्टर पुष्पराज, डॉक्टर कावेरी टीम, एंड उपस्थित सभागार में उपस्थित समस्त डॉक्टर्स जो न केवल जबलपुर बल्कि जबलपुर से बाहर से भी आए हुए, आज की इस कॉन्फ्रेंस में सभी लाभान्वित हुए हैं। मैं भी समय से कुछ पहले आ गई थी, तो मैंने भी सेशन सुने, लाइव इको सेशंस देखे, एंड जब मैं दूसरी स्पेशलिटी के होकर इतनी बेनिफिटेड फील कर रही हूँ, तो मुझे बिल्कुल पूर्ण विश्वास है कि आप सभी ने भी पूरा लाभ उठाया होगा, हमारे इतने लर्नेड टीचर्स जो आज आए हुए हैं, एंड आई एम रियली ऑनर्ड टू शेयर द स्टेज विद यू। IMA जबलपुर की तरफ से मैं सभी ऑर्गेनाइजर्स का और उपस्थित सभागार में सभी डॉक्टर्स का हृदय से अभिनंदन करती हूँ, और मुझे पूरा विश्वास है कि आप सब सुबह से लेकर शाम तक के सेशंस में पूरा लाभ उठाएंगे। आगे आने वाली एथिक्स कॉन्फ्रेंस, जिसके डॉक्टर पुष्पराज भी इज़ वन ऑफ द ऑर्गेनाइजिंग सेक्रेटरी एंड कावेरी इज़ अ जॉइंट सेक्रेटरी, हम सभी को आमंत्रित करते हैं 21 एंड 22 फरवरी के लिए। और पुनः मैं मुझे आमंत्रित करने के लिए पुष्पराज एंड टीम को बहुत बहुत धन्यवाद देती हूँ। थैंक यू वेरी मच।
Thank you, ma'am. Now I request Dr. Pushpraj, whose brainchild was this conference. Then this is the second one. Just
Respected dignitaries, आज हमको जो सौभाग्य मिला है विजय लक्ष्मी मैम, जिनको मतलब जब मैं स्टूडेंट था और मैम के लेक्चर्स रहते थे तो हम लोग खड़े होकर सुनते थे। बुक्स आती मैडम के, जो क्राइटेरिया मैम ने लिखे हैं, जो हम पढ़ते हैं। प्रभावती मैम जैसा अभी भी डिस्कशन के दौरान आप लोगों ने देखा होगा कि मैम पूछ रही थी ये क्या है, ये क्या साइन बोलते हैं, जो मतलब स्टूडेंट डेज की याद आ गई कि ये बता दिया तभी पास हो पाओगे। तो सेम फीलिंग। और विजय लक्ष्मी मैम ने जैसा कि नहीं, पहले क्लिनिकल एग्जामिनेशन बताओ देन यू कैन प्रेजेंट द इको फाइंडिंग्स। तो एक बहुत बड़ी बात है, मैडम की कल फ्लाइट छूट गई, उसके बाद भी दूसरी फ्लाइट कनेक्टिंग फ्लाइट ली, फिर इंदौर गए, वहाँ से यहाँ आए। तो इतना हम लोग देख सकते हैं, इतना डेडिकेशन है मैम का। टाइम से पहले पहुँच गए, उसके इतना थकने के बाद भी कहीं पे भी ऐसा नहीं लग रहा कि थक गए, रात भर प्रॉपरली रेस्ट नहीं कर पाए। लेकिन जो एक एंथुजियाज्म oh my God. So we are blessed to have you मैम here। और जो एक हम लोग प्रैक्टिस में आने के बाद यूजुअली एकेडमिक्स से थोड़ा साथ छूटता जाता है। कुछ चीज़ें जो बुक्स में हमने पढ़ी हैं पहले और प्रैक्टिस में आने के बाद मिस होती रहती, तो वो चीज़ों को एक बार फिर से दोहराना है, याद करना, यही उद्देश्य है इस कॉन्फ्रेंस का। ताकि हम जो छोटे छोटे से पॉइंट्स, जैसा कि सक्सेना सर ने भी कहा कि कंटिन्यूड मेडिकल एजुकेशन ज़रूरी है, सब अपने नॉलेज को रीशेप करते रहें, रीब्रश करते रहें। और विजय लक्ष्मी मैम ने बताया कि डॉक्टर्स आर नेवर एक्स डॉक्टर्स, तो हमेशा क्या नया डेवलपमेंट हो रहा है वी शुड बी नोइंग। और देन ओनली जो एक सबका उद्देश्य है यहाँ पे कि अपने पेशेंट्स को और बेटर सर्व कर सकें और क्या कुछ छूटे ना, तो उसी उद्देश्य को पूरा करने के लिए कॉन्फ्रेंस की गई। और आई एम वेरी हैप्पी कि इतने बड़ी संख्या में लोग आए पूरे एमपी से, तो एवरीवन इज बेनिफिटेड। थैंक यू ऑल।
Thank you so much. And without wasting much time, I request Dr. Pushpraj and Dr. Anjane, Dr. Anivesh, Dr. Animesh Gupta, felicitate our today's teachers, Dr. IB Vijayalakshmi Madam, with a token of memento. These are small memories from our Jabalpur. This is the beautiful scenery of Bhedaghat. This is river Narmada. You are staying near Kaveri. This is Narmada. We are gifting you. Dr. Prabhavati Madam, yeah, please. Archana, come here. I request the team to honor our dais as well. Dr. Navneet Saxena sir. Please give the memento. Dr. Navneet Saxena sir, Dean Medical College, Jabalpur. I request Dr. V.K. Bharadwaj sir to felicitate our Dean. Dr. Sachin, kindly come here and honor Dr. Sharnagat sir. Dr. Sachin is our cardiologist. He is from Pune and he is with us in Golden Heart team. Dr. Rahul, kindly felicitate Dr. Sangeeta Srivastav madam. He is also cardiologist with Dr. Pushpraj. Dr. Pushpraj, please felicitate Dr. Sanjay Mishra sir. Dr. Anivesh Jain, kindly felicitate Dr. Richa Sharma madam. Dr. Chavi, kindly felicitate Dr. Archana. I request Dr. Sanjay Kenema sir. मेरे लिए सर.
I request Dr. Hansh sir to felicitate Dr. Kaveri ma'am, who is a part of a committee and gave a shape to this event.
And I request Dias to be here because we have award of community services for the doctors who are regularly giving services in the society and helping it. We will just name them and please join a little faster because we have to finish it off.
May I have the honor to call Dr. Ajay Bhandari sir, Dr. Sanjay K. Nema sir, Dr. Raj.
Meanwhile, Dr. Anjane. Dr. Anjane Mishra. Dr. Anivesh Jain. Dr. Anjane Mishra, please. Dr. Anivesh Jain. As organizing secretary, Dr. Anjane Mishra is working since, I think, 1 month. He is working hardly on it. Dr. Anivesh Jain. Dr. Animesh Gupta. They are the organizing committee persons who are, though not here in the scene, but they are working with sir. Once he says that I have to do the conference, these people will be there. Thank you, Dr. Animesh Gupta. I request dignitaries to felicitate Dr. Pushpraj Patel. Dr. Pushpraj.
May I have the honor to call Dr. Rajkumar Jain on the dais?
Dr. Divakar Patel. I request Dr. Pushpraj and Dr. Animesh Gupta to felicitate Dr. Sharnagat sir. Dr. D.S. Chaudhary sir. Dr. Manish Gattani sir. Dr. Manish Gattani sir. This Community Services Award is given by Heart Research Association. Dr. Ram Chandra Tripathi sir. Dr. Abhishek Sharma. Dr. Jyotsna Nigam Sahai Madam. Dr. Abhishek. Dr. Rajesh Jain. Dr. Rajesh Jain sir. Dr. Prahlad Patel sir. Dr. Vijay Chawla sir. Dr. Punekar sir. Dr. Behrani sir. With this, we close our award session. Dr. Behrani sir. With this, I close this inauguration ceremony, and I thank everybody, all the awardees and our dignitaries on dais. Thank you for making the event a successful one.
We are truly honored to have all of your presence. As we close the session, we can now.
So now we proceed for the lunch, and after this again we'll have 4 live case demonstration with common congenital heart disease. So I'll request everyone to finish off the lunch fast and then we'll rejoin.
This is the book all of us we read. I read again and again and again. It was like a gospel at that time. And this is the signature of Joseph Parloff himself. He was 90 years old and he took a bedside clinics in Hyderabad CSI conference, and that time we were 1,000 of us. This is early 90s. And then his diagnosis was near perfect, like ago. And later on, when I wrote the comprehensive approach to congenital heart disease, he wrote the preface for my book. And he refused to write until the whole book was sent to him. So the book dummy was printed and sent, and then he wrote. And he says the diagnosis of cyanotic congenital heart disease represents the epitome of applied logic, and correct inferences are drawn from the accurate observations. Diagnoses are made with the gratifying frequency. So in his book, only diagnosis was there, the treatment was not there. So what I did was, I added the treatment in each and every condition, and that's how, my book became very informative and useful. And defect, and these are the types of the atrial defect, and this is the only one which is useful, or what to say, which can be closed with a device. The largest AST I have closed is with the 42 millimeter device. But what is important is, whenever you want to put the device, you have to measure the intra-atrial septum well, that is the whole length, and then the superior rim, inferior rim, and also measure exactly what is the size. Measuring in one view is not enough. At least 2 to 3 views you have to, and the best view is like subcostal view, and this is for the AST device. I showed you the intra-atrial septum length will be very adequately measured in this view. And another view which is very important is the subcostal bicaval view. This is most important. Why? Because the SVC, IVC is there, SVC is there, and you get the real size of the atrial septal defect. More than that, whether the alignment of the septum is correct or not. Suppose when the alignment is like this, the device closure becomes difficult. And when the alignment is like this, the device closure is much easier. One thing is, with the echo, we can measure the length of the rim, but not the strength of the rim. And that's how many a times wobbling can occur. And what is important is, many a times the diagnosis is missed. So my daughter's roommate's mother, she was 52 years, bank manager, and they made it as a diabetic cardiomyopathy. Then when they called me, I said, on the phone, you can't make the diagnosis, please send her to me. When I did the echo, I found that there was a large AST, and I closed it with the 32 millimeter AST, and even now she is alive and she is doing well. And that's how we know the diagnosis should not be missed, and especially when there is a fenestrated AST like this, we have to see how much space is there in between. Suppose it is a small tissue, you can break it and make single and put a single device, or if it is multiple, then you can put 2 devices, one sandwiched with the other. And this is how you can see that the tissue in between the 2 ASTs is very big, so I have put 2 devices in the same patient. So this is how we can do. And this is one of our prestigious Swamiji's younger brother, diagnosed as AST when he was a child, and then they said it is a small AST, no need to close the left. And then when he was 35 years, he had cyanosis and clubbing. And that time the physicians, they became very panicky. They said cyanosis clubbing means Eisenmenger's. Everybody will think it is Eisenmenger's. So they brought the patient to me. I auscultated, P2 was not loud. Without loud P2, palpable P2, you cannot have Eisenmenger's. So I said there is something wrong, the diagnosis must be rectified. So I did the echo, and look at that. What has happened is, this is the SVC, this is the LA, and that's the RA. And this is the sinus venosus type of AST. What is happening? SVC is straddling over the AST. When you are doing horse riding, you straddle both the legs on either side. And when there is a straddling like this, the part of the SVC blood was going into LA and causing the cyanosis. And the cyanosis clubbing was because of the straggling. That means the SVC blood is divided into two halves, part of it coming to RA, part of it going to LA. And then I said, no worry, I give the guarantee, go ahead and do the surgical closure and the patient will be all right. And now it is more than 20 years, he's absolutely fine. And this is how we know clinical acumen has to be applied. Like the first case, they said diabetic cardiomyopathy. I said RA-RV cannot be dilated, isolated in diabetic cardiomyopathy. So I made the ASD. Here it was Eisenmenger's. I said it is not Eisenmenger, and that's how you have to explain. But today, thanks to the 4D echo, we can see literally everything. You can see the shape, how irregular it is. And this, in the past we used to see in 2D and oversize it, and then there used to be residual because it is oval shaped. And this is the small one, the large one, very large ones. And so you can see the AST better. What is more important is, oh sorry, it's not moving. Okay. Sorry. So this is the 4D echo. You can see the AST from the RA side, you can see it from the LA side, and you can see the rim all around. You can see that how much rim is there. Hardly there is any rim, and this is the large AST. And so this is not suitable for the device closure. And what is more important is, gone are the days, this is the first case when they did the device closure, and after 3 months they have done the autopsy in the animal study, and they have seen how endothelium grows over the device. And now you can see that this is the device. After 4 months I have done the echo, and you can literally see that endothelium has grown over the device, and it is beautifully there. So whether there is a thrombus, endothelium, what it is, everything can be made out so well. And this is seen from the RA side. And the same thing you can see it from the LA side also. So this is how the 4D echo is almost like, seeing what it is inside without opening the heart. Now this is a 42-year-old man with the history of palpitation, exertional dyspnea, came with the fatigue. And you can see that in the M mode, huge RV is there. It's almost bigger than the LV. And this is this paradoxical septal movement. And once you have the paradoxical movement like this, it is an AST. So when you do apical 4-chamber view, you can see that there is a large AST. So why we have done contrast is that already pulmonary artery is so huge, and then there is a severe pulmonary hypertension. One thing, here the pulmonary hypertension was because there was a membrane in the right atrium, and this is the divided right atrium, and that was causing the multiple thromboembolism, and pulmonary hypertension was there. So you can see here clearly, you have to go into the RV inflow, and then you can see the membrane right from the IVC to the Thebesian valve, and that is the membrane. So with the balloon, rupture it, and then, or the surgeon can dissect it and then close it. And the 4D echo, you can see beautifully that this is the coronary sinus on the RA side, and that is the papillary muscles of the tricuspid valve. And here you can see that there is a membrane in the left atrium. So in the past we used to call it as cor triatrium sinister, and today it is called as the divided left atrium. And this patient had AST, but the patient had to go for the surgery because of the membrane. So this is how the membrane in the right atrium, and that was in the left atrium. And you can see that multiple thrombus are there because this membrane causes stasis, and that embolizes, and repeatedly you get the pulmonary hypertension. So this is how echo can show you that, see that there is a pericardial effusion, pleural effusion, divided right atrium, AST, non-compaction of the left ventricle, and all these details can be made out only by the echo. And in the past we used to do the contrast echo to find out whether there is a fenestration in the membrane or not. Here you can see that it is fenestrated and the contrast is coming into the proximal chamber. But today, the 4D echo is so beautiful, you can see from above and below and see whether it is fenestrated or not. You can see that it is a fenestrated one, and then this I just opened with the balloon and the patient was all right. Now we move on to the next case. He's a 52 years old male presented with the complaints of palpitations in early childhood, fatigue for 1 year, dyspnea for 1 year, orthopnea and PND for the last 1 month. Now, if it was a congenital heart disease, why the PND has occurred? And then on examination, S1 was normal, A2 was soft, P2 was loud, and apex beat was in the 6th intercostal space. That means there was a LV dilatation. So there was a early diastolic murmur, collapsing pulse, and it was a aortic regurgitation. So 52 years old man, aortic regurgitation means you think it is not congenital or it could be something. But look at this. When we did in the parasternal long axis, you can see that there is a small VST. During the systole, the turbulence is in the RV because of the VST, and during diastole, there is a turbulence in the LV. So this is the to and fro murmur. Systolo-diastolic murmur was there because of the small VST and the aortic regurgitation. But why the aortic regurgitation? See, invariably what happens is, whenever the small VST is left without treating, there will be a Venturi effect, and that Venturi effect will cause the cusp prolapse. So this is from my textbook, and here you can see that when the VST, the high velocity jet is going, it pulls the cusp down, and that causes the prolapse and non-cooptation. So the AR will be there. Though the VST looks small and closing in, it is at the cost of the AR. So this, now the things have changed. I close it with the VST device and be done. So don't allow the AR to occur at all. And that's how, last year in Indore, we had all women cardiologists meet, and Mary Combe was the chief guest. And she told in the chief guest's inaugural address that her child had a hole in the heart, and the surgeons operated, and the cardiac surgeons are gods, next to God, she said. When she came down, I told, if you had to come to me without surgery, without scar, without anesthesia, without blood transfusion, I could have closed it with a device in just 5 minutes. Is that so? She was telling, and her bodyguards were pushing us because she's a VIP, Olympic gold medalist. So we were pushed back. And then all the younger girls, they said, Madam ji, chhodiye na, uske saath kya baat karna hai? Aap to hamare Mary Combe hai. Because so many younger generation, they got inspiration, they started doing the pediatric cardiology and device closure, and such things can be prevented. And I showed you the ductal view. If there is a right to left shunt or the left to right shunt, all can be made out in this patient, and PDA closure in this case is not likely. So more than 250 cases of PDA PH I have closed with the device, because in children, whatever pulmonary hypertension is a reactive hypertension. The moment you close, the PA pressure will come down. But in case of AST, already they are 30, 40 years old, and then already the pH is irreversible, and then closing them with the device becomes very difficult. This is a 25 years old male with the chest pain. Why the person has got these things? Can anyone tell what you see here? On the RV side, there are something multiple. Very trivial MR is there, and then something is abnormal. So by looking at the parasternal long axis, there is a clue that there is something wrong. But what it is, you can't make out. And look at here, the clue is here. In the apical 4-chamber view, what you see is there is a glistening endocardium. Can you see that? I have reduced the TGC so that only the thickening or the glistening endocardium is seen. And this happens when there is a ischemia. Subendocardial ischemia will cause the glistening endocardium. So that means there is a coronary AV fistula. So which coronary artery, where it is opening, you have to look for. And then whether to send for surgery or device closure can be decided. So what has happened is, this is the short axis. You can see that some jet is coming. The PDA jet will come from here, but this is coming in the middle. So this was the right coronary artery. You can see that the right coronary is so much dilated. It's so huge. So right coronary artery fistula is opening into the pulmonary artery. It's a very rare coronary AV fistula closed with the device. So this is a 20 years old person, blurring with the vision. Blurring of vision, you have to look into the eyes and you can see that there is a subluxation of the lens. So what is the diagnosis? Marfans. So once you have the marfans, you have to look for the aorta, dilatation, annulus and dissection. So this, when we did the arch and the descending aorta, you can see that there is a dissection flap there arising right from the arch to the descending aorta. This is the true lumen, that's the false lumen. So the dissection is extending right up to the bifurcation. So when we did the short axis, you can see that this is the bicuspid aortic valve and then there is a flap there. So there is severe aortic regurgitation because of the dissection and the annular dilatation because of the Marfan syndrome. So this child was treated as a, rheumatic fever, as carditis, and those days they used to put steroids for the active carditis. And because the steroid was put, the child's primary complex flared up and developed meningitis, tuberculous meningitis. So was sent to NIMHANS and they did the lumbar puncture and they did everything, and then they sent the child to me because there was a systolic murmur. Look at that. This is the aortic cusp. Look carefully, just 1 millimeter or 2 millimeter below, there is a small membrane. And this membrane was causing the systolic murmur, and clinician thought it is the carditis with the systolic murmur and put the steroid. So this is how mistakes used to occur in the past, and that can be corrected with the echocardiography. You can see that that is the membrane, and now we know that this congenital subaortic membrane, it progressively goes on increasing, and then you can see that here it is almost, LVOT is narrowed. This is the aortic cusp narrowed, and then you can see that sometimes it will become like a tunnel, and this is the third. So this patient had almost 168 gradient across the subaortic membrane. It was like a tunnel, and this patient had to undergo surgery. What happens is it will damage the mitral valve also during the surgery, and that's how even the small subaortic membrane, it should be resected. I used to do balloon dilatation 30 years back, but then I realized that aortic valve was getting damaged despite the balloon dilatation. So we started sending for the surgery. So in the echo subaortic membrane, you have 3 types. The discrete membrane I showed you, and in the diaphragmatic portion, and the fibromuscular ridge that I showed you in the apical 5 chamber, and the tunnel-like obstruction I showed you in the parasternal long axis. So all the 3 types can be there, and we have to treat as early as possible. This is a 26 years old lady, 6 months pregnant, and she became breathless. And then obstetrician sent the patient to me. BP was 120/60, and there was a systolic murmur. The systolic murmur was due to the VST, diastolic murmur was due to the aortic regurgitation. Now you can see that whether the patient has to continue, the small VSTs are always prone for the bacterial endocarditis, and AR carries the high risk. So this is another patient. Pregnancy is high risk because there is a severe aortic regurgitation, LV dilatation is there, ejection fraction is low, and here the nocturnal angina is there. Why the nocturnal angina occurs? during the nocturnal period, the heart rate comes down. When the heart rate comes down, the aortic regurgitation becomes more prominent. And when the aortic runoff is there, coronary flow comes down. And that's how the nocturnal angina, if it is there, that means it is a severe aortic regurgitation, and that patient has to be, the valve replacement has to be done. Now this is, you all know it is a hypertrophic obstructive cardiomyopathy. Anybody would say that this is the hypertrophic obstructive cardiomyopathy, speckled appearance is there and everything is there. And what is important is when you see, tilt and see the modified view, what are you seeing? Not only the LVOT obstruction, there is a RVOT obstruction also. Now you understand, just doing the alcohol ablation will not be enough to take away the RVOT obstruction. That's why, you know, we have to be all eyes when we are doing the echo. Don't be happy with detecting something. Look for the other associated things, and this is how you can see that there is a RVOT obstruction also, and this requires resection. And here you can see that the fluttering is there. See, this is the aortic cusp is fluttering and it is closing so early. So premature closure of the aortic valve and fluttering is a classical sign of the what we call as the hypertrophic obstructive cardiomyopathy. That's how they have a syncope and sudden death can occur, and once you detect like this on the echo, it has to be treated with surgery. What do you see now? Already I have shown this case earlier, so you should be able to make the diagnosis. What is it? 22 years old lady presenting with breathlessness for 2 years, and somebody made it as a rheumatic heart disease with mitral stenosis. What you see? There is a membrane in the left atrium. So what was called as the cor triatrium sinister, it is the divided left atrium, and this has to go for the surgery. This is a 26 years old lady, 32 weeks pregnancy, and she came with the history of angina. So whenever there is angina, you have to be very much worried about what is happening. And here you can see that the patient had a aortic stenosis. I opened it with the balloon, the angina subsided. This is another lady, 28 years old, full-term pregnant, and because of achondroplasia, she couldn't have the normal delivery. She had to go for the cesarean section. And the anesthetist auscultated, he saw the murmur and he said, no, I can't give the anesthesia. So my good friend Sunanda Kulkarni, she sent the patient to me. She had almost 178 millimeter gradient across the aortic valve. So it is not possible to do section at all. So in the morning, I did the balloon dilatation. She didn't have money. Myself and Sunatna, both we donated and did also. And the evening she had pain. She went and they did the cesarean section. And then she came very happily. She showed a beautiful baby. I was very happy. Sunanda was very happy. We were very happy. And afterwards, she never came for the checkup. So she kept on asking, Viju Banla, did she come? And I was asking, did she come? No, she didn't come. After 1.5 years, she came when she was pregnant again. So this is how the level of ignorance is there among our patients. So we have to be go extra mile to explain to them, this is the risk, this is the problem, you have to be careful. Otherwise, they'll put the blame on us rather than taking the blame on themselves. So this is called as the Prussian helmet appearance. So you can see that this is the helmet. In Prussia, the soldiers used to wear the helmet, and this is the negative shadow there is because of the jet going into that, and that means that it is a doming is there, and that negative shadow is there, and that indicates that the aortic stenosis is there. So this Prussian helmet is very classical of the bicuspid aortic valve, and here you can do the balloon dilatation. Now, in the morning, I told you, when you go segmentally, you will not miss the diagnosis. Here you can see that the tricuspid valve is at a lower level, mitral valve is at a higher level. And what is important is there is a non-compaction, the moderator band is there, but why RV has come on that side? So this is the corrected transposition of great arteries. The ventricles are transposed and then there is a small VST, and invariably 80% of these patients will have VST with the pulmonary stenosis, and they will have Teke-Brady syndrome. They have accessory muscle, accessory AV node. So at one time they have tachyarrhythmia, other time there is bradyarrhythmia in the same. And what is the risk for the mother and the fetus is very high, and maternal functional capacity and cyanosis are major risk factors for the miscarriage. So she can have the miscarriage, and the higher miscarriages are seen anywhere between 16 to 27. So you have to be very careful when you are giving fitness to the patient with the CTGV with VST PS. So this is a 24 years old patient, bluish discoloration of the fingers and the lips, and then the diagnosis was situs inversus, levocardia, CTGV, large inlet VST and bidirectional shunt, and the pulmonary stenosis. Now, since there is a pulmonary stenosis, there is a protected lungs. So still operability is there. Though there is a cyanosis clubbing, pulmonary stenosis have protected the lungs, so then patient can go for the surgery. And here this is the patient, 28 years old. What you see is the double chambered RV and the large VST. So this patient went for the surgical correction. So here, this is the non-compaction is there, then embolization can occur, and this patient is problem. So in the morning, I showed you the triology. This is how the triology is there. And one thing, the difference between triology and tetralogy, in tetralogy, BT shunt can be done. In triology, if you do, it will be like killing the patient. So one has to be careful. Here, I did the balloon dilatation of the pulmonary stenosis. Then the TR came down, RA size came down, and then the patient delivered normally. So this is how you have to decide whether to send for surgery or do the balloon dilatation. In tetralogy, you know that there is a overriding, and the only cyanotic adult condition is the tetralogy is the commonest. So any surviving patient is there, make the diagnosis of tetralogy and it is there. And what is more important is coronary anomalies are present in about 4 to 12%. Unless we show the coronary anomaly, it is very difficult, because if there is a coronary artery going across the RVOT like this, surgeon while doing the RVotomy, they will cut the artery and then the patient will die. So this is echo is so very important for you to show how the coronary artery is, and nowadays we don't take the risks. The moment we have any confusion, send for the CT angio, then the reconstructed anatomy will show that then there is this is the RV and this is the pulmonary artery, and then the RVOT, there is a vessel. So you know that this patient has to be treated without the RV being dissected. So this is how today we are progressing and doing better quality. The mortality has come down by the echo that is giving the idea to the surgeon. Now what do you see here? This is a 20 years old person operated and clubbing. There is no cyanosis now because operated, and here you can see that this is the patch, and always the dicron patch that is put, it is adynamic, it is not contracting. The rest of the septum is contracting, hypercontractility is there, where the surgeon has put a patch that is not contracting. And what is seen? There is one jet in the RV and another jet in the LV. What is it? There is a residual shunt, VST, residual VST causing the shunt into the RV. And there is a damage to the aortic valve and the aortic regurgitation. So residual VST and the AR are there. So here you have to decide whether to send for the surgery or not, because if there was no AR, we could have closed that VST, small VST with the device. Now since there is the AR, we have to assess completely. So gone are the days when we used to depend on the death, the autopsy and the things like this. So here you can see that that is the absent pulmonary valve, and the pulmonary atresia also is to see. But today, X-ray will show you the oligemic lung fields are there, tetralogy is there, but instead of pulmonary bay being empty, there is fullness. This can happen only in one subset of the tetralogy where there is an absent pulmonary valve, and that is causing the post-valvular aneurysm. So you can see that this is the dysplastic pulmonary valve. It is open. Annulus is narrow, so causing the pulmonary stenosis, and then there is no valve, so there is a pulmonary regurgitation. So patient is cyanotic, tetralogy, but there is a PSPR. And PSPR will cause the to and fro murmur. You can see that this is the PS and that is the PR. And in the Doppler, you can see the PS and the PR. And this patient has to go for the valve and replacement. Now, this is the post of RV dysfunction is very difficult. RV is not like a LV where Prabha showed in the morning LV function, ejection fraction calculation. But here what happens is it has got the apical portion, it has got the inlet portion, and it has got the outlet portion. So it is the triangular one, and measuring the ejection fraction becomes difficult. In the past, we used to do the what we called as a TAPSE. Measuring the TAPSE, it was inaccurate. But today, thanks to the 4D echo, you just put all the measurements, and then, I don't know why the videos are not playing. Something is wrong. Okay. So here ejection fraction is 41.2. That means the today 4D echo gives the accurate RV dysfunction and what is the ejection fraction. So you can tell the patients that even if the surgery becomes successful, the RV function may not recover. And that's how today we measure the RPA, LPA and main pulmonary artery, and before we send for the surgery, and this is very important. And 1 second. Okay. Yeah, this is an intracardiac TAPVC and very easy to operate also and treat. There is no problem. They can be treated and sent for the pregnancy can be continued later on. But look at this lady. Already there is a tricuspid atresia, and then there is a pericardial effusion, and LV function is reduced, and she is not fit to deliver, and that's how termination of pregnancy is needed. So here this is the inverted portion. The saturation is only 47, and then she is not fit for delivering, and that's how you have to tell them not to conceive and such patients until the correction is done. So Epstein's anomaly, we call it as the money bag appearance, and the ECG will show a tall P wave and called as the Himalayan P wave by mother of pediatric cardiology, that is Helen Tossing. And this is, in the morning I showed you a case where the atrialized RV, and this is how you can see that the RV, functional RV is very small, and this is the atrialized RV, and that is the atrium, and the huge TR is very dominant. So this is very important to conclude, friends. When the 2D echo came, we were very happy, we were thrilled. When the 3D came, we said, oh, it is so nice. Everybody started going for the workshop and learning. And now 4D has come. It is like a child's play. Only you have to press the button and you have in one frame, beat to beat, you get the intracardiac structure seen. And that's how it's there. And so the CMR is like the beyond. This is the Tejas. That is the fighter jet. When it was released, when Narsim Rao was Prime Minister and Abdul Kalam ji was in charge of the missile. And I went as an attending cardiologist to Narsim Rao ji, who had undergone bypass surgery. And this was so impressive. And today we are exporting the Tejas to the other countries. And that is the precision and accuracy is very important. And that's how, the echo can make or break. It can literally save the patient's life with the precise diagnosis. So my quote is, pathologists make the perfect diagnosis, alas, a day too late in the autopsy after the death. But echocardiographer makes not so perfect diagnosis, but in time to save the precious life. And that's how echo has to be done before for the assessment. And this is the Feigenbaum, whose book we used to read. And this is Dr. Naveen C. Nanda, who is like a Bhishma Pitamaha for all of us. And that's how we know I'm sandwiched between the two great people. And today it is important to know what is the precise echo. So though I'm an interventionalist, I always look at the echo to make my decision. And that's how my intervention success rate is very high. So don't think that echo is for technicians, echo is for the, no. Everyone should know the echo. You should be able to make the precise diagnosis. Thank you very much for your kind and the patient hearing. Thank you.
Any questions?
Oh my God, I thought you were all sleeping. That means you are asking question means you didn't sleep.
Life may be shorter one, as you have said. My question is, madam, when we do 2D echo or echo, normally every cardiologist comment LV ejection fraction, 55%, 60% normal, less than that.
Prabha, he's asking question to you, ejection fraction.
Why we are not commenting on the right ventricular ejection fraction? Is it not that important?
Huh? Prabha.
We cannot measure the right ventricular ejection fraction by 2D.
Okay.
Yes, 3D we can measure. Okay. So that is because, as madam already told, RV is not like the model, it's not like LV. RV has apex, then RV OT, they don't come in same plane. So you cannot assess the ejection fraction by 2D. That is the reason we don't write. We cannot. I am going to talk on that.
It means because of we don't having the advanced technology at our. No, you have, but in our places 3D, we don't have that 3D or 4D.
That is why we are using the surrogate markers like types. I am going to talk briefly about all that.
Specifically in the report, sir, we don't mention whether RV is normal or abnormal. But if it is the abnormal, then specifically all the cardiologists they mention the TEPC also and the RV function also. But ejection fraction we don't measure and we don't mention. RV function is normal or not, that we mention in reports.
Instead, we can use RV fractional area change. So that is an indirect
LV ejection fraction is also taken as a prognostic value.
Yes.
Because if your ejection fraction is very less, then prognosis is bad.
Definitely.
Then my question is same. RV is not that important?
RV is very important, sir.
Very important.
Very important.
Very important.
Yes.
Then why we are not measuring the RV ejection fraction?
It is not
difficult
possible.
To measure. Yeah. Difficult to measure. So that is the thing. Difficult to measure.
So those
sir, मैं ये नहीं बोल रहा हूँ.
Sir, to overcome those.
मैं सर ये नहीं बोल रहा हूँ कि 70 लाख की मशीन है कि 20 लाख की मशीन है.
नहीं सर.
मैं हाँ सबके पास नहीं है. मैं वही बोल रहा हूँ कि अभी हम लोग इस शहर में या इस. Okay, thank you.
TEPC gives an indirect measure of the RV function. You wanted specifically RV ejection fraction, that as madam has told, for that we require 3D machine. And as madam has and sir has told that it is difficult. To overcome those difficulties only we have gathered here and to see what we are missing, what we should do.
So what I understand, in principle, LV ejection fraction and RV ejection fraction both are important, but since the machines are costly, since the technical availability is not here, then we are not measuring indirectly.
Sir, in the past, they were bothering only about the LV, forgetting the RV.
Yes.
Like, in the past, they used to bother only about the husband. The wife's importance was not known. But today we know, without wife, the family cannot run. So we have started giving importance to RV function also. But RV is not simple like LV. It has got the 3 component, apex part, inlet, and...
Wife is never simple.
And, that's how we know. So we have to have the advanced technology to assess the RV. Because in spite of successful surgery, the patient will deteriorate if the RV function is not good. So the wife is also very important, sir. Yes.
Thank you, madam. Thank you.
Ma'am, can we proceed with the next case discussion, ma'am? Dr. Ashish Tiwari is an eminent cardiologist from Shelby Hospital. He is going to present the case, ma'am.
Good afternoon, ma'am. It's my pleasure to present the case to you. So she's a 44-year-old lady who presented with us with last 2 years, dyspnea, class 2, and the dyspnea. And apart from dyspnea, she also has started having, since one year, she started having a chest pain, which is atypical anginal with palpitations. So this was the brief history she has given. Before that, she was in class 1 according to herself.
Is the palpitation episodic?
Yeah, episodic palpitation, more on exertional. So I did examine the apex. So apex was typically there are multiple apex I could feel, and there is I could feel multiple apical impulses. The auscultation. Yes.
Any murmur?
No, I could not get any murmur, and even it was very loud, so I could not auscultate anything. Now we can auscultate right now. So this is showing there.
They want to show who is sleeping and who is not sleeping. All are awake. Now see, now you can sleep. Okay. See, this is a beautiful one, and you can see there the pointer, please, pointer. There's a pointer. उधर ऊपर है. The parasternal long axis view she is showing, and what you see is normally when you are doing the parasternal long axis, you don't see the tricuspid valve there. But here the tricuspid valve is seen when just below the mitral valve, and that can happen only in the Epstein's anomaly. So immediately you must think that RV is dilated, and then paradoxical is thing, and then the tricuspid valve is seen along with the mitral valve. You can see that that's the tricuspid valve. And this is the Epstein's anomaly. Then you have to go to the apical 4-chamber view and see how much is the septal adherence and the distance. The more the distance, more severe the function. Then you have to measure the functional RV, then atrialized RV, and then the atrialized RV, and then the atria, and the severity of the TR, and for that tricuspid valve repair can be done. If not possible, they'll do the replacement. And palpitation, they said, in the history, they said palpitation, because invariably they'll have WPW syndrome, and whenever there is a WPW syndrome, they are prone for the arrhythmia, so the palpitation will be there.
In fact, she was diagnosed as WPWA.
Yeah. ECG can be shown to the physicians, how the WPW looks. The short PR interval and the delta wave and all that can be shown. Show the ECG, send it to the...
Just for the audience perspective, just please tell about the surgeries and how they decided about the surgeries of Epstein and about right from cone repair to simple tricuspid valve replacement.
But this is not a classical one, no? There will be shattered RV, impulse will be there. That's not classical.
So,
This patient underwent EPS also, ma'am. There was right posterolateral pathway, but arrhythmia was not inducible. Although she is having history of palpitation and SVT, but on table arrhythmia could not be induced, so they have not done any ablation.
Yeah, freeze, Prabha. Prabha, freeze. Freeze. Okay. Now you can see that this is the septal leaflet adherent to the septum, and that copting point is somewhere there. Move. Okay, please, stop. That is the place where it is copting. So this whole distance has to be measured, and that has to be measured. This is the functional RV, and this is the atrialized RV, and this is the atria.
And functional RV cavity appears good, ma'am.
Little slightly better.
And this might be the region she presented.
Little more till here.
Yeah.
Circumference
Measure the distance from the mitral annulus to the septal leaflet attachment. So
yes, that's the one. 29. That is very severe Epstein.
it is 8 millimeter per meter square. Is the cutoff. You can see some
Any mitral valve abnormality also seen in this man?
As madam said, the coaptation is occurring much below the tricuspid annulus. See there?
Yeah.
It's in the middle of the
So
RV cavity.
It's seen beautifully. Yeah.
Yeah. It's mild to moderate TR, I think. You can see the pressure. It's a low pressure TR.
So that also one of the hallmark that whenever TR will be there in the Epstein, that will be always low pressure. If you see high pressure TR, you should review the diagnosis once.
And even it's difficult to, the murmur is also early systolic. It's not a pan-systolic, it's low pressure TR.
So we do have some associated mitral valve abnormality in Epstein cases.
It's largely normal.
Healthy normal, yes.
Yeah.
So mitral valve comment is
Another
normal.
thing you should look for is intraatrial communication.
Yes, it's one of the commonest association with Epstein is.
And the cyanosis is because of the right to left shunt at atrial level, either because of the foramen ovale or a atrial septal.
So whatever the septal dropout we are seeing.
There is no flow across it.
Yes. But that septal dropout is probably without flow.
Yeah, without flow. So I think it's a mild to moderate form of Epstein's. Functional RV is quite good. Yeah, it's a downward displacement of the septal and posterior leaflet. Posterior we cannot see here. It's only septal leaflet we are seeing. Anterior leaflet is usually large and sail-like. That's why you get a loud T1 component. It's called sail sound. And another feature used to diagnose by MOD is delayed closure of the tricuspid valve. That's what madam was saying. You will see it in the parasternal long axis view. I was trying to look for that delayed closure more than 70 milliseconds.
Yes, ma'am.
After the mitral valve. That's why you get a split second sound and a loud T1 clinically.
Quality is not that good to explain, so we'll take the next case.
Thank you, ma'am.
Thank you so much for those important clinical insights and your enthusiastic participation, ma'am. We now begin with our next session, practical approach to left and right ventricle function assessment. This will be a hands-on interpretation style session, focusing on a practical echo assessment. This session will be conducted by Dr. Prabhavati ma'am.
You give me the. Connected? Yeah. So we are talking a lot about LV function, RV function. We all know LV function is mostly assessed by the ejection fraction, but I would like to draw your attention for few simpler ones also to assess LV function. So assessment of LV function is very important and it should be part of all echo examinations because it provides prognostic information and medical therapy. You know, now you have low heart failure with reduced ejection fraction, medium range ejection fraction and normal ejection fraction, and it also helps in timing of surgery in valvular heart disease. That is an important parameter to assess during valve. And LV dysfunction can occur in practically all diseases, ischemic, cardiomyopathies, hypertensive heart disease, and including cancer chemotherapy. So there are various parameters to assess. I will highlight some of the M mode linear measurements. And of course, everybody knows about the 2D echo with area and volume based measurement, 3D echo, and spectral tracking, which we are not routinely doing. So the first step is to assess the dimensions, LV. Dimensions in parasternal long axis view. You look for the LV, you keep the cursor perpendicular to the ventricle, just below the tip of the mitral leaflets. So there you measure the LV dimensions, and diastole it should correspond to the R wave, and end systole after the T wave. And these are various measurements, normal values. LV diastolic dimension is usually between 3.7 to 5.5 centimeters. It depends on the body surface area also. And systolic dimension is 2 to 4 centimeters. This is a very simple point, E point septal separation. When the mitral valve opens, if the LV function is normal, it almost slaps the interventricular septum. It goes very close to the interventricular septum. So the distance between the E point and the septum gives an idea about the LV function. So this depends on the LVDP. If there is LV dysfunction, this E movement is less. So there is a wide gap between the septum and the E point. So how is it measured? You measure in the parasternal long axis view from E to the septum. Normally it should be within 6 millimeter. So if there is LV dysfunction, it will be more. And there is a rough correlation with the ejection fraction. Okay, less than 6 millimeter is normal. If it is more than 7, it may be EF less than 50%, and if the value increases, the EF decreases.
And
so
sorry for interruption, EPSS should not be measured when presence of AR.
Yeah,
that is erroneous.
I'm going to
That
tell
is
that. I'm going to tell that. So here is a EPSS. You can see even the LV contractility is reduced. EPSS is 22 millimeters suggests you have severe LV dysfunction. So the advantages are it's easy, it's a quick numerical value, it's highly reliable for a bedside assessment in emergency critical care setting. But as madam said, you cannot use when there is mitral stenosis, aortic regurgitation, and when there is septal hypertrophy because EPSS will be anyway reduced. So another important parameter in M mode is B bump. You all know E wave and the A wave. After that the valve closes. Before the valve closes there is a bump. Okay, this is hump after the A point during diastole. So there is a brief opening motion of the mitral valve after atrial contraction. This is called third opening. This indicates a high LVDP of more than 20 millimeter mercury. This is because of the high LVDP, LA pressure remains higher than the LV pressure. So the valve cannot close. So it again partially opens, and then when the systole starts, it closes again. So it is a good specificity, but the sensitivity is low. So if it is there, it suggests high LVDP. This is usually asked question in the DM exam also. What is the M mode finding in increased LVDP? So the third is M mode finding is fractional shortening. This is very easy one. You can say take the end diastolic dimension and end systolic dimension. In parasternal long axis view or short axis view, basal or mid papillary levels. So you take the difference and expressed as percentage. So this reflects the global function. Normal is 30 to 45%. Less than 25% indicates LV systolic dysfunction. So this is useful when the LV geometry is normal, there is no regional wall motion abnormalities. It fairly well correlates with the ejection fraction. So it's a quick and reproducible bedside tool to assess LV function in the emergency room. But you cannot use it when there is regional wall motion abnormalities. Another M mode finding equivalent to TAPSE. It's a MAPSE, mitral annular plane systolic excursion. This is again an M mode. How far the mitral valve base moves towards the apex during systole. So this assesses the longitudinal function of the left ventricle. You can usually use the lateral annulus, sometimes they use the septal also. So you take the lowest point to the highest point during systole. So this gives an idea about the LV function, and normal is between 12 to 15 millimeter. If it is more than 10, EF is more than 55, less than 8 indicates reduced ejection fraction. So it's reliable, easy to use, especially when the image quality is poor. Somehow it is underused and underrepresented. That's what is said in a recent journal in 2024 article. So, but you cannot use after cardiac surgery or significant pericardial effusion is there, mitral valve disease is there because the annulus is affected, and if there is wall motion abnormality in that region or some localized fibrosis. Now ejection fraction, which is the most important parameter to assess the LV function, and this is expression of LV global function, and as sir was discussing, it's a strong predictor of clinical outcome in almost all cardiac conditions. So how many of you really measure the ejection fraction? Do you do eyeballing or measure it? You measure it, or how many of you do eyeballing? Eyeballing, yes. So eyeballing, is it better than measuring? There is a controversy actually. Not that it is excluded, but still in operators, good operators experienced operators can do it better than measuring it in poor quality image. So you should look at the inward motion of the endocardium, thickening of the myocardium, how much longitudinal motion occurs, and also the geometry of the ventricle. So here is an example. How many of you think visual EF is how much in this? It looks normal, decreased, increased. Yeah, it looks normal. You can see thickening is there, base is moving, and the cavity size is decreasing. So it is suggestive of a good EF. On the other hand, here you see. Yeah, what do you think is the EF here? Yeah, it was around 30%. You're right, very good. Yeah, so it works. Yeah, but in patients with regional wall motion abnormalities or rhythm abnormalities or extreme tachycardia or bradycardia, you may not be able to assess, especially if you cannot see all the segments. So actually there was a study in the Israeli group, visual assessment of global and segmental LV function.
the inter and intra-observer variability was only 5% and the reliability was nearly 80%. So ASC also says it can be used. But classically, we measure the ejection fraction using the LV volume assessment by either 2D or 3D. You all know how to calculate it. Stroke volume divided by LV end diastolic volume. Somebody was asking ejection fraction. More than, there is anything above 50% is normal. So how do you do? Do you do monoplane or biplane? You know what is monoplane? What we do is only monoplane. We do it only in the 4-chamber view using Simpson method. Biplane, what is recommended by the ASC, is you have to include the 4-chamber view as well as the 2-chamber view, take the average. So that is what is recommended by the American Society of Echocardiography to assess the biplane EF measurement. So it gives some steps. Zoom, get all the segments, don't foreshorten, then you start from this and include the, you should get a best image, avoid foreshortening, and you should have ECG tracing exactly to define whether end systole and end diastole. That gives a better ejection fraction assessment. And if image is poor, contrast agents are recommended, but we hardly use that. So the problem in Simpson method also is poor image quality when there is regional wall motion abnormality, or you cannot see the endocardial border clearly, or if there is beat to beat variation. We struggle to assess ejection fraction in presence of atrial fibrillation because each beat has a different end diastolic and systolic volumes. We are supposed to do several measurements, but I don't think anybody does it. So pitfalls, we have to, actually they say you have to, this should go inside, the trabeculations, papillary muscles, all should be included, and foreshortening should be avoided. And sometimes you try to avoid this basal segment, that also should be included. So these are the ways you had to improve the assessment of ejection fraction. Anyway, 3D is a better modality to assess the ejection fraction. Then you can, as we discussed in aortic stenosis, you can assess the cardiac output and LVOT. Measuring the LVOT area into LVOT VTA, you can get the stroke volume. So cardiac output is stroke volume into heart rate. So this simple method you can use to assess the stroke volume. These are the normal values. And this is an important. How many of you have tissue Doppler in your machine? You have. So do you do this usually? S prime. Yeah. This is the annular velocity. It is something like our MAPSE only. It has a good correlation with the LV ejection fraction. You measure the lateral annular systolic motion. Usually it should be more than 9 centimeter per second. Anything less than 8 centimeter is suggestive of LV systolic dysfunction. It indicates a longitudinal function. So where do you get more? 16 centimeter per second. This S prime more than 16 centimeter. Where do you get it? It is a marker of malignant. Have you heard of Pickelop sign? In mitral valve prolapse. Mitral valve prolapse, you are supposed to measure the lateral annular systolic excursion by tissue Doppler. If it is more than 16 centimeter, it's a marker of sudden cardiac death. Pickelop sign. So this is tissue Doppler. You measure the highest velocity. And this is a useful reproducible tool for assessment of LV systolic function. So this myocardial perfusion performance index or the TI index, which measures both systolic and diastolic function. Actually, it includes the isolamic contraction time plus isolamic relaxation time you measure and divided by ejection time. So that is the myocardial performance index. We do it in our labs sometimes. And this is another measure where you use the MR jet to assess the rate of pressure rise in the left ventricle. That is called dP by dt. P is pressure, T is time. So this is the time taken for the pressure rise to occur from the 1 meter to 3 meter. It's an easy one. If you just, some machines have that, you can give the, at 1 meter you give, then 3 meter, it calculates and gives you, the 1200 is the normal value. Strain imaging, how many of you do strain imaging? Anybody does? Oh, good. Yeah, I will not go into the depth of this because it's basically strain is lengthening and shortening of the myocardial fibers. This can be measured in the longitudinal, circumferential or radial direction. Most important is longitudinal strain. So here is the ratio of the change in length to the original length measured by spectral tracking, GLS, the global longitudinal strain. Now it is the current ejection fraction because it can pick up the LV dysfunction before the ejection fraction is impaired. This is expressed as percentage and its value is minus 18. Below that is normal, it should be more than that. So since subendocardial fibers are affected first, GLS declines earliest before the ejection fraction is affected. So strain imaging is useful during silent phase of LV dysfunction before the EF is impaired. So it is measured, you give the 3 apical 4 chamber, 2 chamber and apical long axis view and it calculates it. Okay. Then coming to regional wall motion abnormalities in ischemic heart disease. See, normally during systole, systolic thickening should increase by 40% or more. It's less than 30%, between 10 to 30% is hypokinesia, less than 10% is akinesia. If there is outward motion like this is normal, this is hypo, this is akinesia, there is no movement. Whereas in dyskinesia it moves out during systole, whereas in aneurysm it is almost always during systole and diastole it is out. So these are 17 segment model of LV segment analysis for the ischemic heart disease, coronary artery disease. We have basal 6 segments, mid and apical 4 and there is a apical cap. So we can know which vessel is supplying those areas and then we can assess the wall motion abnormalities belonging to which vascular territory. Thank you. This is about LV systolic function and quickly, briefly about the RV function. So as it was discussed, right ventricle and tricuspid valve were the neglected ones. Nobody bothered about the right ventricular function, but now it is shown that it is a powerful predictor of prognosis in cardiopulmonary diseases. In a patient with mitral valve disease, we always look at the RV function. If the TRAPS is less than 10 millimeters, surgeon refuses to take because the mortality is high. So it's a very important tool. We had an extensive discussion after Madam's talk. In LV, EF by 2D echo is the single most useful parameter for global systolic function. However, in RV, we cannot measure this because of we do not have a geometric model to calculate the EF on 2D echo. It's because of the complex shape, non-symmetrical regional contraction, and we do not have adequate literature also. So we go for other parameters to assess the systolic function. No single measure is completely reliable, so it should include various parameters. So again, eyeballing. Usually what we do is eyeballing, no? Most of us? Yeah? Do you write? RV function, how many of you mentioned RV function in your reports? Yeah, tab C. Okay, it has been studied. Eyeball here is not reliable. It's insufficient. So they always recommend quantitative measures. So regional, that is longitudinal assessment can be done with the TAPSE, which you all familiar with, and again S prime of the lateral wall. These are the two parameters to assess the lateral longitudinal function. Then you have a global systolic function which can be assessed with fractional area change, myocardial performance index, that is the TI index which we discussed in the LV function assessment. And again now the strain, global longitudinal strain has become the ejection fraction equivalent and also rate of pressure rise in right ventricle, dP by dt. So various views can be used, but most often used is the apical 4-chamber view, that is the RV focus view, where you focus on the RV and RA. So TAPSE, you all know how to measure it. This is the excursion of the TV annulus during systole, and it corresponds to the longitudinal contraction of the longitudinal fibers of the right ventricle, which is most powerful in the right ventricle. This is measured by M mode and systole from end diastole to end systole. And what is the normal value? More than 17 millimeter. Actually, recent American Society of Echocardiography has given a grading. Okay, mild is 13 to 17, 10 to less than 13 is moderate, and less than 10 is severe. That's what I said. If the TAPSE is less than 10, the mortality is high after mitral valve or left-sided surgeries. So this is, you can see normal TAPSE, and here you can see it's almost flat. TAPSE is hardly 10 millimeter. So it's a quite extensively studied parameter and represents global LV function. They have correlated with radionuclide imaging, RV fractional area change, and it is shown to predict prognosis in heart failure, pulmonary hypertension, and right ventricular MI. It's a surrogate marker of RV function. It's simple to measure, reproducible, highly feasible. You can do it in majority of the patients, and even in poor echo windows you can assess this. But the problem is it's only regional RV function. It is angle dependent, and you have to properly keep the cursor over the lateral annulus, and also it is load dependent. When the volume is more, like severe TR, it may be overestimated. So American Journal of Society of Echocardiography says you should incorporate this TAPSE into your report for estimating RV function. The similar to that is the tissue Doppler imaging of the right ventricle, that is the S prime. This is equal to that only. Here the systolic excursion velocity, similar to measuring TAPSE, this is the longitudinal velocity of excursion of TV annulus or the basal RV segment. You can use either the pulse Doppler or color coded tissue Doppler, which we use is pulse Doppler. You keep it at the lateral annulus, and the normal value is more than 9 centimeters second. Again, you can see here it is 15, normal, it's 6.47, suggestive of RV dysfunction. Again, American Society recently has given a grading for this. 7.2 to 9.5 is mild, 5 to less than 7.2 is moderate, and less than 5 is severe. So again, it's easy to perform, reproducible, highly feasible, and validated. And there is a prognostic value also. Again, it is like TAPSE, it is angle dependent, load dependent, and reflects only longitudinal fraction. But however, ASC says that you should be including this in the RV function assessment. So the third is RV fractional area change. As we said, we cannot assess the LV. Unlike LV, you cannot assess the ejection fraction here. You take the area, end diastolic area and end systolic area, divided by end diastolic area. So this is the percentage, fractional area change. So this we can do easily. Again, in the RV focus view, you start tracing from the lateral annulus, RV endocardial border, from lateral, TV annulus, free wall, then apex towards the septum, end diastole and systole. You include the trabeculations, papillary muscle, moderator band, all should be included. This is the correct way and this is the wrong. You should not exclude that. This again is graded by ASC. Normal is more than 35%, 29 to 35 is mild, and severe RV dysfunction is indicated by fractional area change less than 22%. So this is better than TAPSE because it assesses both longitudinal and the radial components of RV contraction. It correlates well with the ejection fraction measured by the MRI, and it also is a predictor of heart failure, sudden cardiac death or mortality in patients with pulmonary embolism or right ventricular infarction. But it's difficult to get the end diastolic as well as end systole in the same plane. Sometimes it's difficult because of the twisting motion and the crescent shape of the RV. If there is wall motion abnormalities, regional wall motion abnormalities, it may be difficult. So, if there are excess trabeculations or suboptimal image quality, again, it is difficult. RV outflow tract is excluded. So, these are the problems, but still, American Society of Echocardiography recommends that this should be included in estimating the RV function. There are other few things which are not commonly used. As we said already, RV tie index, it's similar to the LV, isolamic relaxation time plus contraction time divided by ET. which is measured by the pulse wave Doppler. You take one across the tricuspid valve and one across the RVOT. So you can calculate the tie index. It's a simple measure. And normal value is less than 0.33, and if it is more than 0.4, it is abnormal, because here the pre-ejection period, that is the isotomic contraction period, is increased. So the ratio goes up when there is RV dysfunction. It's simple, good reproducibility and sufficient data can be performed, but it is not recommended to be done regularly. But when there is AF, you cannot calculate properly. So DPDT, again pressure rise in the right ventricle. We do it sometimes to assess the RV contractility. You should have TR. When there is TR, you can take the ascending limb. The time taken for the pressure to rise from 1 meter to 2 meter. There it is 3 meter, here it is 2 meter. So that value is around 400 millimeter mercury per second is the normal value. So the last is strain rate and strain imaging. Again, this is RV global longitudinal or free wall strain. And again, it detects the subclavicle RV dysfunction. Normal value is minus 20 to 25%. It should be less than that. So this is more robust data, but it's complex and needs software, separate software and offline analysis. It's not used in routine clinical practice. Anybody is doing this? RV strain? I don't think so. Okay. And 3D echo, as madam said, 3D, 4D, they're all superior, more reliable for accurate assessment of RV, but most of the centers do not have this. Now there is a new data has come. You measure the TAPSE by systolic PA pressure. This is called measure of RV-PA coupling. So that means the relationship between the RV contractility and the afterload. When the afterload increases, that means PA pressure goes up. Is the RV able to cope up? So the normal RV-PA coupling is maintained when RV function matches the pulmonary vascular resistance. So this is an important parameter to assess, and that is assessed by TAPSE by systolic PA pressure ratio. So if that is decreased 0.36, TAPSE should be more, systolic PA pressure should be matched to that. So when this ratio is less than 0.36, it's a predictor of poor prognosis. This is like assessing the afterload mismatch in aortic stenosis. So this is TAPSE systolic PA pressure ratio. RV coupling. Diastolic dysfunction rarely measured. It's same as for left side, and however it is independent predictor of mortality. So it's not routinely measured. To conclude, RV function assessment is challenging because of its complex anatomy. Visual assessment alone is not sufficient. You should use TAPSE, S prime or fractional area change, and at least one of these should be incorporated into routine echo. Others may be used in special circumstances. Thank you. Now sun setting, no? Any questions?
No question. They were all awake and listening.
They were all sleeping? Boring? Yeah, one more I have, I'll come later. Huh?
Ma'am, my question is for the management of two subset of patients. First is patient with septic shock with very severe volume distribution. And in those patients, to assess the fluid responsiveness, to start the early ionotrope or to give more fluid continuously. So how we can use TAPSE or MAPSE in that scenario? And second set of patients are those who are with poisoning of antipsychotics kind of drug, those who have a higher metabolic rate and high fever and high cardiac output. So many a times they have third space lossing and loss of fluid because of temperature and all. So how to assess the hemodynamics and fluid management in those kind of patients according to TAPSE or MAPSE if we want to use that? Can you
Does
guide?
it really depend on TAPS? I think you have to depend on the IVC and volume load depends on the IVC size collapsibility, right?
Yeah, IVC size collapsibility, I want to know about the full fluid responsiveness. If the patient is fluid responsive or not. Suppose if we give a higher amount of boluses, sometimes patient do not get the map of more than 65 and we have to start the early inotrope. So that decision can we make a bit early to salvage the organ dysfunction through these parameters?
If these parameters are impaired, maybe it is helpful. I am not really sure. Sir, anybody is... Can you answer that? Because we don't come across such patients. So.
I could not.
एक पेशेंट है
फ्लूइड मैनेजमेंट
पेशेंट है सेप्सिस में है डिस्ट्रीब्यूटिव शॉक में है पेशेंट एंड अब हमने एक 100 ml का हमने 500 ml का बोलस दे दिया अब वो पेशेंट रिस्पॉन्सिव नहीं है एंड अब मुझे अगर ज़्यादा वेट करते हैं तो ऑर्गन डिसफंक्शन भी हो सकता है आयनोट्रॉप स्टार्ट करने में एंड इन दैट सिनेरियो जस्ट लाइक कि अगर हम फ्लूट देते हैं तो इफ देयर इज एनी चेंज इन मैप्सी एंड टैप्सी पैरामीटर्स that can guide me that this patient is fluid responsive and can we surrogate these markers in that scenario ऐसा कर सकते हैं क्या
that's what I said.
जी जी नहीं सर बीपी अगर मैप नहीं बढ़ रहा है आईवीसी तो ठीक है सर अगर मैप नहीं बढ़ रहा है so early inotrope decision can we take?
No, early as the patient is in shock and you already given the 500 ml fluid challenge and still patient is in shock, so you have to start inotropes also. And as MAPSI and TAPSI were initially normal and still they are normal means LV contractility is normal and you are saying that patient is in distributive shock, so still patient will require further fluid management along with inotropes and the reversal of the basic etiology. Meanwhile, if the IVC is not congested, jugular veins are not full, we can give the fluid further. If IVC is congested, means IVC is plethoric or JVP is full or...
Sometimes IVC is 1.7 only. I find most of the time ki IVC is 1.7 and collapsibility is around 50%. But they
so
have a distributive...
early inotropes you have to start.
Okay.
No, patient is hypotensive, is it?
Yes, yes. Patient is
asking to about
and the LV function, RV function,
normal. They are normal. I mean, good. They have tachycardia and all. But I want to judge the is more fluid is better or start the early inotrope first.
Both. But first fluid challenge and then early inotropes also. You can if already you have given 500 ml, that is sufficient. Then you have to start inotropes also.
I have many times fight with the surgeon for that point of view. नहीं फ्लूट दीजिए और दीजिए जैसे अभी रिसेंट में मेरे एक सर्जन ने 6 लीटर फ्लूट दिला दिया बोले नहीं आइनोट्रोप नहीं चालू करना
तो that is like our मतलब जो एक एज अ क्लिनिशियन वी हैव टू एक्सप्लेन द पेशेंट रिलेटिव कि नहीं अब पेशेंट आइनोट्रोपिक सपोर्ट पे आ गए तो पेशेंट की प्रोग्नोसिस खराब है तो वो एक्सप्लेन करना थोड़ा सा डिफिकल्ट हो जाता है
sometimes to the surgeon it was for difficult for me
no for surgeon also सर्जन मना कर रहा है वो बात सही है कि उनको मतलब ये एक्सप्लेन करना कि पेशेंट इतना शॉक में कि आइनोट्रोप लग गया लेकिन अब पेशेंट उतना शॉक में तो है कि आइनोट्रोप लग रहा है तो हमको पेशेंट को बचाना है मतलब आइनोट्रोप से नहीं बचाना है डिसीज से बचाना है आइनोट्रोप से कुछ नहीं होगा
हाँ नहीं सर एक्चुअली दे वर कोटिंग Bailey had some different point of view
but he is saying 6 liter fluid 6 liter is too much
no systemic vasodilatation also may be contributing no maybe we have to give that if the, as well as
ठीक है
okay
thank you good question we have one next interesting case ma'am I'll request Vijayalakshmi ma'am madam we have one case ma'am one case ma'am one congenital okay Dr. Vikas Mishra Dr. Vikas will present short history. Dr. Vikas Mishra is Associate Professor in Cardiology in Medical College.
He's a 27 years old. ma'am, he's a 27 years old male. He presented with history of dyspnea and occasional palpitations, intermittent palpitations since last 4 to 5 years. Currently, he was being posted for some unrelated surgery, and where cardiac workup it demonstrated some ECG changes.
Okay.
Some
So he
RBB
was
in
sent
the
for the
ECG.
fitness for surgery.
Yes, so RBB in the ECG, and probably an echo was done which showed some
Yeah, please show us.
cardiac lesions.
See, whenever they send for fitness for surgery, we must be careful. There was one child who was sent for fitness of surgery, 3 years old child. And I found multiple vegetation on the ascending and the arch of aorta. Never seen vegetation there, you know. Had a bicuspid aortic valve, and that vegetation had spread along with the eccentric jet which was hitting. So this is how, you know, we have to be very careful. Otherwise, unnecessarily post-surgery they will lose with septicemia, and the blame will come on the surgeon. So we have to give the correct assessment to them. Yeah, please go ahead, sir. This is the inverted image they are showing. Okay, they changed the image. Okay, this is the parasternal long axis way. You can see that the RV is enlarged. Okay. Normally we don't see such a big RV. And put the M mode and show us the septal, is that a paradoxical movement of the septum? See that? There is a paradoxical septal movement. So this means AST.
During diastole here, yeah, it suggests you of RV volume overload, right?
Okay,
Yeah.
maybe. The flattening of the septum is there.
Yes, correct.
See, I told you normally septum acts as a part of LV. When the RV volume or pressure overload is there, then the septum is pushed towards the LV. So it becomes like a D shape. So it is flattened.
Aortic is normal. Okay.
No, there is something there, color dropout. Okay, 1 second. So pulmonary artery is enlarged. You can see it is big. And there is something on the pulmonary valve. There is something on the pulmonary valve. If a better picture comes, whether it is a vegetation or thrombus, we'll have to see. Yeah, there is a PR, a jet of pulmonary regurgitation is there, and there is a turbulence in the pulmonary artery. Arey wah. So she is showing something like Durandar, you know, all red. Everywhere blood.
Color, why this color is come? Now it is, okay. There's a turbulence flow actually, increased pulmonary blood flow.
Okay.
Yeah, then mild PR.
Very mild PR is there.
Yes. Very keeping. Okay. We'll go to the.
So here you can see that interventricular septum is straightened. Okay, RARV dilated and show there is a large AST. She'll put the color and show the flow across.
Color.
See, it's a large AST. So the moment we see the RV is so big, paradoxical septal movement, suspect AST and look for confirm it in the apical fourth chamber. Now, Prabha, show the whole intra-atrial septum, how much you measure, and the superior rim and the inferior rim, measure it, and then we'll decide whether it is suitable for device or not. Okay. That is the inferior rim. It is 1 centimeter, adequate. Anything above 7 millimeter is adequate. It's 2.7 or 2.5. Will require, if you oversize by another 3, we require about 28 millimeter device 28 millimeter device, add 7 on either side, so 14. So that becomes how much? 28 plus 14, 30, 42. So intraatrial septum has to be more than 42. Otherwise, our device will crumple and that will cause erosion. So show the intraatrial septum. Prabha, your Doppler also red, your sari also red. They're all thinking of Durandar now. See that? All red. Show the yeah. Freeze. Okay. Move. Okay. No. Previous. Okay. No. Little more. One more frame. Okay. That's it. You take the measurement now. Intraatrial septum. If it is the whole IS. From there, beginning mitral valve. From there to down. Okay. How much?
5 centimeters.
5. So this is suitable for device. Now we have to look for the aortic rim. If aortic rim is less than 4 millimeter, IVC rim is also inadequate, then it will not be suitable. So here 28 millimeter device can be put. Yeah, foreshorten. Yeah, freeze. Okay. No, little more. Get the aorta, 5 chamber, and then measure the rim, aortic rim. Aortic rim. Yeah, this is the bicaval view. You can see that is the IVC, SVC, and then
Inverted.
oh, almost 30. So at least 32 we'll have to put the device. And that's why, whenever you're looking at the AST, not one view, 2-3 views we have to take. And whichever it shows the maximum, that has to be taken as the AST. Because I showed you they can be oval, they can be irregular, they can be anything. Yeah.
Big one, but it's doable. He says it is doable.
You got the aorta. You are getting the aorta. Yeah, freeze. No, now okay, freeze. Move. Okay. Above the aorta, you just see. Yeah, that portion. Measure that. No. Get the aorta. Yeah.
It's there.
Little more. Okay. Measure that. I think aortic rim is deficient. Yeah, freeze and move it. Okay. Yeah, aortic rim appears to be adequate. It's okay. Yeah, it's adequate. Yeah, that's the aortic rim. That's fine. Even if it is 4 millimeter, it's adequate. How old is the patient? What is the weight? Because a large device has to be put. And we show the intraatrial septum again. if we have to put 30 millimeter device, 30 plus 40 means 45 millimeters. It should be more than 45 millimeters. Yeah, no. Oh, okay. Adjust the TGC so that we can see. No, you are having 4 eyes. We have only 2 eyes. No, okay. Yes. Yeah, now you can measure. From above, little more higher. Okay. Below. Okay. That's it. 48. Yeah, you can still try.
Next case we'll discuss, ma'am, ischemic cardiomyopathy. So this man, he had acute coronary syndrome in 2015. He underwent angiogram and then he underwent by CABG with mitral repair with ring. Along with there was LV aneurysm, so aneurysmectomy was also done. Now he had recurrent hospitalizations, maybe around 1 or 2 years with heart failure, and he is on optimal medical management. He is a diabetic and he has recurrent hyponatremia. Creatinine is also borderline. So just thought we'll discuss one, we had a lecture with RWMA. So to see what are the segments, ma'am will enlighten us.
So can anybody comment? So we start with the short axis. Can you identify the segments? Any volunteers here?
Which segment is hypokinetic or akinetic?
I will start with the parational long axis view. Can somebody interpret that echo? See the septum is thin and akinetic, right? The entire length of the septum.
Looks scarred.
Yeah. When do you say scar? What should be the thickness to say scar? Less than 6 millimeter, 5 or so. Yeah. So the whole septum is scarred. So what territory? Yeah, everybody knows LAD territory, yes. So short axis at the mitral valve level. So here we'll see the basal segments. Can you show? This is anterior, anteroseptal, anterolateral. Inferior, infraseptal, infralateral. So this is inferior, infraseptal, infralateral. Now they have changed actually in this. So this is anterior, anteroseptal, and anterolateral. Yeah. How will you explain? Okay. Yeah, you can see the you show the anterior. Yeah, anterior. Yeah. Here also it's anterior, it's basal, anterior, anteroseptal, anterolateral. Then inferior, infroseptal and infralateral. So anterior and anteroseptal basal region, it is supplied by the LAD. Inferior and infroseptal by the RCA, and infralateral and the anterolateral by the circumflex. This is basal. Same thing, this is at the mitral valve level. Then you go down to the short axis at the papillary muscle level. Same. Anterior, anteroseptal, anterolateral. Inferior, infroseptal, infralateral. So more or less same distribution of the vascular territory. Then when you come to the apex, it is only 4 segments. Anterior, inferior, septal, lateral. I'm not able, okay. So at the apical level it is only 4 segments. Can you show that? Yeah, that is anterior, septal, inferior, lateral. Then you have the apical cap. So these anterior, septal are mostly supplied by the LAD, inferior RCA, but here it can vary. So can you assess the ejection fraction here, eyeball? Can you use the EPSS here? Put a M1. I think it's markedly increased. I said mitral valve is not come, I think. Yeah, to take the cut at the leaflet. Yeah. Yeah, grossly you can say it is markedly reduced inner side of the septum. Septal, LV side of the septum to the E point. Yeah. It's around, 19, severe.
More than 7 millimeter is abnormal.
Yes. Then, can you see something in the mitral annular level? You are seeing something? What is that?
So it looks like calcification, but it is.
Yeah, here also.
We repair with annuloplasty.
Yeah, this is the annuloplasty ring you can see in the horizontal plane. Yeah. Is there an MR now? Yeah. So recurrence is more in ischemic MR, whether you repair it, replace it.
TR is also.
RU dysfunction also? Measure on TAPSE also, I think. Annulus. You can get a better one. Yeah, RV focus view. We'll measure the RV function with the TAPSE. Don't come here, huh? You have to balance it. Same line we have to follow. Yeah, here maybe the same line you can put there. Yeah, you have it, okay. No, it's not measuring there. Yeah, it will take. Not you. Oh, your machine, this is different. Here, okay, EPSS. It is different. Distance will don't come.
Distance.
Dimension. Okay, how much it came? 15.
15 millimeter.
So it's mildly reduced, I believe. Okay. PA pressure, you want to assess? There is significant tricuspid regurgitation, RV dysfunction. Yeah. Madam will mark. It's 45. Oh, you can see the IVC again dilated, non-collapsing, reduced collapse. Yes, it's at least 15. You can add, I suppose. Yeah, it becomes 60 something, 45. Okay. EF, eyeball assessment EF is around 30. 30%. Yeah, 30%. Here you cannot use MAPSE because there is
Mitoannuloplasty.
annular ring is there, so you cannot assess the MAPSE. You should know the limitations where you cannot use. Anything to suggest a B hump, you see? B bump, B. Put a mode on the mitral leaflets. It's not there.
Is there a supramitral ring? I came just now.
No, he has undergone mitral annuloplasty.
Okay. No, I saw something.
Yes.
I didn't know what the case was. I just came.
Yeah.
So
Supramitral
mitral
ring comes in that.
annuloplasty has been done.
Yes.
Because if there was a prosthetic valve, we would have seen.
Yeah.
Here the valve is normal, but above the valve there is something.
Yeah, this is
So that could be annuloplasty, or even
Annuloplasty.
supramitral ring looks like just like this.
Yes.
And we have to see what is the gradient across that,
In elderly, it can be post-annular
Sorry,
calcification
Prabha, I came
also.
just now, so I didn't
No
know what the
problem.
case was.
No, these are the three differential diagnoses. One is post-annular calcification, supramitral ring, or a mitral annuloplasty ring. When you see these horizontal things.
Any other question?
MR is there.
MR is there, ma'am. He already underwent mitral repair, but still MR is there.
What I'm saying is sometimes annuloplasty that is done may cause stenosis.
Yeah, it is known. We have seen that. Yes. That's what one of the cause I mentioned also. Even in tricuspid annuloplasty, they can develop some obstruction. Finished? Next program.
In 2015 he underwent CABG, but we don't know it was ischemic or secondary, but it must be secondary because he underwent aneurysmectomy also. He had LV aneurysm also, so LAD. So it must be MR secondary to LV dilatation. I hope you all are enjoying these lectures because these are the basics, and still I see there is a lot of confusion in this. So next we are going to discuss the role of echo in patients with emergency and in ICU. Emergency echo refers to use of echo in the assessment of patients who are unstable, and it should be distinguished from routine echo. The advantages of echo in emergency that it is cheap, portable, widely available, and it is non-invasive, no contrast, no radiation. There should be rational use of echo. The point of care echo in the management of critically ill patients. It provides rapid assessment of cardiac function and physiology. It complements the data which is available from other non-invasive tests, and both a diagnostic and monitoring tool for rapid bedside assessment of cardiovascular pathology in critically ill patients, as we were discussing right now. So what are the challenges? The key decision should be made quickly. It is a stressful condition, and it is often accompanied by difficulties in obtaining the optimal images. And the physician in charge, they are frequently forced to interpret the suboptimal studies. There is limited time for consultation with other colleagues also. So we should adopt this ABCD approach. That awareness, be suspicious, comprehensiveness, and double R. Awareness means we have to fight against the routine, think beyond apparent explanations, be suspicious about the referral diagnosis. It may be misleading. A lot of time it happens that we go with the initial diagnosis. So we should be open-minded and we should never trust. We have to confirm the diagnosis. Do as complete examination as suitable and careful interpretation. The study should be recorded and reviewed, and the teamwork is crucial. The clinical indications for echo in emergency, they are like hemodynamic instability, hypoxia of unclear etiology, suspected tamponade, pulseless electrical activity, tamponade, acute massive internal hemorrhage, massive pulmonary embolism, tension pneumothorax, aortic dissection, acute coronary syndrome, acute valvular pathology like prosthetic valve malfunction, infectoendocarditis, massive pulmonary embolism, acute embolic event, critically in patients due to non-cardiac illness like cardiac function and left ventricle filling may be crucial to guide the fluid resuscitation in these patients, like in septic shock and diabetic ketoacidosis.
And along with this, post-MI rupture of the ventricular septum and also the free wall, that also can be real emergency.
So in emergency room or in CCU or in cath lab, we have to evaluate the regional and global LV function in patients with acute MI. We have to detect and document the presence of hemodynamic significance of new pericardial effusion after PCI or after EP procedure or after pacemaker or device implantation. We have to see post-op cardiac surgery defect early complications. We have to detect the early complications like vessel, bypass graft occlusion, early prosthetic valve dysfunction or endocarditis, paracardiac bleeding, cardiac compression by the hematoma, cardiac tamponade. After effective PCI for detection of new asynergy indicating periprocedural infarction, to detect the complications after acute MI, to detect the vegetation, abscess formation in suspected endocarditis, pericardiocentesis, and the pleural drainage guided by echocardiography, and detection and documentation of acute severe complications like perforation of coronaries, myocardium and consecutive pericardial hemorrhage and tamponade. The algorithm should be unstable patient with shock or with pulmonary edema. We have to do quick targeted echo with minimum views required are like subcostal and apical view. These are the minimum views which are required. We have to see whether if there is moderate pericardial effusion, compressed RARV or collapsed IVC, then we have to assume there is presence of tamponade. If there is severely enlarged and akinetic RV, we have to assume pulmonary embolism. If severely hypokinetic LV, we have to assume the pump failure with post-MI or myocarditis. With small cavity and hyperdynamic circulation with collapsed vena cavas, we have to assume severe hypovolemia with major internal bleeding or sepsis. We have got various protocols with on the basis of symptoms. Rush protocol, FATE and field protocol are there. In acute chest pain, it is recommended, and with emergency echo, the field protocol, it is the focused echo, evaluation in life support, and FATE is focused assessed transthoracic echo. The goals are to acquire standard transthoracic view in ACLS compliant manner, and to recognize major cause of arrest and shock, recognize whether referral for second opinion. The FATE interpretation, you have to look for obvious pathology, mass, vegetation, intrathoracic foreign bodies. We have to assess the morphology and dimension. We have to assess the myocardial function, assess walls, image pleura on both sides, and relate the information on the clinical context. So they have seen that FATE protocol provided usable images which contributed positively in evaluation of 97% of patients. In more than 37% of these bedside echo, they revealed new information. In more than 24% of patients, this imaging was decisive in evaluation of the disease. The rush protocol, we have three-step algorithm. We have to see the pump, the tank, and the pipes. Pump means LV contractility, LV strain, and pericardial fluid. The tank means IVC, and pipes means the aorta and veins. So the rush protocol, we have to see the pump, whether the pump is hypercontractile or small heart size. It shows hypovolemic shock. The tank will be flat, IVC, IJV will be flat, and peritoneal fluid will not be there. In pipes, aortic aneurysm may be there. Then cardiogenic shock, the pump will be hypocontractile heart with dilated heart size, and In obstructive shock, the pump will be may have pericardial effusion or RV strain or hypercontractile heart. In distributive shock, there will be hypercontractile heart with early sepsis and hypocontractile when the myocarditis is already set in. Then it may be having late sepsis may involve myocardium also, leading to hypocontractile heart. Then tank, in hypovolemic shock, flat IVC. In cardiogenic shock, IVC will be distended. In lung, you can see lung rocket, pleural effusion. In obstructive shock, there will be again distended IVC, absent lung sliding in pneumothorax. And in distributive shock, IVC will be normal or small, and pleural effusion may be there or peritoneal effusion may be there. Then the high map protocol like heart, IVC, Morrison's pouch, aorta and vein, and pleura to rule out the pneumothorax. We have to screen all these things for the FATE protocol. In hypovolemic shock, like absolute hypovolemic shock, there may be hemorrhage, dehydration, GI or renal loss, or relative or distributive shock, sepsis secondary to adrenal insufficiency, neurogenic shock, vasoplegic states, or in cardiogenic shock, there will be systolic dysfunction. It may be a regional or global LV dysfunction. In obstructive shock, it may be secondary to HOCM with SAM or massive pleural effusion, ascites, tamponade, tension pneumothorax, or pulmonary embolism. In hypovolemic shock, there may be septic parameters may be abnormal, and in hypovolemic shock, IVC will be distended with delta VTI, delta Vmax, passive leg raising, and kissing papillary sign. I will explain all these things. So, what is IVC distensibility index? It is IVC max minus IVC minimum divided by IVC mean. If this variation is more than 12%, these patients are volume responders. In hypovolemic shock, this delta Vmax and delta VTI we have to measure. This delta Vmax means Vmax minus V minimum divided by V mean. If it is more than 12%, again they are volume responder. And VTI max minus VTI mean divided by VTI mean, if it is more than 20%, then again they are volume responsive. So these are all typical features in hypovolemic shock. Kissing papillary sign means again the cavity is empty, so because of that the papillary muscles are coming together, and during systole we can see the kissing papillary sign. In obstructive shock, it may be secondary to pneumothorax, pleural pericardial effusion, pulmonary embolism, intra-abdominal hypertension, or massive pleural effusion or HOCM with SAM. So we have to see the pump. The first step in evaluation of the patient in shock is to see whether the pump is normal or not. The clinical caring for the patient in shock should begin with a goal-directed echo looking to the pericardial effusion, LV contractility, and RV dilatation. Patient may have pericardial tamponade, and there may be accumulation of fluid in the pericardium. The neck veins will be engorged with muffled heart sound and shock. The small effusion may be seen as a thin stripe inside the pericardial space. The larger effusion tend to wrap the circumference around the heart, and the fresh fluid of blood tends to have dark or anechoic appearance, whereas the clotted blood, it look like a lighter, more echogenic appearance. So as madam has already told that if fluid is only in front of the RV, it is a pericardial fat. If it is behind LV also, then only we can label it as a fluid. So to diagnose the tamponade, there should be pericardial effusion with early diastolic collapse of the RV free wall with late diastolic compression or collapse of the right atrium, and the heart swings in the pericardium in its sac, respiratory variation of mitral and tricuspid flow, and IVC will be dilated. These are the few images with pericardial effusion. So mitral inflow velocity in pericardial effusion, particularly when progressing to tamponade, it causes increase in exaggerated respiratory variation in the mitral and tricuspid inflow velocity. And this increased interpericardial pressure causes restricted cardiac volume, enhancing the influence of intrathoracic pressure, which leads to changes on the ventricular filling. In mitral side, if it is more than 25% variation in the respiratory variation, that is significant and it is diagnostic of tamponade, and tricuspid side more than 40% variation is significant. Then contractility, the pump, as we have already seen. In cardiogenic shock, the contractility will be decreased. Usually we do eyeballing method, but standard is with Simpson's biplane method we should do. The additional findings in cardiogenic shock, IVC will be plethoric and there will be B lines in lung echo. The mode can be used to graphically depict the movement of the LV with the cardiac cycle, placing the cursor across. So this is EPSS, as I was already told. EPS more than 7 millimeter is abnormal. RV size, we have to see RV size. Normally the LV to RV size is 1:0.6. If it is more than 0.6, then it is abnormal. So normally RV is less than 2/3 of the LV size. D-shaped RV means there is a pressure overload on the RV and it is suppressing the intervertebral septum towards the left side, and it is typical of pulmonary embolism. In pulmonary embolism, again RV will be dilated with presence of abnormal right ventricular wall motion with McConnell sign, systolic flattening of the interventricular septum, tricuspid regurgitation, increased PA pressure, IVC will be congested, dilated pulmonary artery, and there may be right-sided thrombus can be seen. In acute massive pulmonary embolism, McConnell sign will be present with RV divided by LV and diastolic diameter will be more than 0.5. 60-60 sign, that is pulmonary acceleration time below 60 millimeters, that is rapid acceleration with the presence of TR jet velocity between 30 to 60. It carries a low sensitivity but very high specificity for diagnosis of pulmonary embolism. In acute pulmonary embolism, we will see the dilatation of RA-RV with McConnell signs. Sometimes thrombus may be seen in the right side cavity. TAPSE, Madam already told. Then tank, the fullness of tank, that is inferior vena cava and internal jugular vein. Looking at both of the relative vessel size and its respiratory dynamics, the IVC provides the indication for intravascular volume, and it is commonly used in place of central venous pressure as a non-invasive marker. We can see whether IVC is discernible or not. Then we can come to tank overload. Finally, lung ultrasound can be done to identify pulmonary edema. That is tank overload sign or tank leakiness sign. To assess for pulmonary edema with ultrasound, the lungs are scanned with a low frequency, means that is convex probe, to examine the lungs for lateral orientation, or from a more posterior approach, increase the sensitivity for this technique. From second to fourth intercostal space, we have to screen the lungs. We can see the B lines or lung rocket in these. These B lines appear as a series of diffuse, brightly echogenic lines originating from the pleural line and projecting posteriorly in a frank manner. So this comet tail appearance or artifact or vertical hyperechoic line may be seen to extend posteriorly from the opposed pleura. This shows the presence of lung sliding with comet tail sign, excludes the pneumothorax. In contrast of a pneumothorax, it results in an air collection between the layers of parietal and visceral pleura. These pleural lines will consist only of the parietal layer. So in this normal image will depict like wave of the breech and it closer to the probe, and the stationary anterior chest wall demonstrates a linear pattern, while posterior to the pleural line the presence of lung motion demonstrates a irregular granular pattern. In pneumothorax, the M-mode Doppler ultrasound will only show repeating horizontal line indicating the lack of lung sliding, in a finding known as the barcode or state of fear sign. Means in M-mode ultrasound there will be no barcode sign. Pleural effusion we can easily make out in lung ultrasound. Again, with presence of pneumothorax in M mode, there will be no motion in the chest wall and no motion in the lung. Then the pipes, in rush protocol, the pipes means we have to look at the arteries of the circulatory system. Secondly, at the venous side, the vascular catastrophe such as ruptured abdominal aorta or aortic dissection, they are life-threatening cause of hypotension. So we have to rule out these also. We have to screen whether abdominal aorta is dilated or not, or whether in suprasternal notch view, as madam has already told, we can make out any aortic dissection. So aortic root may be dilated, or we can sometimes find the flap in the aortic root. In hypovolemic shock patients, so we have to see all these things. From suprasternal notch view, we have to rule out the dissection. From cardiac view, we have to see contractility, vena cava. Then femorals and popliteal also, we have to screen whether there is any DVT or not to rule out the presence of DVT. In pulseless electrical activity, we have to see a quick look, and in pulse check, change the management based on positive findings, pericardial tamponade, pericardiocentesis. If there is hypodermic cardiac wall, then we have to volume resuscitate. If there is RV dilatation, we have to suspect pulmonary embolism, then we have to treat accordingly. If there is profound hypokinesis, we have to start inotropes and treat accordingly. If there is asystole, then follow the ACLS protocol. So in pulseless electrical activity, the false positive cardiac motion may be there with the transthoracic pacemaker or positive pressure ventilation. So in chest trauma, rupture of cardiac structure, myocardial contusion, pericardial effusion, aortic rupture, or the intimal tear or rupture of coronary sinus of Valsalva can be seen. In acute coronary syndrome, we can see whether there is any RWMA, global LV contractility, papillary muscle dysfunction, ventricular septal rupture, free wall rupture, as madam was discussing right now. Other like LV aneurysm, mural thrombus, hypovolemic or ischemic MR. This is the ventricular septal rupture, free wall rupture. So to conclude, the key role of echo in emergency are to assess the cause of the shock, cardiac arrest management, acute chest pain evaluation, detection of structural emergencies, and to guide the interventions. With this, thank you.
Any question to Dr. Pushparaj? Pericardial effusion.
And how many percentage of pulmonary embolism we get the classical picture of S1 Q3 T3 pattern? How many percentage?
The typical S1 Q3 T3 is not only typical, only in 30% of patients we get S1 Q3 T3. Other findings also are there, like atrial fibrillation. In some patients we can have new onset atrial fibrillation, sinus tachycardia, tall P wave, RBB. So there are it is not the only ECG finding which we can get in acute pulmonary embolism.
What is the significance of the or blood markers, cardiac markers?
Significance of
cardiac markers significant
in pulmonary embolism. So cardiac markers markers D-dimer, anti-proBNP, troponin, D or CPKMB. D-dimer will be raised in any patient who is having thrombus. Post-surgery patient may have raised D-dimer, but he will not have, he may not have pulmonary embolism. Then troponin and CPKMB may be raised if there is significant pulmonary embolism leading to myocardial ischemia secondary to workload. So troponin and CPKMB may also be raised. Anti-proBNP will not be raised only if there is only presence of pulmonary embolism. Till the late heart failure sets in, anti-proBNP will not be raised. If D-dimer is normal, then pulmonary embolism is unlikely.
Sir, just one point to add, any moderate or massive pulmonary embolism should have RV strain precordially. Any clinical significant pulmonary embolism should have RV strain. And that is one of the markers which can tell you that patient, this pulmonary embolism can kill patient or not, apart from other signs.
Yeah. Good afternoon. Dr. Pushparaj has in detail explained to you all the emergencies. I'll show you the cases and how to manage practically. You know, this is a 5-year-old child who had 1.5 months treated as a bronchopneumonia. How people can go wrong without the echocardiography I'm showing, and then treated with the IV fluids. And then the patient deteriorated in congestive cardiac failure, and then he was referred to our hospital. So when I did the emergency echo in the parasternal long axis view, you can see that there is a VST, very small VST, very innocuous, but that cannot explain the congestive heart failure. So there were multiple vegetation trying to close the VST. That is what surprised me. Look at that. See, it is such a huge, like grape bunch like VST, and that was trying to close the VST, and this bacterial endocarditis had caused the congestive cardiac failure. And so what happened was, look at that, and that was causing the TSTR. So JVP was raised, patient had a bilateral edema because of the huge vegetation, and this huge vegetation was because of the contaminated IV fluids. Like in the drug addicts, they get the right-sided vegetation. In the same way, because of the IV fluids, the child had developed this. And then, apart from that, what happened was, there is a pericardial effusion. So all the time he spoke about the pericardial effusion. What I am showing is the pyopericardium. The pyopericardium is, along with the vegetation, multiple vegetation, there is a pus around. So here it is important is, even if you take the blood sample for culture, it may come negative. But when you tap the pus from the pericardium, it will come positive. And that's how we did the tap the pericardium. And you can see that even in the IVC, the vegetations are there. This is how the vegetations, right from the IV fluids which is going into the heart, they're the vegetation. So this is a multiple vegetation with the pyopericardium with fibrosis, and this is the large vegetation on the tricuspid valve. And this is extremely rare incidence because 5 to 10% mostly found with the IV drug abusers and artificial implants and pacing leads. Otherwise, such a small child with the VST developing this complication is unheard of. And what they were treating as pneumonia was nothing but the vegetation embolizing into the lung causing the symptoms. So they were treating it as a pneumonia, which is actually like it would have formed like a lung abscess if we had not treated in time. So this is another case, 9-year-old child, known case of VST, and now the total count is 30,000. Once the total count is 30,000, that means there is some infection. So what sort of infection? CRP is positive, that is, it is a non-specific. Any infection, it will be raised. And what is important is 3+ RBCs were present in the urine. So that gives a clue that no blood, growth in the blood sample, but that gives a clue that there is some infection. Can you tell what is there? Where is the heart? Anybody? Not able to see the heart. And it is covered by the thick pus. That is nothing but the thick pus. And in the past, they used to send to the surgeon to drain it, but today, no more. You can see that with the negative needle pressure, I have put inside, and then when I got 1/4 cc of fluid, put the guide wire and put the sheath, confirm that I am in the pericardium, and then started giving 10,000 units of streptokinase inside the pericardium, and that started resolving, and the first 400 ml, next day again. So daily lavage was done with the streptokinase as well as the streptomycin, and ultimately when we started seeing the heart, you can see that the pulmonary valve is perforated. The vegetation has eaten up and there is a perforation, and the PR will be in the center. This is in the periphery. So this is how there was a regurgitation. So this is before treatment and this is after treatment. So you know, culture positive, treat the antibiotic, higher antibiotic, drain the pus, put the streptokinase. In fact, the streptokinase was first tried in the pleural effusion, and then for MI, and now we are using for the pericardial effusion with the thrombosis. And all these fibrin bands can be broken and we can literally get back. There is a small VST and then the pericardial effusion is drained completely. This is another case, something is moving, it's a vegetation. So this vegetation, it was not my patient, and there was a pericardial effusion and the child was very sick, and this vegetation embolized and the patient died. Then I thought this should not happen with any child. So I went back and reviewed the echo. This is not attached to the tricuspid valve. It is not attached to the intra-atrial septum. It is attached somewhere between here. And that happens with the Garbude shunt. The LV to RA VST, and there the vegetation is attached. So then I started closing the Garbude defects with the ADO2 VSTs, and I was the first one to close the Garbude's congenital with the device and presented and published the series. And this is another 7-year-old child presented with the history of fall. And then the child was treated by the orthopedic surgeon, and the child deteriorated, and then they referred, and you can see that there is a huge vegetation on the tricuspid, on the aortic valve, and there is a mobile vegetation in the LVOT, and any time it would embolize. So it embolized and had the gangrene of the 2 fingers, and then this is what the pericardial effusion. Can you see that? There is something like speckled appearance, that is the pus churning. When the heart is beating, the pus is churning. So this is how you can see, and then this was again tapped and culture was done. You can see here now. All this churning is the pericardial, pyopericardium, the pus around that. So the infective endocarditis usually occurs in the damaged valves, but here, if it occurs on the normal valve, and that is invariably, it is due to the Staphylococcus aureus, and mainly it is a methicillin sensitive drug. So then we go to the 13-year-old girl with non-Hodgkin's lymphoma. I think I'll skip this, it will be too much. These are all thrombi and pericardial effusion, pleural effusion. Today somebody was asking about, oh God, it's not moving. The thrombus versus the myxoma. This is how the myxoma occurs. Can you see the speckled appearance? It is heterogeneous. The thrombus is uniform. And this is the myxoma. Sorry, it is not moving. And here it is moving. You can see that the hemolytic part is inside, like the translucent areas, and then it is the myxoma. The stalk is attached to the intra-atrial septum. It is going to the mitral valve and coming back. And that's how the patient had the tumor plop. And that lady, she wanted her husband to come from Andaman and then only get operated. But he was supposed to come on Monday. On Sunday, it embolized. And this is the peripartum cardiomyopathy. Nowadays, it has come down with the improvement in the nutrition. You can see that there is a large thrombus in the LA. And as we progressed, she had multiple convulsions, and then she was sent to us because of the convulsions. And the convulsions were because of the multiple embolism occurring to the brain. From the LV and the multiple microembolism of the thrombi was going. Now you can see that there is a LV thrombus also. LV and the LA thrombus. Now what is this? Can anyone tell? Just because there is a pericardial effusion, don't put the needle in every patient until you suspect what it is. This is the hydrated cyst. Multiple hydrated cysts are there. And if you put the needle and anaphylactic reaction, and you lose the patient. So this is the importance of emergency echo and decision making. So this is the multiple hydrated cyst, and when it was operated very carefully, 250 daughter cysts were drained from the pericardium. And this is how it is there. Now this is the 40-year-old man, again hydrated cyst, but this was in the pericardium and it was there. And this patient, you can see that what Prabha told, the traffic jam, there is a, you can see that the sec is there. And what is happening is IVC, RA, RV are collapsed because of the extra cardiac mass. That is the lung mass pressing on that, causing the RA obstruction as well as the RV obstruction and also the IVC obstruction. So this is, that something is fallen on that, and surely the heart is struggling. Now what is this? Okay. भैया क्या हो गया है? Oh, कुछ नहीं. Some cancel is coming, no? It's not moving. That means I have to stop. ये क्या है? I put cancel, ये नहीं हो रहा. Okay. And now, this was a child, I think, from UP, and you see that there is a non-compaction, and there is a pericardial effusion all around, and what is important is the doming is there, severe aortic stenosis is there. And the failure was because of two things. One is the LV non-compaction, and the second one is aortic stenosis, double insult. So I did the balloon dilatation. On the table itself, the child said, "Ab to मैं बेहतर हूँ, अच्छा हो गया." You know, this is how you make the correct diagnosis and do the treatment, and the patients are very happy. Where is the heart? He was telling tamponade, no? This is the tamponade. The whole fluid is so much, the heart is coming and going, the swinging heart. So after we tapped about 400 amount of fluid, the pus, this is how we can started seeing the heart. And what is happening? The RV is collapsing and RA wall is collapsing. So that means it is a tamponade. This is despite tapping the fluid. So that means it is such a massive fluid. And all this is pus because you can see the speckle, and that is all the flakes. And here you can see that the heart comes and goes because of the swinging heart. See, it is moving like this, and that swinging heart is because of the massive pericardial effusion. And this is how the swinging heart is seen, RA, RV collapsing, and very nicely seen here. And what is the diagnosis? Once I presented this in the Indian Academy of Echocardiography, Dr. J.C. Mohan said, "Vijay, thoda अच्छा echo दिखाओ, कुछ नहीं दिख रहा है." Sir, ऐसे मुझे भी नहीं दिख रहा है. And this is what happens when the pyopericardium is there. You don't see anything. The thick pus is covering, and you don't see any chambers at all. So this is a masterpiece. Now we don't see such cases. This is 30 years old. The LV collapse is occurring. Tamponade, we say whenever the RA, RV collapse is there. But here RA, RV are hugely dilated, and the LV is so small, and then the pericardial effusion and LV collapse is occurring. This can occur only in the Eisenmenger's complex. And when I started pediatric cardiology, almost 12.8% of them, they used to have the Eisenmenger's or pulmonary hypertension. And I went on telling people to detect in time and send, so that we started putting the devices and didn't allow the children to go for the Eisenmenger's. You know, the beautiful film actress Madhubala, she died of Eisenmenger's and hemoptysis. And that should not happen as on today, because we have such beautiful echocardiography, and then the surgeons can do, or if they are small, we can close them. And this is how the LV collapse occurs when there is a suprasystemic RV pressure. When the suprasystemic RV pressure is there, RV, RA do not collapse. It is the LV collapses because hardly there is any flow into that. So thank you very much for your kind and patient hearing. And this is Richard Van Pra. His wife is Stella Van Pra. And this is Bob Anderson, and that is his wife. And I have already shown this is Feigenbaum and Naveen C. Nanda. These are stalwarts. And you know, though they are at the loggerheads, they are great people. Whenever pediatric cardiologists, they read Vanpra, Vanpra. Vanpra, Vanpra, 2 times it comes because Stella Vanpra is his wife and Richard is the husband. So both work together, and that's a Vanpra, Vanpra. And thank you very much for your kind and the patient hearing. Thank you.
There is one interesting case of HOCM. I request 5 volunteers can come over here. Madam is going to demonstrate. This is a 29-year-old male with generalized weakness and complaining of palpitation on and off. His blood pressure is 120/70. Pulse rate 75 and weight 50 kg. BMI is 20.
Yeah, somebody can comment? No, I thought the no, I wanted these volunteers to comment.
Septal hypertrophy. Septal hypertrophy, ma'am.
Yeah, Prachi, where are you?
Even the posterior wall is appearing thickened.
Thickened, both posterior wall and the septa.
Yeah, it
Prachi
appears
is
to be
not there?
The cavity is compromised.
concentric. Huh? Yeah, you can see some speckled appearance, no, echogenic.
Yeah, the speckled appearance morning I showed, no? The interventricular septum has got a speckled appearance. And that is the classical of hypertrophic cardiomyopathy. Once you get the speckled appearance, you have to measure the interventricular septum and then the posterior wall and see whether it is 1.5 times the posterior wall. That's the first
Can
thing
you
that
just
you
measure?
have to do.
Put a
Yeah,
M mode?
freeze, and either you can measure like this only, or you can take an M mode and then measure it. I think next is the quiz, you know. Those who want to win the quiz prize don't have to sleep or have to take a nap and become fresh again.
IVS thickness is how much? Where it is coming?
20
centimeters.
2
20
centimeter. Even the posterior wall you measure? Posterior wall, okay, from there.
Yeah,
yes.
below that, because you are including the papillary
Cardiac.
muscle. Yeah. It is
Okay.
1.8.
More or less same.
No,
there
no,
is.
you have included the papillary muscle.
Okay. So you're supposed to measure just below the mitral valve.
Yeah, just below the mitral valve. Put the cursor there and
yeah.
take the measurement.
Yeah.
Yeah,
What do you get?
freeze.
It's coming like windows. Now you can see posterior wall is not that thick here.
Yeah, now you take the posterior wall in the middle somewhere here. It's around 12 millimeters or so. Anyway, it's okay.
Okay.
Because we have quiz, let us finish fast. Okay, then go to the short axis.
What else you will see in M mode?
We want to see the SAM. Show us
Ah,
the SAM.
You see the
SAM, madam.
Yeah, you
That
put,
is the SAM.
put your cursor on the AML, mitral leaflet now. No, take off. Yeah, EPSS illa. You put.
Show the SAM and gradient.
Yeah.
And once you have the gradient, the dynamic obstruction, for that you have to
No,
do the
this is
hand
the
grip or
diastole.
something and then
Systole you should
record
get
the
here.
gradient again.
This is the diastole. You should get in the systole, anterior motion of the mitral leaflet. We are not getting so much. Just see once more, you put at the tip of the leaflets, just at the tip. Yeah. Tip you have put there. Is it moving? Some movement is there, but it is not touching the. Actually, there is a grading, Gilbert's grading. If the SAM septal distance is more than 10 millimeter, it's grade 1. Less than 10, grade 2.
It is not much, and in
Yeah.
fact, you know, when you put the color, the obstruction
Yeah,
is
we'll
also
see
not much.
yeah, now you can see it is more or less touching. Okay, put the color. You can see the turbulence if there is obstruction.
Not much.
Yeah, you remove the amode, only put the color. There is some turbulence though. No, I think color gain is increased. Put color now.
Yeah, there is obstruction.
Yeah.
There is turbulence in the LVOT. And you can go to the apical 5-chamber view and measure the gradient across the LVOT.
You should be careful, MR can adulterate it. MR set. No, it's gone. That was MR, it was more than 6 meters. This is the dagger you can see there, it's coming there. Just, see there, that is the dagger shape. Yes, yeah. Little up, you are keeping this too low. Actually, that is called. Yeah, no, just still go. There will be. See there, yeah. This is the typical dagger. Yeah, freeze. Here also it's going below.
Dagger shaped, yes.
Go back.
See the dagger.
Move it. The previous one was better, the dagger shape and. Okay.
Why you get dagger shape?
You take the second one. Second or the fourth one. There is
It's actually
significant
going.
gradient.
Yeah.
See, the emergent thing will be, contour will be different. That
this
U
is
shape,
typical dagger.
Where this is the dagger shaped.
Okay. Yeah. Anything else? Yeah. See, you make it. You put color now. We'll see the MR. Whenever there is obstruction, MR has to be there, and it is.
It's there, but not
Yeah,
much.
it's a
mild.
posterolateral jet. Yeah, this is okay.
Now you freeze.
Freeze.
You measure it.
This is the MR jet, and this is the dagger. Is the yeah.
See, the MR is also there and this dagger is also there. You
Actually,
measure only the dagger, not
it is
the MR.
pushing my.
MR jet will come first always.
Yes.
Followed by the HOCM jet.
Yeah, this is the dagger. If.
And it will be full, ma'am.
Yeah, MR will be, yes, it comes start earlier. Yeah.
Pushparaj is going to conduct the quiz.
Not Dr. Pushparaj.
No, this is Dr. K.L. Uma Maheshwar.
You can start, I think.
Okay. Yeah, come.
Okay. Yeah, there is severe LVOT obstruction.
Thank you so much. We now move on to an interactive quiz session designed to make learning engaging and enjoyable. It is my privilege to invite Dr. K.L. Uma Maheshwar sir to conduct this session. Known for his vast knowledge and engaging teaching style, this quiz promises to be both informative and exciting.
So, thanks everyone, and I've been, it's open for all. Yeah. So, I've been asked to assess the sleepiness index of the hall. So, that's why I prepared this quiz here itself when Vijay Lakshmi madam and this is fine, I think.
Dr. K.L. Uma Maheshwar, he is cardiologist in the city, and I hope everybody must be knowing he is more into pediatric cardiology, and he brought 2-3 cases of pediatric cardiology. He is going to conduct this quiz, and I want active participation of all the delegates over here. Once you want to answer, just raise your hand, we'll give the mic to you. And we want little faster answers because we have to summarize our sessions little faster. After that, one more talk is there. So please be little active. If you want to get awakened, then tell
raise
us.
the hand
We,
early,
we have nice gifts for all of you. Just raise your hand and get it. Grab the gifts.
Yeah, if you don't raise, Prabha will raise the hand.
And Dr. Pushpraj sir has announced an eco machine free of cost for the winners. So I've been watching all the session from the morning. So whether you people are sleeping or not, I'll just see from first 3 slides, because it has been very easy, and just to see whether how you are doing all the day. Please, this image is taken at which phase of the cardiac cycle?
Yeah, somebody. No course answers. Huh? You have to ask.
And diastole.
Mid-systole.
Mid-systole.
And diastole, sir.
So there are multiple answers, and systole, mid-systole. I will also put a V. Oh, क्या होता है गायने का तो?
So mid-systole, yes. So this is mid-systole, because
So
the
who
aortic
is
valve
the
is fully
mid-systole?
opened and mitral valve is fully closed. We'll take the answers later on, please.
Who answered mid-systole?
Yes, sir. Yeah, you'll
Your name?
If you answer more than 5, definitely you'll get the eco
More
machine.
than 5. Sir has different criteria. Okay.
Yes. Ostium second now. Yes, definitely. Fine.
VSD, sir.
Everybody is listening to you,
Prize
ma'am,
has to
from
be
the
given to all.
Everybody was
Now
listening to
we
you.
distribute all the prizes to everyone.
Just be active and please raise your hands.
See, they're all inspired. All of them answered.
VSD. Yes.
AVSD.
Yes. So whole of the septum.
AV canal defect.
Yeah. AV canal defect, because there is an ostium primum plus ostium secundum and a VSD also. So ma'am, I think you have been fantastic lecturers. They were able to detect every kind of ASDs, VSDs and all the things, structural heart disease. Yes. Subaortic membrane.
A.
Bicuspid aortic.
I think Pushpraj has to arrange for more prizes now. That is not enough, I thought how many prizes? Now that appears very less. Something is ballooning in the apex. What is it?
Dilated cardiomyopathy.
What aneurysm is that? Apical?
Apical aneurysm.
So where do you get apical aneurysm? Now, how do you distinguish aneurysm from the diverticulum? Aneurysm will have wide neck, and then only pericardium will be there, and all the 3 layers of endocardium, myocardium will not be there. Whereas diverticulum will have all, and the neck will be very wide, and that is congenital, more at the base. So this appears like the thinning and the apical aneurysm, and that happens when there is a antro-1 MI with the aneurysm. Okay.
So you can appreciate the thickness of the septum and the posterior wall. There is a difference. So this is HOCM with apical aneurysm.
Or it could be hypertensive patient with the aneurysm, because they are more prone for the MI. HOCM getting MI is rare. Whereas hypertension with MI is common.
No, you will not answer. I will not give you a machine to you. Any other person.
Otherwise, wife will get all the prizes.
Less than 17, yes. Endopneumatic mitral valve stenosis. Aneurysm or dissection?
Aneurysm. Aneurysm.
Aneurysm. How? Dilatation of the aortic root.
And if it is more than 4.5 centimeters, it's emergency. We have to do the Bentall.
Dissection. It is aortic dissection.
Not supravalvular something? Coronary artery?
Dissection.
Yes,
Aortic
aortic dissection only. Because you have a flap here and a false lumen also.
Who is giving the prizes? They're not giving prizes.
Ma'am, everybody is answering, so we'll distribute to all.
All. Okay, that's better. Including me?
Yes, ma'am.
Severe MS.
Severe MS, yes. So what is this? And you have to explain the finding also. Whoever is answering should know. No, ma'am. This. Anyone else? Are you able to, sorry. Are you able to appreciate inspiration dip and expiration? There is a difference of septal movement.
Yes.
Where you get the septal bounce? Septal is bouncing in during inspiration and expiration. So you will get in, this is septal bounce. What is this grading?
Diastolic. Grading of
Diastolic.
severity of diastolic.
Why so? Bi and lateral, yes.
Severe PH.
Why? What
D-
is this
D-
called?
D-
D-shaped
D-
septum.
section.
D-shaped septum. Please don't say heart is common in all.
Pericardial effusions.
Yes.
Myxoma.
No. You see, there are 4 options.
Is it a soccer ball or a cricket ball or a tennis ball or
There are
softball?
4 options. Both are LA myxoma, both are
No, I gave
LA
all the 4
thrombus.
options. Which one?
Both are LA myxoma?
Yeah.
Atrial myxoma.
LNLA.
Atrial myxoma.
Football. They answered right.
No. I have written only A and B. So A is myxoma, B is thrombus, or A is thrombus, B is myxoma, or both are LA thrombus.
A is myxoma, B is thrombus. Yes.
So we are not seeing the interlateral attachment anywhere. What else is the clue?
Sir,
What is the clue?
myxoma is attached with the atrial septum.
At least two differentiation you should tell. One madam has already told.
Attached to the septum.
Septum attachment is very difficult to see specifically in 2D. The pedunculated we are not seeing, definitely. Yes, this is not pedunculated, but in 2D echo, most of the time this pedunculation has not been seen, or attachment is not seen. Any other thing, very, very obvious. What about this valve? This is mitral stenosis. Are you expecting thrombus or myxoma in mitral stenosis? So mostly thrombus. So this is also one clue. This mitral leaflets are all opening very well. Most probably this should not be a thrombus then. This. So this one. A is myxoma, B is thrombus.
C.
Thank you.
Wow, thank you so much.
winner is Quiz Master. Give a big hand. Please give a big hand to him.
I request both dignitaries just felicitate our backbone, Dr. K.L. Uma Maheshwar. Dr. Nivesh and Dr. Nimesh Gupta there. Anjane, Dr. Anjane.
I've told her if you want to say Narmada Aarti, finish your talk first.
Disconnect. Connect. Yeah.
So there is one of the last talk of the day, post-MI complications, and that is by Dr. Prabhavati ma'am.
Yeah, I hope you're all not tired. This is last talk. I'll take just 10 minutes and show some echoes in post-MI mechanical complications. What are the mechanical complications which are potentially life-threatening are free wall rupture, ventricular septal rupture, papillary muscle rupture causing severe mitral regurgitation. All these are acute, catastrophic and fatal. They can die within minutes. So other complications are chronic ischemic MR, intramyocardial hematoma, dynamic LVOT obstruction, which is less diagnosed. So free wall rupture is seen in around 0.8 to 6%, and it contributes to 10% of the mortality after acute MI. It's highly fatal. It's usually preceded by a large infarct, and the ruptures occurs at the junction of the normal and the infarct muscle. More common on the LV, it involves the anterior and lateral walls. There are three types. Type 1 is acute, usually within 24 hours of thrombolysis. Subacute, slow onset. Type 3 is late, which causes pseudoaneurysm. So type 1 is the acute form. It's called blowout, sudden cardiac arrest. You will be seeing the patient. Patient will have kind of electromechanical dissociation, severe hypotension. This is because of the severe cardiac tamponade. It's almost always fatal within minutes. You can see here, when a patient suddenly arrests, you do an echo, it will be like this. That Dr. Pushparaj said there is some movement. It is not really cardiac contraction, and you see pericardial effusion around that. So that is the type 1, sudden profound shock, pulseless electrical activity. Type 2 is subacute. There is a oozing. There is no cardiac arrest. Patient slowly develops moderate to large pericardial effusion. Hypotension may occur of varied severity. They may have some sinus bradycardia. So this is the large pericardial effusion, which occurs little slowly, not suddenly. That is why they do not develop shock. How to diagnose free wall rupture? There should be a pericardial effusion of more than 5 millimeter, layered high acoustic echoes suggestive of blood clot. You can see this. Yeah. That is suggestive of pericardial collection. Okay. So increasing size of pericardial effusion, presence of thrombus in the pericardial space, and you can make a diagnosis. Can you see that? Yeah. Okay.
You can see how beautifully the thrombus has formed. You know?
So this is a story of a 60-year-old male patient with anterior MI. He suddenly deteriorated, had cardiac arrest on the second day. You can see the anterior MI extensive. You can see a pericardial effusion. Pericardiocentesis was done, and the patient was immediately wheeled to the operation theatre. So you can see 48 hours later because of shock. So localization of rupture is difficult, maybe possible in 40% as seen here. You can see some vent here and you can see the flow across that. Yeah, this is a emergency. If time permits, they can undergo surgery. The type 3 is LV pseudoaneurysm formation. So here what happens is there is subacute tear in the LV wall which is spontaneously sealed by the thrombus and it is contained by the thrombus and the adherent pericardium. There is no which septum, it may have a serpiginous course. So you may need non-conventional imaging planes. You see this is in the apex, we have to use non-conventional views to pick up these. This is a serpiginous LV to RV communication. And peak gradient gives an idea about the pulmonary artery pressure and you can see the defect size. Sometimes you may plan for VSD device closure as madam showed.
4D echo will show very beautifully from LV side, RV side, and we can do the device closure.
And this was device closed. You can see the device here, close with the device. Then a third complication is papillary muscle rupture. More often is a posterior medial papillary muscle rupture because of the single blood supply occurs in around 1%, usually 2 to 7 days after the MI. They present with acute pulmonary edema, cardiogenic shock, poor prognosis, high mortality within hours. So on the echo you will see flail of one or both leaflets because the papillary muscle is ruptured. Now the leaflet is freely moving, showing flail, and they will have severe MR. You can see here, the anterior leaflet, you can see the papillary muscle head attached to this, and you can see severe mitral regurgitation due to papillary muscle rupture. Chronic ischemic MR, it occurs in the healing phase of MI, whereas the LV remodels, there is normal geometry of the mitral valve apparatus becomes distorted, and there is incomplete leaflet closure, as we saw in the morning. We saw this. Yeah, this is the PML. There is posterolateral MI causing severe mitral regurgitation due to incomplete closure. This is an interesting thing. Intramyocardial hematoma we rarely come across. This is caused by hemorrhagic dissection through the myocardium. Most common in the anterior wall MI in the apical region. It's often misdiagnosed as pseudoaneurysm or clot. One good thing is it spontaneously resolves. See this? You will mistake it for a clot or a rupture. The thing here is its inner myocardial layer separating the hematoma from the cavity.
Is down and above is the hematoma inside.
This is the hematoma. This is separated by the hematoma. So,
very beautiful.
So this spontaneously resolves at 20 days, and you see at the 60 days, it's almost resolved. So we don't have to do anything. LV thrombus, all of you would have seen, usually occurs at the site of akinesis, dyskinesis in the apical region, multiple mobile clots. If they are protruding or echolucent center is there, they are more prone for, like this, protruding mobile clots are more prone for embolism. You need to give anticoagulation for at least 3 months. These are fresh clots with echolucency in the center. Finally, dynamic LV outflow obstruction. This is a under-recognized complication. Patient is in shock, you keep giving inotropes. What happens? They will not come out because, I'll tell you why. Anterior wall MI, they will be in shock because they have apical hypokinesia. The basal segments are hypercontractile, okay, which causes alveolar obstruction due to systolic anterior motion of the mitral leaflet. You can see here, apex is hypokinetic, AML is moving, and there is some turbulence in the LVOT. These are taken in the ICU, so image quality is not that good. And you can see the SAM and LVOT gradient of 50 millimeter mercury. This patient was on inotrope. When inotrope was stopped, SAM decreased and LVOT gradient reduced. If you are continue to give dopamine, then the obstruction increases and patient will continue to be in the shock. So that is the last. So bedside echo can detect most of the complications of acute myocardial infarction, dynamic LVOT obstruction, VSR, RV, papillary muscle rupture, pre-wall rupture, false aneurysm, true aneurysm, everything. Thank you.